in the field of diabetology, Dr. S. Venkatraman sir, Dr. Jayashree madam, and Dr. Krishna sir. To no, just slides. Put the slides. So can I have the slides, please? Just go to the slides. Day 1. Day 2, day 2. Yes. So, this one is okay. Okay, we'll have the slides later. Thank you. Sure. No. It's not coming. It's different. This is not the slides. Some error has happened. No, it's not. Okay. So no problem, sir. Let me start.
Are we waiting? While we wait, we'll start off.
We'll start off, sir. So I'll just present the case. It's not working. It's not the different slides. Something has happened. Sure, sir. I'll just start off with the things.
Balaji, you become the expert. I'll moderate.
Sure, sir. No. I'll just start off with directly.
I'm moderate.
Done. Plus.
Okay. See, all of us are enamored of these drugs, but many of us are very, very worried about. Thank you. This is a much better GLP-1 RA than anything else. All of us are enamored of the GLP-1 RAs. But how many of the people here in the audience actually use them? One. All of you have used them. Somebody is still waiting. The important question is, how many of you are comfortable using them? How many are comfortable using a GLP-1 RA? Not everyone is. And that's the reason this workshop was started. Because whenever we go, we get these questions that comfort, when you start a new drug, and one with potential toxicities, and one that causes such dramatic reductions in weight and glucose, and the more important is one that also people say that, oh, I have the same. The first question that I'm going to ask the panelists here is it necessary for us to be overweight to start a GLP-1 RA? First question, and all of you, any of you can answer.
So the brief answer is no, because it's a very powerful anti-diabetes agent. And in fact, what I generally tell people is it started off as diabetes medicines, and because it caused a lot of weight reduction, it's now being used in obesity. Given the fact that it's got significant cardiovascular, kidney, liver, other one by one protections, not necessarily. I would be careful in initiating it in someone with a low BMI, but not to say that it is a contraindication to get started on it, if they have other indications.
So is there a BMI cutoff below which that you will not start a GLP-1 RA?
Not really. I don't use a BMI cutoff. I think for me what is more important is the extent of fitness / frailty. So for example, an elderly person, if I'm going to start, if I'm considering it because of, say, protection for the heart, protection for the kidney, someone who has a vasculopath that I want to improve the vascular thing, I would probably have a discussion about how they can maintain their muscle mass while they get onto the medicine. Anytime people lose weight, they're not losing only fat, they're losing some amount of muscle and bone. So it is, anyway, I think they need to be strength training. And I always like to say I got my 82-year-old mother strength training. So if she can, with severe osteoporosis and 2 hip fractures, sitting in a chair, she does it. If she can do it, I think all of us should be doing it. So,
by the way,
essential.
Anyone who has a question, just come line up and we will interrupt this discussion and you can ask questions, because this whole idea is we'll use the next half an hour to get everyone's things today. The second question, so...
Can I just add a point?
Yes, please.
To what I think Jayashree just now alluded to. I think in clinical medicine and therapeutics especially, when there are twin advantages, we tend to be carried away by the second aspect of the efficacy. For example, linagliptin, when it is introduced as a DP4 inhibitor, so much was harped on the renal safety, everybody thought that you should use linagliptin only when there is a renal failure. Likewise, when you have this molecule, since they have the twin advantage of a robust HbA1c reduction, the weight reduction, I think at the back of the mind, of course, nothing wrong if your priority is going to be an obese patient or an overweight patient with diabetes. But since it is a robust HbA1c reduction, number one, and number two, the weight reduction is based upon the baseline weight. So let's not be worried about the 6 to 8 or 10 kilos in the phase 3 trial or the real world experience. So all those have been in the context of...
So if you have a BMI of 23, but the patient has an established cardiovascular disease, will you start them on a GLP-1 RA?
Absolutely, especially if somebody is going to be on, probably the case in question which you are supposed to discuss had 4 molecules on board, something like that. So you have metformin, you have an SGLT2 inhibitor, an SU, and oglibose. I think that's the thing that Chidambaram had planned. Certainly, I would like to introduce, of course, the case in question was with a high BMI. Even with a BMI of 23, with a cardiovascular protection in point of view, certainly I would like to
So Balaji, I have a question. So you decide that somebody needs to start GLP-1 RA, correct? You're practicing in Kumbakonam, and immediately people assume that patients there can't afford it. But you have a lot of patients on GLP-1 RA. So how do you start this discussion with someone who requires it?
Thing is, absolutely, starting a GLP-1 receptor agonist in a periphery place like Kumbakonam is very difficult, because everyone says about the cost factor and things. But taking into consideration the various prospective things about the GLP-1 agonist, when we counsel the patients about the positive aspect of things, some patients who are really affordable, they come forward to take this particular GLP-1, whatever may be the group of class of drugs. The main thing is we need to just explain the things before starting on a particular class of drugs. And I'm able to convince the patient even if the cost of the drug is more. But the prospective things, what we take from the positive aspect of this molecule when we add on to the patients, what they gain, if we can explain them in detail, some people get convinced and we can start it. Okay. So only thing is education.
Okay, so what do all of you offer? Do you offer the oral preparations, or do you think you offer the injectable? Do you have a particular preference, and does that preference influence your patient choice? Anyone, just pick up the mic and anyone.
So on a lighter note, I was thinking, would I give Venkatraman sir GLP-1 RA? And the answer is yes. Will you take it, sir?
He could lose some.
As a patient, I can refuse, no? That is also in a lighter vein. No, what I am trying to say is, I think when you offer a therapeutic option, even though it's an injectable, I think this particular class, of course being an injectable as well, I think the first visit, I wouldn't be too enthusiastic. Just make a mention, there is an option available here. No, just give a rough quote. Patients who are eligible for this part of therapy, if 10 of them who may initiate a discussion, of course given the time in your clinic and making a sincere attempt, I'm sure the first attempt takers will be 30%. But down the line, you can convert the remaining 70, probably about 40 to 50% of them. So I think we should not be disappointed or should not give up our efforts, initiate the discussion. Wonderful molecule is there, option is there, it has got so many benefits. Of course, the constraints are etc. 1, 2, 3, 4. Then immediately, only few takers are there. But down the line, in the next visit, after a month or two, certainly many of them are motivated.
Oral or injectable?
I would now prefer injectable. For the simple reason, initially when the oral was introduced, I think we thought that people would prefer an oral tablet rather than an injection. But having said that, when the injectable form was introduced, once a week seems to be an attractive option for people, number one. And I tend to believe the metabolic endpoints of both the HbA1c reduction and the weight reduction, I may be corrected if I'm wrong, are possibly slightly much more better with the injectables and more so with tirzepatide than semaglutide.
What do you do? Oral or injectable?
I also lean towards the injectables, also for some practical reasons. I think it's very difficult for people to every day take that tablet empty stomach, particularly people who are traveling. So for practical reasons, I think a few people even on oral respond very well with significant weight reduction and sugar control. So something like I would say maybe about 10-20% of people, but the vast majority of people on injectables respond better. So in general, I agree with Dr. Venkatraman sir. Unless they refuse an injectable, I start the discussion off and offer the injectable first.
In your
Yes,
a rural
the same
practice?
thing, sir. What both of them just alluded, the same thing. When we come to even to the periphery, people prefer injectable. The main advantage is once weekly, and as Madam said, patient little bit hesitant to take these tablets half an hour before food, and even after taking the tablet, you should not take anything for next half an hour, which makes them difficult in day-to-day practice. So even it is an injectable, they prefer to take it once weekly injections.
Again, anyone who has a question, just come over or I'll come and give you the mic, and let's do multiple ways of doing this.
I mean, there is no doubt, like, it's like getting hooked. Like, someone goes on a GLP-1 injectable, I feel they're not going to stop it. Once they see the advantages, once they see the weight loss, once they see the glycemic control, once we see the sugars, once they see the sugars coming down, reducing the insulins, who are also on insulin, they're going to get hooked. But someone like, I would also agree with Madam, as she said, I wouldn't start someone like Dr. Venkatraman on a GLP-1 agonist. I'll tell you, in clinical practice, a lot of dropouts due either taking GLP or even an SGLT for that matter is because of weight loss. Because they are already someone who is frail, I would be a bit reluctant. Thank you.
So just a point about the weight loss. I mean, I don't know what the other panelists feel. I feel that the SGLT2 inhibitors cause more of this face weight loss, where the cheek fat goes down. It is not that evident or that obvious unless people lose weight very rapidly. I feel it's not that obvious with the GLP-1 RAs. Do you agree? Or?
Absolutely. I think buccal pad of fat, which Jayashree just now mentioned, and also the weight loss with the SGLT2 occurs very early, probably in some cases bit rapid as well. Of course, it reaches a plateau within a couple of months or about 12 weeks time. Here it takes some time, and quite often it is the central adiposity that we are able to see. Even though the response is a bit delayed, it is more. You don't have that sick look of the emaciated feeling with the loss of buccal pad of fat and the cheekbones being very prominent.
So my question is, We are majority GLP-1 analogs are used for obesity, focused for obesity. But but very small fraction of patients are going to take it. I want to give the benefit to all my patients who need the cardiovascular protection and how to use it. Shall I use it in even with lean individual? And what is the dose to be maintained? I don't want weight loss. Already they are lean or moderately having weight. And how to go with this? I want to give the cardiovascular protection.
I think Anbu and I discussed this yesterday informally. What I thought was the cardiovascular benefit have been achieved with the maximal tolerated or the maximal permitted dose as per the label for both the molecules, if I remember right. That's number one. And as I keep on repeating, the weight loss is proportional to the baseline body weight. For somebody with about 90 kilos, she or he might lose about 8 to 10 kgs. And then another caveat is, weight loss in the diabetic population is less than what you encounter in the obese, non-diabetic population. This has been captured in the studies, that's our experience as well. So coming back to your question, so even in a lean individual, unless somebody is very thin and got prone for postural hypertension on multiple antihypertensive drugs, the risk of a fall with risk of a fracture, everything is there, maybe. And if the patient is not a candidate for resistance training, improving certain amount of the physical tone and the sarcopenia which is there, probably I'll be even, but at the back of your mind, the class of molecules which have had a consistent benefit with the cardiovascular disease benefit are the GLP-1 receptor agonists. Okay. So the positive aspect of the story
I'm going to move away from the positive aspects because I think we've beaten that to death in the last 2 days. I want to tell me, who will you not use it? Who are the people you're going to say, this is not for you?
Somebody whose glycemic control is good and whose body weight is also within your acceptable range. I don't think you need to consider this molecule. I'll give a comparison. Supposing somebody is on a sulfonylurea, metformin, oglibose combination, control is good, possibly with or without a trace of proteinuria, or even if the E by E prime is not within the normal limits, I would force myself to an SGLT2 inhibitor in this particular patient because my aim will be to remove the, say, SU from the list for obvious benefits. I think the CKD benefits. In a comparable scenario, I don't think the same amount of logic is practicable in the day-to-day practice to substitute a GLP-1 receptor agonist for a sulfonylurea if the control is good, no hypoglycemia, and then the say BMI is around 21, 22, etc. That's my
Jayashree, disagree, please.
I was going to say, I think the main places where I'm cautious or would not consider using it is obviously people with a history of gastroparesis, people with a history of depression, antipsychotics, antidepressants. Unfortunately, quite often what happens
depression
is...
Depression or severe depression?
Severe depression, and if they are on multiple, say, antidepressants, antipsychotics, I say we need to discuss this with the psychiatrist because I do not know what is the risk of, the suicidal risk is sort of, floating in the background. I don't think it's a major risk, but we do have, and most important, I think you need to have a motivated patient. Because initially when these medications are started, it significantly reduces appetite. People need to be willing to put up with that side effect. So a very well-motivated patient is, I think, the prime. So for example, I've used it in, women in the 60s, 70s, 80s, whose children have said, children in the US have said, please use it because it's so good. And they hated it. They hated the way it made them feel. So gastroparesis, history of severe pancreatitis, someone with a gallbladder stone that looks like it's going to slip and maybe cause problems. So I get an ultrasound abdomen at baseline. But yeah, apart from that, no real contraindication if the person is a suitable candidate.
Okay, I'll add a couple of caveats here. One is that if someone's BMI is 21 or less, I'm careful. That would include Venkataraman.
Sorry, I forgot to mention the eyes. Right. Very important.
We'll come to the eyes. I will do a larger. Just give me a minute.
Krishna,
give me a minute.
Situation of a contraindication.
Give me a minute.
Yeah, I just want to give this example. Yeah, please go ahead.
Just give me a minute. So, I would be very careful if somebody is LADA-like, meaning that we are dealing with the insulin deficient state, and the BMI is less than 21, I usually am careful. I'm just adding this caveat.
No, in the same tone, in Apollo, I have at least 4 or 5 cases of LADA. I have written in the prescription because the patient is on a pump, CSIA, but the weight gain is huge. Weight gain is huge.
No, but that's a
I
different
put
story.
them on. So, but I've given the benefits and risks of has been explained to the patient. Now, the patient is on about 60 to 70 units of insulin with SGLT2 inhibitor as well as with a GLP-1 receptor agonist. Because otherwise, and one of my classmates who's a type 1 diabetic patient is on both. Because in fact, a couple of times he went in for a mild ketosis, but otherwise the insulin requirement is about 150 to 180 units. And the weight gain is something like about 8 to 10 kgs, is already obese. So he says, now coming back to the same thing of a contraindication, other end of the spectrum, I have an obese lady, a Marwari lady who has been in my clinical, fortunately for the past 3.5, right from 93, she's under my care, referred by one of the gastroenterologists with a label of acute pancreatitis. So since then, we have been careful enough to avoid any incretin-based therapy. What has happened is, down the line, already obese, she has obstructive sleep apnea, not at all ambulant, then she developed severe polyarthritis rheumatica, and she was on steroids. Now all these have kicked up her, now she is about 126 kgs, somewhere from, say, about 98 to. Then they kept on asking about the molecule, tirzepatide. I told, I would have been the first to use once it was launched, or the earlier part of the molecule because of this. The family agreed, they given it in writing, we have been explained. I have started on tirzepatide. She has lost in the last 2 months about more than 6 to 7 kgs, and she's so happy. And the whole family is asking me, what I'm trying to say is individual discretion, being careful about your own reputation or your legal position is not at stake. Then I think even the so-called situations wherein you need to be careful or contraindicated, in my opinion, you can. And maybe down the line, if there are indications, we are so happy.
Okay. We have some time, so what I'm going to ask is, as we go through these questions, brief responses so that we can cover a little more ground. You have a paper? So please, you can't. I'll get you mine. Huh? Absolutely, you can use it. There's no issue. Which one? No, sir, forget this question, sir, please. No, that question, please forget it. Please forget the question. By the turn off the thing now. Okay, we're not doing the slides because there are an issue with the slides. Okay, let's go on, because first is, go back to your, what are the baseline testing that you would do before you start these drugs? Yes, you can take it. Arvind, you can go up also. No, go sit. I'm only asking questions, go.
Yeah, I think the routine testing of a diabetic patient, which includes the routine glycemic matrix, and also, as Jayashree pointed out, an ultrasound, and of course...
Why, one second. Jayashree, why an ultrasound? Why do you think a baseline ultrasound is required?
At least in the non-diabetic population, I do it. If there is going to be a gallstone of around 10 millimeters,
so what
more than
do?
that, I do. In fact,
what it is going to do?
Yeah. So we do the, I subject them to lab chole and then take it up, because subsequent risk of pancreatitis is not there. That is number one. Acute cholecystitis, not the pancreatitis, acute cholecystitis. Number one. Number two, when exenatide was introduced, we had, it was late 90s or something, so we were interested about the gallstones which emerged at that point of time. So I was discussing with one of the pioneers in that field of exenatide therapy that it was logical conclusion. It is not as if we have done some work or something. I told him, when it can slow down so many things, probably it slows down the movement of the gallbladder also. He foo-fooed it. He said, if that is the reason, it's so obvious, as you have rightly pointed out, now everybody accepts it. So,
no, but
the incretin-based therapy...
I'm going to challenge you, Dr. Venkatraman. Why do you think a baseline ultrasound is required?
Absolutely, because if it is going to be even a complicated or a non-complicated gallbladder disease with a gallstone, certainly I would like to knock it off before embarking on this therapy.
So I do it more to document a baseline, either presence or absence of gallbladder stones.
Just to protect yourself.
Yes, because when people lose weight rapidly, they're going to form gallbladder stones.
So-
If there is a problem, I just need to know whether it was there at baseline or not.
So this issue was a lot with Lyra, the sense that people talked about it causing cholecystitis and cholelithitis. The actual truth that the literature talks about is that it causes more of gallbladder sludge rather than actual stone formation. So the second thing is, even in a diabetic...
Cholecystitis is documented with all the GLP-1 receptor agonists as one of the complications.
It's going to have, no, but the thing is...
But when you have this stone sitting with 12 millimeters, 15 millimeters, after all, lab chole, the patient recovers in no time. Yeah, postpone your GLP-1 by a month.
Okay, fair enough.
No,
we need...
do you agree? For this, it's a clinical discretion.
Okay. If you're doing it to protect yourself, absolutely. Second, move on. What about the fundus exam?
Definitely.
One second, let's go on. Yeah.
I think it goes without saying that you have to have a fundus examination, and then mild to moderate is absolutely okay. You keep watching him every 3 to 4 months, but if it's more than moderate and likelihood chances of DME, I think it is better to wait, and I don't think we should risk it.
Do you get a
Even though
laser before you start a GLP-1 RA?
Before a GLP-1, always a fundus examination to make sure that there is no higher grades of retinopathy, just to be sure. Even though the trials are going on, there are no red flags at this point of time, but the FOCUS trial is still going on. By next year, we will know the reports of FOCUS. However, I think it's always good to do a fundus examination.
But a fundus exam, one moment, a fundus exam does not predict NAION. So what do you do?
No, absolutely, but the chance of AION is less than 0.1%. Less than 0.1%.
So the question I was going to come to you was, is there something else that you're looking at the fundus photograph?
No, you're looking at your glaucoma changes, you're looking at your AMD changes, you're looking at your fundus examination, cup to disc ratio.
What cup to disc ratio do you use?
Well, I think you caught me there. I don't remember the figure. Is it
you want
what?
to
It's
take
more
a-
than 0.3
No,
or something?
before that, what I wanted to have a consensus is, number one, is the deterioration in retinopathy because of the rapidity of control that you achieve with this class of drugs,
So
or
just 1 second. Can we come back to that, because I want to finish the cup to disc ratio and we will come to this. I will
So-
come to that rapid deterioration. Just finish the cup to disc ratio.
The
Yes.
cup to disc ratio of less than 0.3 is supposed to be somewhat of a marker for NAION, but every ophthalmologist I've spoken to have poo-pooed me.
Yeah. So two things. One is, let's put this together. One is, a fundus photograph is absolutely, a fundus exam is something required. If you have proliferative diabetic retinopathy, there is a chance of worsening that has been reported with every drug in this class. So that is very, very well known. So most of us would say, if you have proliferative diabetic retinopathy, treat it and then start the agent. This is one. But the cup to disc ratio that we are talking about in a fundus photograph is actually called a virtual cup to disc ratio, because there is no way of calculating a clear CDR with just a fundus photograph. It's a VCDR that is done by the AI component of the fundus photograph.
Yeah.
So what I do is, when I see a VCDR that is less than 0.3, I refer it to an ophthalmologist who gets an OCT and other things, and then I ask him, can I go ahead and start the patient on it? And most of the time, it's very interesting, while the AI is very good for all the other stuff, with the cup to disc ratio, it doesn't do so great. The ophthalmologist will say, no, it's fine, there's no crowding, you can go ahead and start. But what Jayashree is saying is also very important, that there are really no predictors of NAION. There are no predictors of NAION. In some meta-analysis, it seems to be that there seems to be a greater incidence in the low CDRs. But the real truth is, there is no. So, what do you warn your patients about eye?
So one of the things that is believed to happen which causes NAION, and it's both the rapid changes or the drops in the blood pressure and the sugar affecting the retinal vasculature, which I think behaves a little bit differently compared to the vasculature in the rest of the body, maybe. What I've started to do is a lot of times when you initiate GLP-1 analogs, blood pressure drops fairly rapidly. It drops. If they're on antihypertensives, I'm saying.
So you have
if
to
they are
de-escalate
on-
many of these guys.
So I preemptively try to reduce the BP tablets a little bit. The other risk factors for NAION are someone who is very obese with sleep apnea, hypertensive. These are all sort of the places where, for example, recently I had somebody who had hypertensive retinopathy and the ophthalmologist wrote back saying, don't start GLP-1 RA. And we said, fine, we are not going to start it. I think it's a combination of like stiff vessels in which the BP suddenly drops, which precipitates maybe.
So what do you tell the patient?
No, I tell them that this problem is there. You have to watch out for, it's a very, very rare occurrence. It's a very controversial issue that is going on at present. There are plenty of studies saying that people who have been given this long term are not experiencing this complication. We've been using this class of medications for at least 15 years and we haven't really picked up a signal like this. However, it is something you need to be aware of, which is why I'm asking you to go meet the ophthalmologist. And if while on the medication you start noticing any blurring of vision, please stop the medicine, talk to me and talk to the eye doctor.
Do you document in the case sheet?
Absolutely. Yes,
Okay.
we give them a long list of
So just to
things.
summarize, and I am going to adverse reactions quickly because we don't have much time. One, before you do it, if you believe in it, go ahead and get a ultrasound of the abdomen. Second, get a fundus photograph, or at least, or if you have an ophthalmologist right in you, ask them to examine it. Look for signs of diabetic retinopathy. Importantly, diabetic macular edema, which is actually more dangerous than that. If they have DME or if they have proliferative diabetic retinopathy, fix that before you start the drug. If you have the access to a cup disc ratio, if it is more than 0.3, please get an ophthalmology opinion. So these are the things that you will do before you start. Question?
Contraindication or not, Krishna? Proliferative.
I would not use it unless I fix it.
Yeah, you fix it.
Then you
but
can start it.
Presence of proliferative retinopathy, is it a contraindication?
No,
You fix it and start.
yeah, it's not a contraindication, but the chances is if there are too many new vessel formation with proliferative diabetic retinopathy, there's a small risk of increased bleeds. Okay, now therefore you don't want to take a chance because vision-threatening retinopathy when you are there in front of you, I don't think we should worry just about the obesity here. I think that's more important. Just categorize which is more important now. As Krishna said, fix the retinopathy part of it and then start him on
Okay.
this.
Can I add a point to what?
Okay, quickly, please. Yes.
So I think we discussed yesterday, the proliferative diabetic proliferative retinopathy, the new blood vessels do not have a supportive basement membrane. They are supported by the intraocular pressure. And then once you have a glycemic control, I think the risk of hypoglycemia is always there. So once metabolic swings are there, the intraocular pressure comes down. So the supporting framework for these potentially friable vessels is not there. That's the reason. That's why they say, for that matter, any intervention which induces the risk of hypoglycemia. So that is probably one of the reasons given in all the texts.
So I have 5 minutes to close this. So we're going to do this very fast.
In retinopathy, I want to ask one thing.
No. I want to do this.
GLP-1 receptors are there in the layer of retina. But still, it is not the molecule that is worsening the retinopathy. It is probably the rapidity of control. Am I right?
Fair enough, but we're going to take this offline because I want to get your brains on the most important points. One, about their food. What do you want them about their food? Arvind, you want to take this first?
About the food?
So, what to expect about once they start it? What are the side effects that you'll say? What are you going to say are the side effects? What are you going to say are the effects of the drug that they should expect?
See, what I always do is to write a figure of a stomach and then tell them, look, GLP is naturally produced in your body, so we're not giving you a drug or a medicine, number one. And then it has the action on the pancreas. Just draw it in front of them, show it to them. And then I tell them, when you start the drug, there are two things that you have to watch out for. One is a little bit of nausea, vomiting sensation, and bloating of the stomach. And then suddenly disinterest in food. Okay, so start with, this is a good effect of the drug. So that means it's good for me. I'm happy that this drug is working for you, so don't get worried.
So you're going to tell them that satiety and aversion to certain foods are effects of the drug. Is that correct?
Effects of the drugs, yes.
Go ahead, and then we'll
Yeah.
get Madam to ask a question.
Yeah. I do tell them, that means the drug is really working for you. Okay, nausea, bloating, So take small quantities because there is a delay in the clearance of the food from your stomach.
Small quantities multiple times, or just small quantity at your meal?
Small quantities, say once in 4 hours. Okay, I mean.
Do you do the same thing?
Yeah.
I would say make use of the medication satiety effect and eat when you're hungry. I mean, I don't say eat every 4 hours, just eat when you're hungry.
Balaji, any different in your patient?
But quite often they are not able to eat. After the first few weeks of therapy, they do not, that inclination dies down.
No, even if you see all the, the Wegovy, Ozempic, and then the Mounjaro, this one, information sheet, it's also told take small quantities of food when you have this problem and then you get over this. One thing that they complain of is total lack of appetite in many of the patients, and there's a disinterest in seeing food.
Ma'am?
Sir, NaON, which may be Jayashree ma'am. NaON, which may be precipitated in hypertensive individuals, which can be corrected once you stop the drug. Is there any permanent loss of vision or something like that, ma'am?
There will be.
I just want to clarification.
They'll
get back their vision once you stop the drug if they develop.
No, I think it's quite permanent.
It's a permanent
vision,
thing.
so therefore you just want to be careful. You don't want to be sued, so therefore you just want to be extra careful in this kind of thing.
Let's also get the point that it is exceptionally rare. It's 1 in 10,000 reported with GLP-1 RA. In the entire tirzepatide story, 8 cases have been reported completely. Yeah.
It's a permanent damage.
Okay,
So-
don't go into NIO.
Okay, fine.
Go back to this.
So the thing is about the
We need to
diet.
get people-
Once we start on GLP-1 agonist, it's obvious that they will have that lack of appetite and things. So they will lose the thing. So the patient.
What is the commonest complaint that you get from patients as soon as once you start a low dose?
Disinterest in taking food.
No, I think it's nausea and bloating. Nausea and bloating.
Okay.
Nausea and fullness. He says, sir, as if somebody has put gas into my stomach. And the madri is there bloating.
And
this is what I have heard
Do
from
you
most of
do
the
you
patients.
give any supportive measures for these patients? Do you give them?
A little bit of PPIs and kind of Emised tablets, mouth dissolve.
I have one question. How many of you tried stopping metformin when they complain of
no,
complications?
never.
No indication.
No.
I'll tell you something.
One thing is, I had more amount of complaints of diarrhea with patients.
tirzepatide.
Yes.
But do you get that with the Rybelsus or semaglutide?
No idea.
Mostly constipation. And very interestingly, I'll give you my theory, but it may be wrong. They are complaining of constipation because the quantity of food has come down. Right? And in fact, increasing the fiber doesn't seem to work. So usually end up doing a stool softener or telling them it's all right if you go to the toilet once in 2 to 3 days. Okay. Now, we need to close up because this is the amount of time we have, but a couple of things. Single sentences. Something unique you've seen when you use the GLP-1 RA? And you think people should know? We'll start from Jayashree and then one by one. And maybe we'll even have a second round as long as these sentences are short.
So, well, this is something I also want the expert's opinion. I currently have a lady who took one shot of, she's about 65, obese, took one shot and is on glimepiride at baseline, 1 mg twice a day, took one shot of a 2.5 mg and is now in the hospital with severe hypoglycemia, undergoing treatment, requiring glucose infusions, almost 48 hours. So I just wanted to be careful.
Okay? One thing unique.
No,
Something
one
unique.
sentence you want to tell about the GLP receptor agonist.
Anything that you think is unique that everybody should know about
The
GLP-1 RA?
combination of robust HbA1c reduction as well as
No,
weight
from your
reduction.
practice, something that they should learn.
The practice, I think the example that I gave, a obese lady with acute pancreatitis whom I didn't even consider any form of incretin therapy. Now, with the family pressurizing me, I've taken care to an extent legally as well, and now she is last about. So in situations wherein there is an absolute or relative contraindication as well, in clinical situations, one might, taking the patients and the family to confidence, use this molecule because the effects are phenomenal.
Your craziest GLP-1 RA story?
I don't think I have any crazy stories as such, but then the people are extremely happy. I think this is a great drug which majority of Indians will need. If we can have a good patient education system, and if you can train one of your dietitians or educated to actually sit with the patient, educate them before starting your GLP-1, and with the prices coming down with the generics availability, I think this is what India needed. I think this is a great drug. I think the doctor should go out of the way to see if we can actually fit a patient into a GLP-1 in future.
One thing is, each and every time, most of the patient asks, how long should I take this?
Yeah.
Absolutely. Okay, how do you answer that question? Very interesting. That was going to be my last question. So how long should you?
The thing is, they have to take it lifelong, continuously. Because we know that...
Okay, so when you say lifelong, if it's a diabetic, it's fine. If it's a non-diabetic, they feel very dissuaded. Do you answer them differently?
Absolutely. But the thing is, they have to replace with lifestyle modifications and exercise. That has to be done, either this way or this way. Otherwise, the weight regain will be there.
Okay.
I think the joint issue with Aravind Krishna, one thing. So the generics are going to be in the pipeline. I'm slightly apprehensive about the efficacy of the generics going by what is happening in the SGLT2 space. I think compared to the innovator molecules, be the weight reduction or the HbA1c reduction, I'm not saying they are not effective, but get a feeling. I've not done any studies. The impression is the innovators are innovators.
Okay. That's a story, another story for another day.
I will just sum it up about this. Okay, I've been told by some of the people who are actually making the generics that this is one of the easiest things to actually make once you have the formula. And I'm sure there'll be a lot of generics. I'm sure it's going to work.
So from evidence, we are into opinion and speculation now. Let's get out of this. First is, I hope the objective of this particular workshop was to look at some tips and tricks when we start using it. I hope you've gotten some of that. You will get a lot more as you start using it. The most important thing is, I hope many of you are more comfortable using it now. Is that a fair statement? If that is true, then I think we have done our job for the day. Please give a big hand to all our panelists. I'm sorry I rushed you, but even then we are a little behind time. So, move on to the next session.
So thank you all the panelists for the wonderful session, and thank you Krishna Share also.
I don't belong to this panel. I just pitched in because the lights didn't work.
So moving on to the next session. The next session will be on Aging and Longevity Symposia. And to chair the session, may I call upon Professor Dr. Anand Moses and Dr. N. Kannan.
So good morning and welcome to the morning session on a very interesting topic on longevity and aging and longevity. I think over the last decade, the demography of many of the countries have changed due to longevity and aging. With that comes many problems. Aging people, many of them are health. There is something called a healthy aging. Some people develop many chronic diseases. So to talk to us and as an introduction on longevity and aging, we have the first speaker. I request Dr. Kannan to introduce the first speaker.
Friends, it's a great pleasure and honor to be here. First of all, just I want to enlighten on the topic. So regarding with the date of birth, we know about the date of birth, we know the age in numbers. But how far our cells or our organs or our myocardium or our vasculature is running along with our age or behind the age or against the age, overshooting against the age. That is the main for the chronological age and the biological age. So what the understanding that we have been enriched until now regarding with our chronological age as well as the biological age. For this we have our own senior most endocrinologist, Dr. Jayashree Gopal. It's a great pleasure and honor to invite you, ma'am.
Thank you. Thank you so much. Good morning. And thanks to Krishna for always giving me topics that makes me, like I said, read, think. So this is the, yeah, it's up. Is age just a number, chronological versus biological age? We all know what aging is, and being at an age where I'm starting to worry about aging, this topic actually had a lot of, I read it with great interest. It is defined as this. So there is actually a medical definition. It is the process of accumulation of the consequences of life, such as the molecular and cellular damage that ultimately leads to functional decline, chronic diseases, and mortality. So that is aging. But how do we define age? Obviously, like Dr. Kannan said in the introduction, we have the chronological age, and that is determined by our date of birth. It's a calendar-based measure. We celebrate our birthdays every year. So that is the chronological age. But the biological age is what is defined by the level of the biological changes or the damage that is accumulated inside each one of our cells. It is a physiology-based measure, and the way it is calculated is, I'll talk about how biological age is measured in a little bit, but a number in units of time matching the chronological age. So let's say you measure, let's say my biological age right now is probably something like about 10 years older than my actual chronological age. So I will say that I'm currently 58 years old. My chronological age is probably 68 years old because my cellular damage is reflecting that of a 68-year-old chronologically old person. So age really is a physiology. It is not a number, it is a physiology. We all know this old adage, we are as old as we feel, but it's absolutely true. The problem with just looking at chronological age as clinicians, as you know, when we practice medicine, is that it fails to capture physiological deterioration. We look at a 40-year-old and we think he's only 40. What problems could he have? Or we look at someone who's, you know, I have a 88-year-old gentleman who's very active, who goes around. We all know people like that, very healthy at that age. So the chronological age obviously fails to capture their functional age or their functional status or their biological age. And you can see here in the sort of little cartoon that I made. Oops, sorry, I didn't mean to do that. Yeah. So this person, let's say you have someone who's 55 years old, could have either a biological age of 40, or you could have, the same person could be at a biological age of 60, accelerated. Why is this important for us to know? Because aging and the changes that occur with aging is being recognized as a very important part of what needs to be studied to help improve humans' health span, lifespan. There are a lot of labs around the world that have been set up to, you know, study this aspect. We are getting control of a lot of the chronic diseases. The next frontier that humans are trying to, conquer is this, not only just living longer, but living healthier. And one aspect of doing that is to recognize what biological age is. And biological age really ultimately captures a physiological deterioration better than the chronological age. And it is amenable to interventions. These are all some of the changes that occur. In the interest of time, very quickly, I'll just point out a couple of them. Some of the things that occur as we get older, telomere attrition. And in fact, this is one of the ways that biological age is measured, and I'll come to that. Epigenetic alterations occur. Loss of protein homeostasis. So basically, proteins don't get folded up properly. Because of that, they don't work properly. Deregulated nutrient sensing. There was to be a talk on mitochondrial dysfunction, a lot of accumulation of mitochondria that are not able to divide. So multiple molecular, cellular, organ level changes are occurring which contribute to the aging. These are all some of the new definitions that are used. You'll be seeing a lot of articles that come up about aging, so I thought it would be useful to talk about it. One is what we call health span, which is a period of life prior to the onset of chronic disease and disability. So this is what the process of trying to understand about aging and trying to prevent the biological deterioration that occurs with aging. We are trying to improve the health span for people. And there's something called an age deviation, which is the change, the difference between the biological and the chronological age. So if it is positive, it means you have accelerated aging. If it's negative, you have decelerated aging. And then there are things called geroprotectors. It's just something that helps with keeps us healthy and prevents us from getting older. Geroprotectors range from simple things like all the lifestyle changes that we always talk about, eat less, sleep more, have less stress, to things like, for example, they're studying molecules like rapamycin. I had a patient who came in and was very keen to get onto rapamycin because there is a lot of studies going on about the use of rapamycin as an anti-aging molecule and as something that protects the beta cells, among other things. He was a person with diabetes and he wanted to get onto it for that. So there is a lot of work going on in pharmacological agents which are working as geroprotectors. So again, this biological, what I had mentioned earlier, the difference between your chronological age and the biological age will determine whether you're accelerating towards your mortality or whether you're hopefully decelerating and having a longer health span when we live. Why do we have to measure the biological age? I spoke a lot about it because it predicts survival. Again, to me as a clinician, I think it's important that when I have this 40-year-old in front of me, we know that diabetes adds 10 years to a person's life. We've always been told that. So we know that a person who's 40 with diabetes is equivalent to a person of, say, 50 or 55 years. How can I keep him at a lower age? So anytime you have accelerated aging, it is going to increase mortality. So irrespective of the age, even when you take someone at the age of 40 to 50 years, if he has accelerated aging, his survival probability comes down significantly in the next 10 to 15 years. And at each age, this graph holds true. So this is a very strong predictor. Biological age is a strong predictor of survival. It also predicts what I had alluded to earlier, which is health span. So when you have a younger biological age, you've accumulated less damage in your body, you tend to have a better, longer health span, you're active and fit, you have a stronger immune system, you're able to fight off infections, versus if you have a shorter health span, you're more likely to develop, obviously, frailty, disability, but also things like cognitive decline, cancers. I didn't put it up there, but biological age predicts your health span. There are studies clearly documenting, it is not just sort of a vague, amorphous calculation, but biological age has been shown to predict your CV event risk and cancer risk, among other things. It predicts many things, but I just pulled up two. So older biological age, for every 5 to 6 year increase in your biological age, you have a 60% higher risk of a CV event. And that's one number which came up. Again, with an increase of 5 to 6 years in your biological age, you have a 2 to 3 times higher risk of developing cancers. So biological age calculation is something that's going on. How do we measure then this biological age? And there are various measures that are used. I'll talk about a little bit of them, but some of them are simple that we can just use in our day-to-day practice. We know about fitness, the get up and go test. How fast is a person able to walk? How fast is he able to run? What is his muscle strength? And so on and so forth. And then there are more sophisticated things that are used like the proteomic clocks, epigenetic clocks, telomere length. They're even looking at the gut microbiome to see how that impacts upon aging. So this is what I meant. Even simple things like we can use grip strength, the VO2 max, gait speed, apart from simple things like waist-hip ratio, BMI. We all know that as we get older, we lose muscle and gain fat. So even things like that give us the clue that biological age is accelerating. There are many licensed models looking at which predict biological age, molecular markers. So I've just put up some of the names here. A very well-known one which was developed by Dr. Horvath, the DNA M-Age, I believe it's called, is an epigenetic clock looking at DNA methylation measures. Another one called the glycan age looks at the actual glycan which is attached to the immunoglobulin antibodies, and this is associated, the more number of glycans get attached, the higher the biological age, and this has been correlated with multiple things like time to death and development of diseases. So let's talk about a couple of these molecular markers. One is the methylation clock. And again, there are many licensed models which look at this. The DNA methylation pattern. What do I mean by methylation? So anytime you have a cytosine adjacent to a guanine, the methyl group can get attached to that cytosine. So this is what is called the DNA methylation pattern, specifically at this cytosine guanine site. When you have a younger biological age, you have lesser methylation. When you have an older biological age, you have more methylation sites. What happens when this methyl group gets attached here? It affects the gene function. It affects the way that the gene works, the type of proteins that are made, and it also correlates with the biological age. So, for example, using that, this sort of patented technology called the DNA-M Grim-Age, they showed that every 1 standard deviation increase in this Grim-Age calculation was associated with almost a doubling of a higher all-cause mortality in older adults. And these are some of the more recent sort of biological age clock measures that have come up. So people whose methylation age is older than their chronological age have approximately an 80% higher risk of death after adjusting for the calendar or their chronological age. And there are many other studies. I just put up a few here. For example, there are studies which have correlated the methylation rates with not only all-cause mortality, like I mentioned, but with the incidence of cardiovascular disease. So 1.5 times higher risk of a cardiovascular event, 2.5 very strong predictor of diabetes, also, depending on what type of the model that we use. And this is after adjusting for all other risk factors. So after adjusting for age and obesity. So in spite of that, this biological age is a very powerful marker of mortality, cardiovascular disease, diabetes, cancers. Another one that is commonly used is the telomere length. So we know that telomeres are found at the ends of the chromosomes. The older we get, every time our DNA is replicating, chunks of the little bits of the telomere gets cut off. So older people have shorter telomeres. There are interventions looking at something called the STIRT enzyme. TERT is something which rebuilds the telomeres, and there is a lot of work going on. I've not gone into that in great detail, but they've looked at things like using the STIRT to reverse degenerative pathways in mice models. So this is one of the pharmacotherapy things that I've talked about, which they are trying to do to restore telomere length. This is just one of the changes that occur. I don't think, obviously, it's not going to be as simple as just saying, put the telomere back to the original length and things will get reversed. Like I showed you in that one graph, there are many, many, many changes all happening in parallel in our body. But again, strong evidence that telomere length, for example, for every 1 standard deviation, the telomere is shorter, there is about a 26% higher risk of all-cause mortality, and so on, whichever one you take. Let's say cancer incidence, about a 16% increase. So, well done scientific studies saying that the telomere length correlates with the prediction of developing various chronic diseases and mortality. A recent study that was published about a couple of years ago, the UK Biobank study, they looked at close to about 500,000 adults who were middle-aged at baseline, and they were followed up for a long time. And I liked the study because they calculated a biological age from routine markers. Look at this, the CRP, glucose, albumin, creatinine, WBC count. I'll put this up in the next slide. This is a list of the markers that they came up with. It was obviously a lot of number crunching, but look at the simple things they put up. Red cell erythrocyte distribution width, you know, that thing that always comes up which we never look at. This is one of the strongest predictors of your biological age. Cystatin C, which we don't normally use, again a strong predictor of biological age. So I'm saying already the clues are available. We don't really need to go and do sophisticated things like your molecular marker tests. Already the clues are available when patients come to us. The ones that stood out the strongest: CRP, higher glucose, increased WBC, increased RDW, reduced albumin, which makes sense. We are all familiar with this, and raised creatinine. The last two I don't think will come as a surprise, but keep these three in mind. More and more we are seeing 45-year-olds, or even I see young 20, 25-year-olds who are coming to us with PCOS with an elevated CRP. For me, it is a reflection of their insulin resistance and inflammation, but it is also a marker that their biological age is significantly higher than what it should be for a 25-year-old woman. And they correlated, because it was a long-term prospective study, they correlated it with increased cardiovascular events and incident cancer also, particularly lung and colorectal cancers. How do we balance it out? I think all of this is fairly, how do we reduce the biological aging process? But some of these are things which we may not think about. Social engagement, safe neighborhood, versus compared to someone who's had a poor maternal health, polypharmacy, low childhood education, stressful environment, low social position. When you don't have control of your time and space, I think that becomes the biggest stressor which accelerates aging for a lot of people. So these are all some of the things that you can use to balance out. So the take-home messages are to me, I think this just captures it. Chronological age tells you how long you've lived. Biological age tells how well you've lived. What is your health been like? So the biological age reflects your metabolism, your inflammation, your muscle fitness and resilience. Most of these drivers that accelerate biological aging are actually modifiable, and the goal of modern medicine is to extend health span, not just lifespan. Thank you.
Thank you, Dr. Jayashree. I think we are going to have the questions at the end of the two sessions. I call upon the next speaker, Dr. Deepak Saini, to talk on mitochondrial world, role of mitochondria in aging process, probably.
If the
Can I have his profile? Yes.
So friends, if the biological age is, shows the speed of aging, the mitochondria will be the engine behind it. So mitochondrial dysregulation plays an important role predicting our biological value. Over to you, Dr. Deepak sir.
The slides are not showing. So good morning everyone, and I think on the outset I would like to thank the triad of the organizing team here who's actually invited me. So the first few disclaimers: I'm not a practicing clinician. I will not prescribe anything to you. I will also hope that I do not change your practicing habits. I actually want to tell you a little bit about what we do at Indian Institute of Science. My research group is working on various aspects of aging and longevity for about 15 years now. And trust me, we have learned very little. And the way I expect is for India, we still have a long way to go. So I'm actually a person who likes to study how cells communicate with each other. Communication is what my bread and butter. So that's what I look at signaling in aging, inflammation, and infection. But I'll tell you what exactly I'm going to talk about because I've been given 15 minutes. And as a professional teacher, I can talk endlessly with 2 slides also. So I'll actually try not to do that. But the idea of the longevity industry is this. This is what somebody told me, that longevity industry is actually battling this very aspect, that how do you want to die young as late as possible. That basically means we need to stay fit, and then suddenly we want to pop out as cleanly as possible. Well, a lot of people don't want to pop out, and there's a very big movement called don't die. And let's not endorse that. So we disconnect ourselves from people who don't want to die, because that's against nature. But I'll tell you about what my group has been working on. We actually look at aging from multiple perspectives, from a cell to model systems to human. And over the years, we have transitioned more towards human. And that's one reason I'm in a forum where there are a lot of clinicians, where I don't get to talk about or even discuss my science. But what we've been looking at is very fundamental questions here. I'll just take out the pointer here. We look at how DNA damage occurs and how it affects inflammation. We look at proteostasis. Actually, the previous speaker, she made my life very easy. I actually removed half a dozen of my slides because she's pretty much shown everything what happens during aging and longevity. But these few features actually are hallmarks. We see us almost everywhere. My group is particularly interested in what we do, how does the mitochondria get influenced? How does the biomolecules in our body? We talk about lipids. Lipids go up. But the question is, why do the lipids go up? What happens, to all the biomolecules in the body? There's a very interesting analogy we say, when you look at from a evolutionary perspective, there are all kind of organisms which are on this planet. And the theory says that, if you are fitter, you do a lot of exercise, and you run around quite a bit, you're going to live longer. And when you look around mouse, and then you look at tortoise and turtles and elephants, I've never seen an elephant doing any exercise. I forget about tortoise. They live to 300 years, right? It's amazing. I think it's not about what you do, it's about how you do. It's more about that. So there's a very interesting piece about number of breaths, and I think that's where the biomolecular oxidation creeps in, that how the body manages oxygen and gets rid of the free radicals. I'll talk about that. And also a lot of clinicians have talked about that there are a lot of biomechanical alterations. Our body changes mechanical sensing. The tissue undergoes fibrosis. And what we believe, fibrosis is a mechanism to keep us alive. Fibrosis is not a trigger in response. It's just not a trigger to make tissue dysfunction. It's actually a trigger to keep the systems alive even when it's dysfunctional. So the idea is that when cells lead, she talked about telomere regeneration. When cells don't regenerate, the only fate for them to is die. But you don't want to die. The ultimate survival is the key here. And if you don't want to die, what do? You learn to live in that environment which is not conducive. So fibrosis is one condition which do not allow these damaged cells to die. And that's very interesting. So you don't want to cure fibrosis because you might end up dying. So it's a very interesting challenge. And then lastly, we do some drug discovery. I'll take you through. So we have transitioned from molecules to multidisciplinary studies in human. Ma'am actually talked about very nicely about a lot of things. So I'll quickly take you through what mitochondria does. Mitochondria dysfunction is actually at the heart of a lot of changes which happen during aging, which includes generation of free radical, reactive oxygen species, oxidative proteins. We always talk about that, but at the same time, mitochondria dysfunction also reduces amount of energy which we can actually generate from the food we consume. So the ATP production comes down, and in this process, poor energy utilization and poor physiological health generates a very conducive environment to accelerate aging. So ultimately, we need to figure out how we can improve our mitochondrial function, because that's at the heart of aging problem. So this is where mitochondrial dysfunction. So if you look at these arrows, what was fascinating about these arrows, all of them are bidirectional. There's nothing which says you do this and the mitochondria goes bad. It's back and forth. So genomic instability affects mitochondria, and mitochondrial dysfunction affects genomic instability. And it goes true for everything, that there is a backward-forward communication between mitochondria and other cellular processes, which dictates at the rate by which energy metabolism and redox stress is managed in the cell. And ultimately, it is the redox stress. It's a vicious cycle. Mitochondrial dysfunction affects mitochondrial activity, which generates free radical species or reactive oxygen species, which causes mitochondrial mutation, and the cycle keeps going on and on. So where do we intervene? That's the biggest question. And the challenge is that we have loads of measurements, right from measuring ROS, NAD level, mitochondrial protein, OXPHOS pathways, mitochondrial dynamics. We can record all that. The previous speaker very nicely talked about what are the various ways we measure age. And let me tell you one thing which is very interesting. We all talk about aging clocks. So she talked about Horvath methylation clock, she talked about pheno age, she talked about Grimm age, glycan age. You all wear watches, and thankfully all the watches show same time. But if all the clocks are showing you different time, that means none of them are right. And that's a very fundamental rule. That means all the clocks are fundamentally flawed. They are measuring what they would like to measure. If I take your blood in the morning and do any clock, and I take the blood in the evening and do the same experiment again, I'll get two different ages. They are very sensitive to the environment we are in. They're very sensitive to my genetics. They're very sensitive to what I eat. So that means these clocks are misleading to a large extent from a clinical perspective. What actually we should be measuring is physiological resilience. Do we have a measure of physiological well-being, ability to handle stress? So I'll quickly shift upon what we showed something in cell. These are two movies, and I hope the movies run. These are normal cell. And if you look under the microscope, they love to divide. That's what the cells do. Give them nutrition, give them enough environment which is conducive, they love to divide. And the same thing, you do it with an aged cell. And look at the windows. This is 46 hours and that goes to 70. They don't divide that rapidly. Actually, not only they don't divide, they take this funny morphology of big, large cells, and they actually will stay like this for months altogether. They will not divide, they'll stay. That pretty much reminds of the old people, right? They sit around the village on a charpai, and they just see the world go by and nothing changes for decades. And that's exactly what these cells do. They're inflamed, they're not dividing, they do not have regeneration potential. So what we wanted to understand is that, can I capture what changes happen in these cells when they go old? So we set up some model systems. Do not worry about the cell type, but I'll tell you what we did. We took cells and we removed one gene at a time. And to identify that which gene when I remove, my cells either become accelerated or they do not become aged. Well, I did not find any gene which prevents aging, but we found a whole bunch of genes which actually cause acceleration. So the blue ones are all the genes which reduce the time it takes to age the cells. The red ones did not do anything. The blue ones seem to slow down aging, but we found that actually it's not slow down aging, the cells were actually dying. So it was a misleading information, but the one which you got interested in, the bottom blue, where is a TIM50 protein stood out. This is a very interesting protein. It's a mitochondrial protein. So that means the moment you deplete mitochondrial protein, this one protein, cells undergo aging. We don't need to do anything at all. No damage, no insult, no calling names to your cells. Cells just become old. So this is where the TIM50 protein is. I'll go back to my pointer. It's right here. This is where the TIM50 protein is. It's actually in the mitochondrial membrane. It regulates how the proteins get into the mitochondria and generate energy. And what we found in multiple model systems, these are the cells which were exposed to radiation. And radiation leads to complete loss of TIM50 protein. And when you do increasing dose of radiation, the TIM50 protein starts getting depleted. That clearly shows just TIM50 protein is enough to accelerate. And these are some staining to show the cells, when they get old, they actually accumulate a lot of lysosome. They want to process proteostasis. They want to get rid of bad protein. So these lysosome can be stained blue. And this is when you remove TIM50, you can actually see cells without radiation, they're getting old. So now we have a handle. We have an interesting handle which says how we can study mitochondrial role in aging. And this is the first protein which people showed. And this is a lot of data. I will not bore you with this data, but what you need to see is old cell actually become pretty large, granular. And if you see here, these are non-damaged cells and they're very large and aging. And this shows formation of DNA damage. You can actually quantify the damage in the nucleus by counting the lesions on the damaged DNA by using advanced microscopy tools. And we can see that on radiation, the foci or the damaged lesions start appearing, but in TIM50, without damage, the foci starts appearing. I'm going to bore you a little bit with lots of graphs, but the idea is you can measure a lot of things in these cells. You can measure reactive oxygen species, reactive nitrogen, IL-6, IL-8 she talked about. A lot of inflammation, reactive oxygen species you can measure, and all of them show that when you remove TIM50, the cells become damaged, stressed, and when you add TIM50 back from these cells, they actually become very happy. So TIM50 level is a pretty good indicator of mitochondrial function, and what we found that it actually increases mitochondrial generated ROS. So ROS, or reactive oxygen species which damage your body, comes from mitochondria. Though it comes from other proteins in the cytosol also, but mitochondria is a key culprit which introduces damage to your organic systems. And ATP level comes down. So that means these cells are actually generating low amount of ATP. And let's look at the mitochondria. Mitochondria wants to repair itself, and mitochondria is a funny beast. When it gets damaged, it fuses another mitochondria and takes the protein and DNA from it and tries to repair itself. So leave that part, but what was interesting was this. Then using this handle, we started looking for a lot of anti-aging molecules which are commonly used in the market. I'm sure all of you have tried to buy a drug off shelf from Amazon or from clinic. So let's try some berberine, let's try some NAD, let's try some resveratrol. We actually took a whole bunch of them, and some of them are clinically very interesting molecule, and see which one of them can restore my mitochondria. And what we found, there are actually 3 molecules which can restore some mitochondrial function. Resveratrol, verapamil, and mitotempo, which blocks mitochondrial ROS. Mitotempo is not clinically approved, it's actually a research molecule, but resveratrol and verapamil are clinically approved. But what was funny, they improved mitochondrial function in the older cell, but they damaged the young cell and made them old again. So it was like, you figure out what you want to do. If you're old, you can take a drug and improve your quality, but if you're not old, you're actually accelerating yourself. So it's a funny problem that the whole rules of the game at a cellular system are very different when you're young versus when you're old. So actually, pretty much you're studying 2 organisms. You're not studying a trajectory of young to old. They're 2 different organisms. And the profile of these 2 organisms is different between every individual when they're young versus when they're old. So it's a very different battle we are fighting, that which we cannot address by using some molecules, some changes. Interestingly, what we know as of today, that the only thing which slows down aging and has a significant impact on quality of life, even after a decade or actually a century of research, is caloric restriction. We have not been able to come anywhere close from a pharmacological point of view to anything which can mimic the effect by simple caloric restriction. Cut down the carbs and you actually have much better physiological indices, and no molecule can mimic it. None. Absolutely zero. So that's where we stand in terms of fundamental research, but that's the challenge. But we did something more interesting, that we said, okay, these damaged models are pretty bizarre. They're non-physiological. I mean, in my lifetime, I will not be taking chemotherapy drugs and trying to see what happens to aging or undergo radiation. We get exposed to low dose radiation throughout our life. Radiation or damage like oxygen, sugars. So we started looking at what happens when you expose the body to low dose radiation, and does it actually affect mitochondria? So with a lot of gene expression, let's not worry about that, but what I want you to look into this confluence on the top. All the model system which we look, they affect some key pathways here. And these key pathways, I'm sure you cannot see, but I'll elaborate upon them. They are mitochondrial pathways. And what we ended up looking at is when you actually look at these pathways and look at mitochondria in this low-dose radiation model, we find that mitochondrial membrane potential, ATP level, everything actually gets heavily affected when the radiation level is actually low. Nucleus is not damaged, DNA is not damaged, just plain simple mitochondrial distress is sufficient to trigger aging. So this is what's happening. We actually started looking at this foci once more by just damaging the mitochondria, and guess what we found? We actually found that when you actually give high dose of radiation, you see a lot of nuclear DNA injury, but low dose also gives nuclear DNA injury, but when you remove the mitochondrial ROS from this picture, the injury actually is missing. So the way we propose is that once the mitochondria is distressed, they generate reactive oxygen species, they go and damage your nuclear DNA, and that leads to cell cycle arrest or leads or pushes the cells into a non-proliferative, non-regenerative state, and that's the problem. So fix your mitochondria, that's a key thing. So a lot of companies are just purely based on mitochondrial functional improvement. People are actually talking about mitochondrial replacement therapy. But the challenge is what the previous speaker alluded, which tissue needs mitochondrial replacement? We have no clue. We believe the PBMC's replacement is going to do the work, but that's not going to work. We need a tissue-specific challenge. So the key findings from what I'm going to talk about, because I'm taking a few extra minutes to talk about what we are doing at Indian Institute of Science. From my talk is mitochondrial dysfunction is the first hallmark of aging. Some proteins, which like TIM50 is a bona fide marker. Pharmacological intervention of mitochondria can protect cells from DNA damage, but again, it's not easy. And low dose damage only affect mitochondria. An injured mitochondria is the one which actually causes nuclear injury and leads to cellular aging. And of course, mitochondrial functional restoration will alleviate effective aging, but we still do not know how to do that. Now, I'll touch, like next 3 minutes, I will not take much time, is something what we're doing at Indian Institute of Science. I'm the convener of an organization or center called Longevity India. This is center which we started about a couple of years back, and we have key stakeholders, which include scientists like us from Indian Institute of Science and many institutes, clinicians. DICON is a partner, hopefully, in this initiative. We have policymakers, and we have a lot of industry engagement. The idea is that only when we have all these 4 pillars checked in, we can address an issue like longevity or healthy aging or health span in the right way. So we want to look at biological markers of aging, and that's what she talked about. All the clocks, all the markers of aging are based on Western data. And India being the largest populated country in the world, we really don't have India's baseline data to understand aging. And that's what we're trying to do. So as I said, we have 4 pillars, and there are few major initiatives we have started. Our study is called the Bharat study. It's an acronym which stands for Biomarkers for Healthy Aging, Resilience, Adversity, and Transition. That's pretty much what summarizes what changes happens in our body when we get old. There is health, there is resilience, there is adversity, and there's transition, especially for women in various stages of their life. And what we're trying to do is, I'll touch upon in the next slide, but this is a very initiative where we collect about 2 million data points per person to build a blue book for Indian in terms of how they get old. The second project is called Copycat, where we're making models for aging, where we study specific organs of aging. You know, we talked about which organ is acceleraged. I don't even know how to find that at accelerage. So we're trying to create that models in our lab by using advanced 3D model system, bioprinting, and we get this aging models, and we collect signatures from them and trace them back to the human body. Then we have something which is very, very favorite to me, and we call it the grandma therapeutics. The traditional Indian knowledge is rich. I mean, yesterday, the last talk was wonderful because we have a lot of history in this India where we actually address longevity from multiple dimensions, philosophical and physiological both. So there's a lot of information. We talk about Ayurveda, we talk about therapeutics which is coming from nature. But the Ayurveda was at the domain of the king and the riches. The poor man had domain which is just the plants. So where does this plant therapeutics or botanicals work? We are actually trying to use that as a molecules, and we examine them in our copycat models to see which can have some therapeutic implication, along with our traditional, the small molecule inhibitor, which we're very fond of. Then we have a very large outreach channel. We run webinars, podcasts, newsletters, meetings, and collaborations. We are quite open to talk to everybody who wants to join this ecosystem. And this is our key study called the Bharat study. In this study, we collect almost 2 million data points per person, which is a big challenge because these are healthy people we are looking into. They don't come to hospitals. We have to reach out and find them. So we have a rural team which goes out to various parts in the country and collects samples. Now, to collect the data from these samples, we have to maintain data, the sample sanctity. You cannot just take the sample and put it in the pocket and start analyzing next day. So we have 30 minutes window of collecting these samples and processing them. So we deploy our team on the field. Within 30 minutes, samples is in liquid nitrogen, and we process them on-site in IISc. So there's a lot of data sets which we collect. The idea is using that information to develop multiple aging clocks for India. And again, we are looking for support for our mission. We are looking to clinicians to help us, give us sampling and data collection support. A lot of interesting ways. These QR codes will give you all the information. And we are also open to a lot of engagement with anybody who's interested in this space. And I'll stop here. And we work with a lot of collaborators. We've been funded by ICMR. We are a Center for Advanced Research backed by ICMR. All the data which we generate will go into public domain. It will be under something called Federated and Responsible Data Sharing Platform. We will allow people to access this data, develop new clocks, new intervention, new diagnostics. That's where we are headed. So I'll stop here and I'm open to take any questions. Thank you.
Thank you, sir. Thank you for the elegant talk on the mitochondrial health, sir. Thank you very much. We have the question at the end of the session, sir.
Sure, thank you.
Friends, next we move on to the nutrient-stimulated hormones, whether these hormones are brings the elixir for the longevity. For that, we have our own mentor, Professor Krishna Shastri.
20.
Over to you, sir.
Can I have the slides, please? Thank you. I'm actually a fill-in speaker because originally I had Deep doing this talk, doing a slightly different talk, but then when the thing opened up, I thought, let me give a talk. And it's morely a hypothesis-stimulating talk than, a lot of data. There'll be some animal data that is put in. And one of the reasons I have Dr. Mohan parked in the front chair is because I thought this could lead to something where we can have more discussions on. Okay, how many of you, what do you think is the ideal lifespan? What do you think is the ideal lifespan? How many of you have ideas about this? How long should we live? Somebody says 125. 60. 100. Okay. Okay. So Albus Dumbledore used to say longevity is a curse. But it's very interesting that Western science doesn't talk about what is the ideal lifespan of an individual. We've talked about so many things. We talk about curing diseases, preventing progression of disease. But all of science, and Deepak may correct me wrong, but there is not a single publication that says this is the ideal lifespan of. But you find that in Ayurveda. You find it in the Vedic blessing, tells two interesting ones. So, in the daily prayers that is done to the sun, to the Parabrahma and the Savitra Mandala, it says, Paschema Sharadashadam, Jivena Sharadashadam, Nandam Sharadashadam, Bhavam Sharadashadam, Shrinvan Sharadashadam. It says, let us live to see 100 autumns. Let us listen to each other for 100 autumns. Let us move together for 100 autumns. Let us see each other for 100 autumns. Let us live happily for 100 autumns. So, when they talk about it, so remember, it's not just living, they're talking about living well for 100 years. So, if you look at the Ayurvedic textbooks, they clearly talk about the Shatam as this thing. So, this is another story I want you to know. This is a story of how we got to be long. So actually, we didn't have this kind of longevity, right? So we were given 20 years to be a man, to be happy, to be a child, to enjoy ourselves. But then a donkey was given 60 years and it said, look, I don't want 60 years, just give me 30 years because I don't want to be carrying weights all my life. So man said, give it to me, so for next 30 years is a donkey. He carries the burden of his family, heavy works and this thing. Then the dog said, you give me 30 years, I don't want to be guarding a house for 30 years, give me, I don't want it, you take it back. And man told God, give me that 15. So after his 50th year, he's sitting in the Tinnai and guarding the house. The last 10 years, and this is a change from the Aesop's fable. So he becomes a monkey, going from one child's house to another, moving all the way. So just in the lighter vein, this is the duration of life. But why this talk? Very interestingly, last year, suddenly there was this particular talk about are GLP-1s the first longevity drugs? Now we've heard about elixirs of life right from DHEA sulfate to melatonin, all of that. But for the first time, we have people coming and talking about a longevity drug. So is this just one more flash in the pan? I thought we'll use this, but also to build some hypothesis on NASH rather than GLP-1. So remember that in the last 100 years, our life expectancy has climbed. Somewhere around 30 to 50 in the early 50s. Even in India, if you look at the South Asia, we've gone way past 65. But the important thing to understand that lifespan is not health span. That being 90 is fine, but being 90 and then being dependent and incontinent and bedridden is not what we really look for. So that's very important. So all of you heard about Amrita, right? Amrita means Amrita, without death. But when the Devas took Amrita, they also got youth back. So what exactly is a longevity drug? Is there a definition when you say longevity? So a longevity drug targets at least one aging pathway, is capable of treating or preventing multiple age-related diseases, and thereby improves lifespan. So when it comes to the GLP-1s and the incretin or the NASH-based therapeutics, we know that it prevents multiple age-related diseases, cardiovascular disease, it prevents progression of renal disease, it reduces arthritis, so that part is thing. But the second question is, does it target aging pathways? So I'm going to go back to the first slide that Jayashree showed and Deepak showed, that from the late 90s we've been talking about the hallmarks of aging. I think now we have 14 hallmarks. But this is pretty much this is a seminal article in 2013 that published that talks about these hallmarks, that you're unable to repair the DNA, that your telomeres get shortening, there are epigenetic alterations, you're unable to fold your protein, your cells are not able to eat themselves back and get out of circulation, you can't sense, intercellular signaling is lost, mitochondrial dysfunction is there, and of course the stem cell exhaustion and a whole bunch of other things. So do NASH hormones target aging pathways? I'm just going to run through it, but remember, the top one is cellular studies, the middle one is animal studies and human studies. We clearly know that at this point of time, the NASH hormones actually work through the P53 and the P16RB pathways, and therefore seem to, at least in the thing, impairs DNA repair, restore DNA pathways, and from clinical pathways, we know at least that they seem to be reducing neurofibrillary tangles, improving motor outcomes, which are all hallmarks of glial neurorepair. So some data there. They also, liraglutide especially, and I'm not taking it as sema this thing, it's just a whole bunch, seems to increase telomerase activity. It's translocation to the and what it does is it translocates the telomerase to the nucleus, and therefore prevents shortening of telomeres. And then seems to protect telomere length. And in humans, we know that when you improve insulin sensitivity, there is a change in telomerase activity. There are epigenetic modifications that are very, very well known. I'll come to it because I'm going to show some more data on this. And interestingly, and yesterday I talked about it, that they actually work at the AMPK-mTOR pathway, and very interestingly, in older mice, and I'll show you data on older mice because it's very, very interesting how it changes between older and younger mice, that these transcriptomic signatures are changed, and there is a change in the autophagy. And of course, markers of protein misfolding like amyloid, beta tau are all reduced in human studies. He's talked about mitochondrial dysfunction, but these seem to work through the PINK1 pathway and all the others. It also reduces inflammatory markers. There are signs, at least in the animal studies, that it reduces senescence markers. Now, Deepak mentioned it, And I'm going to tell you that there has been no model, no drug that has shown as much promise as caloric restriction in longevity and aging. This is because of multiple reasons. Sirtuin, mTOR, AMPK, and PPARs, but interestingly, except mTOR, we've not been able to even pharmacology exploit it. A lot of money was spent on creating a sirtuin-based molecule. I keep forgetting the company spent billions on acquiring it, failed miserably. But rapamycin, which is an mTOR-based drug, is still around, and in many ways, while we will never see rapamycin as a longevity product, becomes a prototype for how we want longevity drugs to work. But to tell you, to go back to caloric restriction, if you restrict calories, you move from a plenty to a poverty mode. Instead of wanting fertility, the cell decides, I need to conserve myself. Autophagy improves, mitophagy improves, so there's a switch that occurs. In yeast, in C. elegans, in mice, we clearly know that caloric restriction is one of the best ways to improve longevity. In humans, we don't have longevity data, but many people who lose weight by caloric restriction feel better. The prototype, as I said, is rapamycin, and seems to work by two different pathways. One is the ULK1 pathway and the mTOR pathway. We know a lot about the mTOR pathway, a little less about the ULK pathway, but the ULK1 pathway is the one that mediates autophagy. And therefore, this is one of the key ways to judge a longevity drug. Does it work like rapamycin, or does it work by other pathways, right? I'm not going into details. Remember, this is a hypothesis generation talk, but just for us to set the context and understand. And you will realize that caloric restriction and rapamycin both work by similar but also distinct pathways. So there are multiple pathways to it. Caloric restriction is the gold standard for this whole thing. Rapamycin seems to do a lot of other things, especially in the mTOR pathway, and they both have significantly similar as well as distinct pathways. Now, I'm going to take one trial, and I think yesterday A.K. Singh talked about it, but something very interesting that I will tease out just one part of it. In the SELECT trial, you would see that the benefit of the GLP-1 RAs accrued much before significant weight loss. If you look at the 20th week, significant cardiovascular benefit. Now, the only correlation that you could find was the reduction in waist was significantly large at week 20, meaning that waist loss precedes weight loss as a cause of cardiovascular benefit. But that could explain only a third of the CV benefit seen at this early time, which means that there are off-target benefits other than pure weight loss or even waist loss that seem to explain the benefit. Remember, aging drug is two parts. One is it should act on longevity pathways, which I told you, but it also prevent progression. And I'm adding that irrespective of whether you're losing weight or not. Because then you'll say, okay, it's because of calorie restriction. No. We seem to have an off-target that specifically works without weight loss. Indeed, if you give GLP-1 RA to aging mice, interestingly, remember everybody talks about sarcopenia. I believe that there is a differential effect on sarcopenia in GLP-1 RA. In younger people, it doesn't have any effect on it. The muscle loss is probably not arrested, but in older people, in older mice, there is subsequent interesting data show that the forearm strength actually improves. It doesn't worsen, it improves. Body strength improves in aging mice on GLP-1 RAs. I'm not going to explain each of this, but just it's a trust me bro slide, because if I go into these slides, then we spend a lot of time. The second thing, on the other hand, in a young adult mice, not really significant improvement in forearm limb strength. So remember yesterday I was talking about that the NUSH hormones and incretin hormones, and we've seen that with the DPP4 inhibitors also, that they seem to work on damaged cells a lot better than non-damaged cells. For example, when we did work on sitagliptin, it worked much better in the elderly. It works much better in places where beta cell dysfunction is there. Incretins are exactly the same. So they seem to do better when there is cellular dysfunction rather than in healthy cells, right? So, and this just tells you the same thing, and this just shows the age-related transformed regulation, but importantly, the epigenetic changes are also reduced, meaning the HTAG, it's a metabolome, all these, in multiple tissues you will find these things are changing. And even here, and I won't go into the exact details, just to tell you that there are distinct pathways and there are shared pathways with rapamycin as well as in color. Of course, the jump from animals to humans is huge. Don't go by this, but these are interesting observations to understand. Now, remember yesterday I talked about the vagus. This is the big part. If you knock off the hypothalamus, all of these effects are attenuated, meaning that these are centrally mediated, that whether you like it or not, that even aging is not just a cellular, peripheral, uncontrolled process. Your brain actually tells you to get old and die. That's a leap, but this seems to be pointing out there. And these seem to be mediated by NUSH hormones. Before I move on to just a little bit, one of the hallmarks of aging is slow replacement of your cells by mesenchymes. This is called the mesenchymal drift. And since 2006, we know that you can partially reprogram the mesenchymes and reverse aging. These are called the Yamanaka factors. These are these 4 factors. And if you're able to induce the Yamanaka factors, you can reverse this mesenchymal drift. And that's possible and people do it. And we now know that the GLP-1 RAs seem to work in tandem with mesenchymal cells. Interestingly, this particular study, which I'm showing you a picture of, is actually enhancement of stem cell activity by mixing, giving GLP-1 RAs along with the mesenchymal cells and improving pancreatic beta cells, improving the others. So they do work hand in hand. Whether they reverse mesenchymal shift, that's another question for another research another day. Which brings me to the last part of my talk where I want to bring these things together. We think we are one person. But this is just a shell inhabited by a few billion or trillion microorganisms that's part of a larger continuum. They have a mind of their own. You inherit them from your mother and her mother and her mother. And they decide what goes in, how well you're nourished and how well you're maintained. And interestingly, a lot of data is coming out on the alteration in the gut microbiota and how long you live. There are some of these, and I'll come in the next one, that there are some that are markers of longevity, that remember that they normally shift as you age, but also in people who age a little faster, or whose biological age is much more than their chronological age, there are some that are dysbiosed. In fact, if you look at extremely long-lived persons, there seem to be some specific gut microbiome. For example, Akkermansia is the one that is very important when you take high-fiber diets. But this one, this Christianella, is a particularly found in people who live past 100. Whether it decides, okay, I've come, you're 100 now, let me make my appearance, or is it a marker for extreme longevity, nobody knows. But these are found. Associations are not causality, but remember again, this is a hypothesis generation talk. It is not a causality talk. The last part, which many people don't talk about is, and especially the Instagrammers who think age is a number, is that nature sets 2 or 3 points to kick you out. First is towards the end of your reproductive utility at 40, there's a rapid loss of there's an increase in cell senescence. The second is at 60. That's why you find these two distinct parts, and this has been well shown. Please look at this particular article, fantastic. But what I want to show you is not the other thing, the transcriptome change, the proteomics change, the metabolomics change. But I just want you to see that the microbiome actually changes. That the microbiome undergoes distinct age-related changes at these very 3 parts. And it is so striking that you can't say, well, maybe this is happening right there. And not, you could say, okay, it's just an impact of aging on the gut microbiota. But is it possible that the gut microbiota are actually part of the aging process? Why am I saying this? Now, I said that GLP-1 seem to be potential longevity agents. And guess how the microbiome works? This is the intestine. These are the gut hormones. They work to 3 parts. One is HDAC, which is the epigenetic pathway. The TLRs, which is the lipopolysaccharide inflammation pathway. And the FXR, which is basically the bile salt pathway. And then this is how they stimulate the NASH hormones. In each of these places, the microbiome that is present is capable of stimulating GLP-1, PYY, CPK, every one of these hormones. Fair enough? So at each of these places, the gut hormones, through their short-chain fatty acids, to LPS, to fatty acids, actually work through the center through modification of nutrient-stimulated hormones. And therefore, it's quite possible that maintaining a healthy gut is an important part of longevity. Interestingly, in animal studies, when you take the fecal microbiota of young animals and put it into older animals, there seems to be a reversal of the aging process. So clearly, the gut-brain axis. So I said the brain, when you do a hypothalamic knockout, the GLP-1R effects on the aging comes off. And when you add young people's fecus into in animals, you find a restoration of or a slight reversal of the aging process. So clearly, this gut-brain cellular axis is very, very important. To close up, I'm sure all of you know about these blue zones. Okinawa, Sardinia, Icaria, Nova, Costa Rica, Loma Linda, where people live longer. I'm going to put this all together, and I want you to bring this particular part, that the microbiome is also related to the soil that is there. The soil microbiome is an important part of this whole story. What you eat, what we locally source. The guys who did this thing, which is Buenent et al., who initially did this as a project for National Geographic, tell you that most of us live within a 4-kilometer radius of where we are born. Most of us. I came back to a 4-kilometer radius, I'm sure. Jayashree did. A few of us here, there. All of us, at least we live within 40 kilometers of where we are born. Many of us. That it's like salmon, it pulls us back. So the important thing is, if the soil, the food, the freshness, the seasons of where you're born, all contribute to your height. And I'm telling you that the food we eat, hypothesis, influences the bacteria that are there. The bacteria that are there influence the hormones that send the signals to the brain. And the brain that we have, through the hypothalamus, signals our cells partially, not completely, how long we live. With that, while Western medicine has always focused on disease, this is the third stanza after in Ashtanga Hridaya, which is the classical Ayurvedic text. It says, Ayuh kamayena dharmartha sukha sadhanam Ayurvedopadeshu videha paramadha. Meaning, if you want a long life, and the reason for long life is because it is the vehicle for dharma, artha and kama and sukha, right? Follow the tenets that have been laid on the study of life. That is why it's Ayurveda. And how you live influence how we die, right? So ultimately, it's our soil, where we are, what we eat and how we live. So just a hypothesis generation, but I think we should study this a little more. Thank you so much.
Thank you, Krishna. I think we have questions for one question each. Sure. Allow 3 questions, 1 question to each speaker. I request the speakers to come onto the stage.
Friends, any questions from the floor?
Sir, good morning, sir. Sir, my question is to Deepak, sir. Sir, we were doing on the cognitive research with Mayo Clinic with Florida. There we were looking for the TIM40. We were not looking for the TIM50. They were looking for the TIM40, and where we used to collect the blood sample, and they used to prefer my investigator, he preferred me to look in the platelet thing, because it doesn't have any nucleus and it has mitochondria, and this subset of patient we used to take for PET scan. And your thoughts on TIM40, sir?
So I think the granularity of molecule was not the point in my talk.
Okay, sorry.
See, one of the main things which you realize is we access blood to do all our analysis, given that it's connecting everything. And we use blood cell for all the clock making, epigenetic, clocks and so on and so forth. But that does not give you any handle about which tissue is actually dysfunctional.
Yes, sir.
That's a fundamental flaw in a lot of our cellular-based blood marker. Telomere theory is very popular.
Sir.
The interesting part is that telomerase saturation does not take place in differentiated cells. So if it doesn't take place in differentiated cells, how can it drive aging?
Yes, sir.
So we have actually found an inverse correlation of telomerase length in multiple populations and elderly. So
Yes,
some
sir.
old people have longer telomeres.
Yes, sir.
So it doesn't make sense. So there's, given to your question, TIM, it could be TIM40, it could be TIM50, it all depends on what question you are asking. So we were looking at molecule with mitochondria which changes with
Sir.
age, and that's how we landed with TIM40. That's the 50.
We were looking in Alzheimer's disease, sir.
Yes, so it's complete. Any molecule which affects mitochondrial function will have the same impact. It's like a systemic change.
Thank you so much, sir.
Jayashree ma'am,
Yeah.
coming here. Madam,
Krishna sir, gut microbial transplantation in healthy adult has already been started due to antibiotic resistance and gut dysbiosis. It has been started in GI people. They are doing it just to prevent the antibiotic resistant.
Yes, ma'am. See, we have been, after the advent of Alzheimer's, actually we have been knowing a lot more about APOE genes and with aging. And I don't know about these pathways going to this, whether it is Citwin or mTOR. mTOR is usually mostly with the fasting and calorie restriction. And in fact, rapamycin was accidentally invented when they were going in search of the blue zones. So there was also a clash about taking metformin for longevity, and it was been having contradictory statements with regards to that. And I don't know, sir, it's a question to Dr. Deepak, sir, whether the studies you have been mentioning has been done as in vitro studies or in the human studies also.
So the molecule studies?
Yes, sir.
I think there's enough data from cell, from animal systems to human.
Okay.
Especially for all the things, you talk about metformin off-label use for longevity.
Yes.
The effect is not very clean.
Okay.
It's actually a mixed bag. As I said,
Yeah.
the problem could be simply the ratio of aged versus non-aged cells in our body. Because a non-aged cell react differently versus the aged cell. And that ratio will dictate how the molecule is going to behave.
Okay. Yeah.
So I think when you start early, it starts showing good signs and you start assuming this is an anti-aging drug.
Okay.
But in the aging system, it actually has a different manifestation. So that is a challenge which we have right now. We've been looking at aging from one lens that it is young. But the lens says that there are multiple states. I mean, as you talk about in the traditional knowledge, we know there are multiple states of the system. And
Yes.
that is a challenge to understand.
Yes.
Which body, which organ, which cell is in which state.
Specific, okay. And with Dr. Krishna Seshatri, sir,
Krishna.
the incredible incretins, of course, from K and L cells from the ileum and the duodenum, And I would like to know that is there any direct link found with the microbiome change and aging?
Yeah, absolutely.
You've been mentioning.
So
right?
there is one, the microbiome changes as we age. That is well known. Now, are these contributing to the aging process is a question that we need to ask. Second, in accelerated aging, is there a greater change? Because there is inflammation, there is LPS and the thing. The fourth is, can you modify these microbiome? For example, I showed Cristanella as a extreme longevity marker. Okay, if you replace the microbiome with some of these, Akkermansia, the best way to get Akkermansia, eat a high fiber diet. But let's say we create a situation where Cristanella is there, can we reduce aging? We don't know.
Definitely.
Remember also that even when you do a fecal microbiome transplant, and then you go have McDonald's and cheese fries, and these are going to die.
Yes.
So this will only be temporizing. The ultimate way is to eat what your grandmother and her grandmother and her grandmother ate.
And the fecal transplant has been one of the proven way. Yeah.
So I'll actually answer this. This is something which we are doing right now with the Indian population. As I said, we get a lot of population from rural. Urban gut is bad gut. It's a Swiggy, Zomato gut. It's not the real gut. But what we are finding very interesting is our gut biome is very tight when we are young. The diversity increases as we get older. And when you get super older, the diversity comes down again. So it's a very interesting biphasic response. And that captures, so interestingly, we say fix thy gut, fix thyself, or fix thy health.
Very true.
And it's very true because our gut is at a stable state with what my physiology is. You can say change the gut, it will change the physiology. Well, it goes. If change your physiology, you change your gut. So you cannot just implement one change. You have to change both the processes.
Sure.
And
Centenarians seem to have a more diverse gut than someone who's this thing. So clearly, it's not just a sign of aging, but probably diversity is a marker of healthy aging. I think we should stop.
Thank you.
Thank you, sir.
Thank you, sir.
I thank all the three speakers.
Thank you, sir. So I thank the chairperson, Dr. Moses, sir, and Dr. Kannan, and all the three speakers. So moving on from Aging and Longevity Symposia, we'll move on to the potpourri. To chair this session, may invite Dr. Bhuchandran, sir. And we have two excellent speakers, Dr. Bhavana Susle and our stalwart and Professor P. Mogan, sir.
So, good morning, everyone. So, we got two excellent speakers and two interesting topics for discussion. And first, we have Bhavana Sosail. I hope I pronounced it right. She's the director at Diacon Hospital and visiting consultant at Colombo Asia Hospital. And she's quite well known for her course in diabetes, which is well recognized by the medical university. And during today's morning talk, we did have a lot of discussion about GLP-1s and the retinopathy and so forth. So without delay, over to you, Dr. Bhavana.
Good morning to everyone here. I see this, I'm waiting for my slides to come up. I see it on the screen. Could I please have my slides up? All right, so we're going to do an overview of anti-diabetic medications in the eye. So I'll get straight to it. Now, I'm a part of a study which is looking at this, and I'll touch upon that. But again, I'm going to be covering a lot of drugs and not just GLP-1s. So let's start with a poll. Okay, so we have a middle-aged person coming to us, diabetes and obesity, and wants to initiate a popular weight loss drug. Now, what would you do? Would you say an eye exam is necessary before starting a GLP-1? He can see well, so he doesn't need an eye exam. He had an eye exam 1 year ago, and therefore he doesn't need it. And there's no relationship to diabetes medicines and the eye, so why do we need to screen? I think the poll doesn't work, so raise of hands, how many people say he needs an eye exam? So we have a few people, so that's good. So we'll start with that. Now, to set the context, when we think of diabetes and eye, we all think of diabetic retinopathy. And that's what I'm hoping to change today. Now, 1 in 3 individuals with diabetes has diabetic retinopathy, and it's a leading cause for blindness. But these are actual retinal images from our patients who came last year. Now, the first on the left is diabetic retinopathy. There are microaneurysms. The one in the middle, you can see near the macula, there are those whitish spots. This is dry AMD. And the one on the right, there's a large cup to disc ratio. So normal is about 0.3 to 0.4. So this is much bigger than that. So this patient has glaucoma. So the point I'm making is individuals with diabetes have several other sight-threatening ocular diseases. So we have to think beyond just diabetic retinopathy when we think of medications and eye. So today, all of us as physicians, we have this tool available. There is a camera developed by Remedio Innovative Solutions, which is in Bangalore. It's a fundus camera, and it has an AI algorithm called Medio's AI. Now, we were part of several initial studies to develop and validate the AI for DR. The glaucoma AI has been developed at LV Prasad at Hyderabad, and the AMD AI has been developed at Arvind Eye Hospitals. So now you take a retinal image of a person, you run the AI on it, you get a diagnosis for 3 different eye conditions. So we decided to see what are we looking at in our patients, and we screened our patients using the AI. We presented this last year at the IDF in Bangkok, and what we found was that 37% of our patients walking in to see us every day have referable diabetic retinopathy. But they also had other things. They also had glaucoma, they also had AMD. So which means that when you look at overall ocular diseases, 50%. So if you had all patients coming to see me tomorrow, half of you are going to have some form of eye disease. And if you think of that on a large scale, that's a big number that 1 out of 2 individuals has some form of eye diseases. So keeping that in mind, why is it that this is not given importance when we think of starting medication? So we first need to know a few things. What is the effect of aggressive glycemic control? What are the long-term benefits of good glycemic control? Risk versus benefit of different eye medications. And then I will say, when you think of diabetes and eye, it's not just what you read in the news. It's not neon or it's not DR. It's a lot of other things. It's glaucoma, it's cataract, it's neon also, it's refractive error, it's AMD, and of course diabetic retinopathy. So we need to think of the eye as an entire organ which has other things other than just DR. So what happens when we screen, so when we treat diabetes very aggressively, there's actually some ischemia in the retinal tissue. This increases VEGF, that causes more new vessel formation, and this leaks and there's vitreous hemorrhage. Now this could happen potentially with 2 classes of agents, insulin, and today also with GLP-1 based molecules, because there's a rapid glycemic control, and that's actually the first problem. But if the glycemic control is slow, it's durable, it happens over a period of time, there is a definite benefit, and this has been seen in several studies like UKPDS, DCCT, Accord-I, and Advance. But it's not just DR outcomes that improve. There's a reduced risk of cataract, reduced risk of neovascular glaucoma, reduced risk of RVO, retinal vein occlusions, and as the duration of control improves, there's also a benefit that sustains over time, and there is a legacy effect. There is a minor change in the refraction when the blood glucose goes up. So someone with high sugars, the retinal image is going to be formed in front of the retina, so there's a myopic shift, and then we treat the blood sugars, and the blood sugars start to stabilize and come down, and there's a hyperopic shift. So the image is formed behind the retina. And the patient may come back and tell us that they're actually having blurring of vision, but their sugars are getting better. So we need to know, when is this actually a red warning flag that I need to send the patient back to the ophthalmologist, or is it just the refraction changing because of better glycemic control? So we'll now move to individual classes of drugs. When we think of insulin, overall insulin is good. Better control, long duration, better eye outcomes. There's also a lower incidence of cataract development when diabetes is well controlled. So the only thing to remember is that very rapid glycemic correction, it can cause early worsening of retinopathy, and this is possible with insulin. However, we still use insulin. It's safe to use even in people with diabetic retinopathy. Maybe just go slower and control a little bit slowly. The next class of drugs is TZDs. Now, TZDs are good overall anti-hyperglycemic agents. They are also showing some benefit in MAFL and therefore it's used. However, there is one red flag here, and that is macular edema. Now, this was not seen even with the larger RCTs like Proactive, but this has been seen in several observational studies that there's an increased risk of macular edema because of fluid collection in the retina. Now, who are the patients at risk? People with pre-existing macular edema who have been treated in the past, or people with poor legacy, very high sugars, long duration of diabetes, insulin, CKD, heart failure, and in several of these cases, we actually don't use pioglitazone. So just keep that in mind that when you use inappropriately, also that may be causing macular edema. So if someone does develop macular edema, what do we do? Stop the TZD, send them to an ophthalmologist, get the eye treated, use other therapy for diabetes. Metformin, largely no red flags, it's safe. Better glycemic control, better eye outcomes for diabetic retinopathy, but also has other benefits. It reduces the risk of wet AMD, protects against retinal vascular occlusions, reduces the risk of open angle glaucoma, and development of cataract, and also post-cataract surgery opacification is lower with metformin. SUs, overall safe for the eye, no red flags here, better glycemic control, and then better eye outcomes. DPP4s and AGIs, again, nothing much to report, so it's neutral with respect to the eye. So we'll now go to two classes of drugs, which I'm going to focus on more, SGLT2 inhibitors and the GLP-1 based therapies. Now with SGLT2 inhibitors, there were no actual eye-related endpoints in any of the initial studies. But what we learned from EMPA-REG and declettermy was that at least there are no worsening adverse events reported with respect to the eye. Now, subsequently, over a period of time, people have been on these drugs now for about 10 years. And a lot of data is available from retrospective studies and databases analysis, which have shown that individuals who have taken SGLT2 inhibitors compared to other therapies, there is a benefit. And what is the benefit? There's a lower risk of proliferative DR, DME, and also a reduced intervention for vitreoretinal procedures, whether it's anti-VEGF or vitrectomies or just laser, PRPs or focal lasers. Now I'll quote 2-3 of these studies, and there are several more if you go back and look up yourself. Now this was a database study which looked at patients who got SGLT2 versus GLP-1 from 2016 to 19. There was a close to 50% reduction in proliferative retinopathy and need for eye procedures in patients on SGLT2s compared to GLP-1s. Now another study which looked at a larger number of individuals, 68,000 plus, from 2015 to 2025, looked at 3 classes of drugs, SGLT2 versus GLP-1, SGLT2 versus DPP4, and GLP versus DPP4. Now, everything was better in the SGLT arm. Lower open angle glaucoma, lesser ocular hypertension, lesser cataract, lesser diabetic retinopathy, and macular edema. But all the systemic complications were better in the people who took GLP-1 RAs. Lesser nephropathy, lesser liver cirrhosis, lesser dementia, IHD, and stroke. So this is something to keep in mind, that when we choose drugs, there are pluses and minuses of every single agent that we use. A third study, which was done more recently, looked at the differences between people using SGLT2 versus GLP-1, looking at specific eye outcomes, which was risk of PDR or DME at 1 year and 3 years. And there was a lower risk of PDR, DME, and eye interventions with the use of SGLT2 inhibitors at both the 1 year and the 3 year mark. So what do we know for SGLT2s? Safe for the eye, has several benefits, DR and otherwise. No specific retinopathy warnings. We can use it in anyone with diabetic retinopathy or other eye conditions as well. And standard eye monitoring based on what is recommended in usual standard of care eye guidelines. So now we'll move to GLP-1 based therapies. Now SUSTAIN and PIONEER, 2 studies both done with semaglutide, showed that there was an increased risk of retinopathy complication, 3% in the semaglutide arm versus 1.8% in the placebo arm. When they later analyzed the data, it was seen that this progression of complications was actually seen in people with baseline retinopathy. It's important to note that in most studies on GLP-1s, people with active retinopathy who require laser anti-VEGF treatment are actually excluded. Now, one of the studies that Novo is currently doing is the FOCUS study, which is looking at the long-term effects of semaglutide compared to a placebo arm. This is a phase 3 trial and on retinopathy outcomes. So we are a center, Diacon is a center, Dr. Mohan is also a center for the FOCUS study. This will probably end next year, and we will know what happens in the SEMA versus placebo arm with respect to DR outcomes. But why the higher risk? Rapid glycemic control, VEGF surge, this is the hypothesis. Faster A1C reduction, the second reason, and maybe altered retinal blood flow. Now, it's also important to say that some of these are reported in the previous studies, but they were not eye outcome-based studies. So we'll have to wait for the FOCUS result to come out. None of these associations have been reported with tirzepatide. However, we need to extend the same degree of caution irrespective of which GLP-1 based therapy we are using. So what is actually recommended? So someone who wants to start one of these newer medications, get an eye exam, PDR or DME requiring treatment, don't use these drugs, use other classes of drugs to treat diabetes, and then send them to an eye doctor, and the retinal specialist should be able to treat this. No DR, standard monitoring every year. Mild NPDR every 6 months. Now, moderate to severe NPDR, this is where we don't have a guideline. Now, this is the gap for us between guideline and practice, where we don't actually know what to do. Now, the standard guidelines for eye for monitoring for moderate to severe NPDR says you monitor every 3 to 4 months. And if it's stable, the ophthalmologist, even for moderate NPDR, will say every 6 months. But we know early worsening phenomenon can occur. We know A1C is rapidly going to fall. So there are going to be some changes that maybe we have to inculcate, and these guidelines will evolve. So should we monitor every month until the dose is fixed, until we escalate the GLP-1? Should we then monitor every 3 to 4 months only once the dose is stable? Now, this is something for us to discuss with our individual ophthalmologists whom we work with, and we actually prefer to monitor more frequently. So how do we mitigate adverse events? So treat active retinopathy, use other agents. Wait for at least 6 months before you think of using GLP-1 therapies. Start at the lowest dose. Be more realistic when it comes to A1C, weight control. Monitor the eye more frequently than what is recommended. Don't need to titrate every 4 weeks just because a trial did that. We could do it every 8 weeks, every 12 weeks, and have better expectations and look at the patient as a whole. Now, there are also some reports of NEON with GLP-1 based therapy with semaglutide, but the absolute risk is low. The common risk factors for developing this are what most of our patients have. They're elderly, they smoke, they have hypertension, they have diabetes, dyslipidemia. One of the things to note is the anatomical changes seen as actually the presence of drusen's and a small cup disc ratio. So these are things that we as physicians have to look out for before starting therapy when we get an eye report. It's not just no DR and now I can start a patient on this therapy. We actually need to go back into eye anatomy and see if these things are being reported by our retinal colleagues when we actually want to start these molecules for our patients. Now, it's not just negatives. There are some positives of GLP-1s on the eye as well. There's actually a protective effect on the retinal ganglion cells, and several studies have shown that there's a close to 30% reduction in the incidence of glaucoma with GLP-1 therapies compared to other drugs. And there's also a reduced risk of dry AMD, but some studies have reported wet AMD going up, so that's a little bit conflicting. So what do we do with this information when we go back to see patients? Always get an eye exam. So that's the first thing. No new drug without an eye exam. Now you want to start GLP-1 therapy, someone with maybe mild to moderate non-proliferative retinopathy, do they need the therapy is the first question. Is it the CV risk that's high, or do they need to lose weight? Assess individual risk-benefit ratio. Consider closer eye monitoring with your ophthalmologist, because your eye doctor is going to say review at 6 months. Your patient will ask you, why are you asking me to review more frequently? So discuss that and have some guideline at your center. So there could be an early worsening phenomenon. Make sure the patient knows when to come back to you, when to seek care, and consider these things before you start any anti-diabetic drug actually. So the takeaway today is uncontrolled diabetes is going to be the biggest risk, and regular eye exams are a part of routine care. Now, if we all have an access to an ophthalmologist in the hospital we're working with, we get a report before we give our prescription out, that would be excellent. Now, if you do not have that, we have a screening tool. We have the Remedio FOP. It has the AI. It can run on any retinal image and give you the output for 3 conditions, so DR, AMD, and glaucoma. And it also tells us these things which I've highlighted there, like the cup disc ratio. So anything that's low and you think maybe it's a risk for neon, don't use GLP-1. So we need to start looking at the eye report more comprehensively, rather than the patient coming back with a letter from the ophthalmologist saying, this is okay, or, non-proliferative DR and review after 6 months. So that's not enough for us to treat diabetes anymore. So never start an anti-diabetic medication, and especially a weight loss medication, without an actual eye exam. So a few years ago, when I would talk about DR and AI and eye screening, my slide was a little different. It said if the physician does not screen for diabetic retinopathy, our patient will go blind. But now with all these newer therapies and so much more that we have to think about, the effect on glaucoma, AMD, several other things, we need to really remember that we have to also think beyond diabetic retinopathy. So if we do not screen our patients for ocular diseases before starting therapy and during monitoring, it's likely that some of our patients are going to go blind. So with that, thank you.
Thank you so much, Dr. Bhavna. Next, we'll take the questions at the end. We have Professor V. Mohan with us, who's going to talk all about saroglitazar. And I don't think he needs much introduction, as I can see from the claps, but still, he's the chairman of Dr. Mohan's Diabetes Specialty Center, chairman of Madras Diabetes Research Foundation, and has got a lot of publications, original articles to his name. And over to you, Dr. Mohan.
Thank you very much. At the outset, I'd like to thank Krishna Sheshadri, Bhavna, and Arvind and the whole team, for Rohit and the whole team for inviting me to be here. It's always a pleasure to come back to this meeting because it is so academic. So I'm going to give 2 talks today, almost back to back. And so this one is a company-sponsored talk. It's on saroglitazar, and I'd like to thank Zydus for the opportunity to talk on this molecule. The reason I am personally attached to this molecule is because we did some original research with this molecule, and also because it's an Indian-made molecule. The very few molecules which actually come from India. If you think about it, for years and years and years, pharma has been working on it, and here is one drug completely made in India, which seems to work. So those are my financial disclosures, and this talk is sponsored by Zydus. So first, let's, at any point, I think we have to think of the burden of the problem of diabetes in India, not just diabetes, but also all the metabolic NCDs in India. And if you consider that from the ICMR INDIAB study, you can see the numbers are not small. When you have a country with 1.45 or 546 billion people, the largest country in the world now, it's not surprising that we have over 100 million people with diabetes, 136 million people with pre-diabetes. And we take obesity, abdominal obesity, it's 351 million people. That's more than the United States whole population, the number of people with obesity in India, and that's growing. We just have some recent data, unpublished, we're going to publish it now, where we looked at INDIAB 10-year follow-up. So we've looked at 2 states, Tamil Nadu and Arunachal Pradesh. And we chose those because they were the first states we studied. And at that time, 10, 12 years ago, Tamil Nadu in that 5 states had the highest prevalence, and Arunachal Pradesh the lowest prevalence. So we took the state with the lowest prevalence, the highest prevalence, and re-evaluated them after 10 years. Diabetes has doubled in Tamil Nadu, from 14% urban to 28% of urban Tamil Nadu now has diabetes. And it's not Chennai. All the smaller towns are also included. And even Arunachal Pradesh, where some 5% has become 10% now. So the doubling is occurring there also, but at a slower pace than what's happening here. Abdominal obesity and obesity is also doubled. Hypertension has gone up. Everything has gone up. And guess what? The control of diabetes actually worsened in 10 years' time. We have less people who are controlled now in a state like Tamil Nadu, which we think is the best in the country. Even there, the control of diabetes actually worsened. And in Arunachal also, it has worsened. So we are not doing well. We have all these conferences, but we are not actually delivering to the people. We just keep talking. And then the ICMR DG, when he heard the results, he was very angry. I said, why are you angry with me? I'm only telling you the results. I'm not responsible for the whole country going bad. I'm not the bad man who has done this. We all have to collectively take responsibility for this. So, and a lot of it has to do with diet. We already had some discussions this morning, and every time we come back to the same thing. But here is data, and this is published in Nature Medicine, one of the topmost journals in the world, where the entire data of diet in the country was correlated to metabolic disease. Everywhere in the country you go, whether it's north, south, east, west, it's all carbs, carbs, carbs. The type of carbs may vary, wheat in the north and west, and rice in the east and south and northeast. But almost 65% of calories coming from carbs. And you can see that if you take newly diagnosed diabetes, newly diagnosed pre-diabetes, centralized obesity, generalized obesity, you just plot the carbs, and this is for the whole country, for whole India, you can see that there is an increase. So what we proposed in this study, we did substitution analysis, we did mathematical modeling, we did all kinds of things. Just 5 to 10% carbohydrate you reduce and replace it with good protein, and you'll be able to kind of blunt the epidemic of diabetes. And we're trying to do RCTs now to actually prove that. Now, insulin resistance syndrome, earlier called insulin resistance syndrome, then metabolic syndrome, and so on. This is a very old study, 2002, where if you look at the overall prevalence of insulin resistance syndrome at that time was only 11%. In Chennai, it's much more now. And this insulin resistance, we know, is the key. Because we talk about obesity, but it's actually the insulin resistant, because there are some forms, very few forms of obesity which are actually healthy. But if you look at the majority of people, 95% of people with obesity, is actually bad. And the core of it is insulin resistance, and I won't go into all the pathways, but if you look at hyperinsulinemia with hyperglycemia, and then if you go into the liver, if you look at various organs in the body, there is damage to all of them, including the heart and the blood vessels, liver, and every aspect of it you can see. And this is, of course, driven by many factors. There are some genetic predisposition, there are environmental factors, and so on. But the core of it is that we should address this insulin resistance. So the burden of diabetic dyslipidemia and MASLD also comes from this. So we know that as Indians we have this atherogenic dyslipidemia. So we have very high triglycerides. I don't know whether you're aware that we have the lowest HDL cholesterol in the whole world. It's not very well known, but if you take any ethnicity, you take Chinese, Japanese, Koreans, white people, black people, you can study people across the world, we have the lowest HDL cholesterol. Now, whether it's genetic or due to the high rice we take or a combination of that, less physical activity, we don't know. But the fact is that we do have. Similarly, if you take triglycerides, we have very high triglycerides. As a nation, we have much higher triglycerides than other nations. And all these, of course, add to metabolic disease. Fatty liver is the new diabetes because there is no talk which is now complete without talking about non-alcoholic fatty liver disease, now called as metabolic dysfunction associated steatotic liver disease. That's quite a mouthful, MASLD. And it's time to break the ice. So we know that MASLD is steatotic liver disease with at least one cardiometabolic risk factors. What we talked about the metabolic syndrome earlier, TG, lower, elevated TG, low HDL, diabetes, hyperglycemia, obesity, and high blood pressure. If you have any one of these along with fatty liver, then it's called as MASLD. Now, this is data which Krishna was also part of, and we were also part of. We looked at the prevalence of hepatic steatosis and fibrosis using FibroScan, recent data published very recently, where we looked at two clinics, his clinic and our clinic, and measured using FibroScan and looked at the hepatic steatosis and fibrosis, and the details of this are given in this paper. And 76% of individuals with type 2 diabetes have hepatic steatosis. So, of all the patients who come to Krishna's clinic or my clinic, 76% of individuals have hepatic steatosis, and almost 28% have fibrosis. Now, steatosis, you can say a little bit of fatty liver, grade 1, but 28.6% having fibrosis as shown by FibroScan. Okay, so these are not small figures. Now, there was another study where we looked at the whole country, where we looked at metabolic dysfunction associated steatotic liver disease. It's called the MAP study, where we looked at, and Shashank Joshi is one of the co-authors there, Arvind is a co-author there, and many other people who are here are also co-authors in this. So if you look at that, now this is not my clinic, it's across all clinics in India, and again very similar results. You can see that MASLD is 68% of all people attending these clinics, and even fibrosis is 33%, we found 28, 29%. So here's an independent study showing that it's almost 33% of people having a raised index of fibrosis. So this is a very similar result. So the burden is not just in South India or somewhere, it's in all parts of India. Now, fatty liver disease doesn't just lead to cirrhosis of the liver, as we thought, or to carcinoma of the liver, adenocarcinoma of the liver, as HCC, as was believed. It has an increased risk of MACE. So just having fat in your liver and fibrosis increases your risk of dying due to heart disease, risk of peripheral artery disease, stroke, cardiac arrest. All these have been shown to be much more in those who have MASLD. The case I'm building up is that it's not something, oh, there's some fatty liver and we leave it. We have to treat it, and we should see what we can do to treat that, because it increases mortality not just through cirrhosis, but in many other ways as well, including atherosclerosis. Now, associations have started talking about this, and this is the EASL, EASD, ASO clinical practice guideline, which emphasize that early screening for MASLD in type 2 diabetes and obesity should be mandatory. They're not saying it can be done, please do it. They're saying it's a mandatory approach. So it's almost become, if you don't do it, you're losing out on something. And then if you have type 2 diabetes or obesity with one risk factor or elevated liver enzymes, they should be considered for risk of fibrosis, because the risk of fibrosis, I'm saying, is 30%. It's not some 1% or 2%, it's significant. 1 in 3 has it. 80% of people have fatty liver and 30% of them have fibrosis. It's no longer justified not to do that. And we've got simple indices like the FIB4 index. Incidentally, we have new data coming out to tell you, nobody has shown this in the world. FIB4, we take one cut point and we use it for everyone. Do you know that FIB4 increases with age? So FIB4 at a 60-year-old, a 70-year-old is not the same as a FIB4 as a 30-year-old. People don't know this. They just take one cut point and say everybody after that should be referred to a hepatologist. No need. If you're 65 years old and you have a FIB4 which is high, it may be normal for you. Did you know that HbA1c goes up with age? We have shown the growth of the HbA1c with age in normal people. Fasting is normal, 2 hours normal, no pre-diabetes, nothing. Just measure the HbA1c, it goes up with age. Even 0.2, 0.3, 0.4. So if you have a 65, 70-year-old person with HbA1c of 6, don't start metformin on them. It's normal. For that person, it's normal. So you should know that there are things which change. So what is normal biology and what is abnormal, we should know. That's why we need population-based data. Now coming to Saraglitazar, this drug was entirely, as I said, discovered in India, and there is data to show. I'll show you whatever data we have. We obviously need more data, but there is data to show that it very well works in diabetic dyslipidemia. There are studies to show that works in MASLD, and in diabetes also there is a lowering of HbA1c. This is a consensus statement which a lot of people in India have been involved in. Very big list of authors, as you can see, and Krishna Sheshadri is also part of this. We've had representation. So we used a Delphi tried to find out consensus within Indian diabetologists. It's not from the gastroenterology. Indian diabetologists, what do they think about MASLD? And for those who are interested, read that, because a lot of things that we agreed as a group. We took a long time to come up with these guidelines, but we have finally done that. So saroglitazar has redefined the treatment of metabolic disorders. As early as 2013, which is 13 years before, it was shown to be effective in diabetic dyslipidemia. And when I first started using it in those with very high triglycerides, I found they work very well. In fact, they work much better than the fibrates. So if you compare with fenofibrate and then you try saroglitazar, the reduction in triglyceride is much more marked with saroglitazar. There's no doubt about that. Type 2 diabetes, later on as an add-on to metformin, it's not a very powerful anti-diabetic drug, but about 0.4, 0.5% reduction in A1C is not bad. And then, of course, we have more recent studies where it has actually been approved by the DCGI for treatment of MASLD. Now, how does it work? Because it's a dual PPAR alpha and gamma agonist. Now, the earlier drugs, balaglitazar, ragaglitazar, which Dr. Reddy's developed, which I was part of, I was on the board at the time, and as part of the development process, Novo was involved in that. Unfortunately, towards the end, when we came to almost the phase 3B trials, they produced bladder cancer, like with all the glitazones and so on. This also resulted in bladder cancer, and therefore it had to be withdrawn. Saroglitazar, so when it first came, our worry was mitogenesis, whether it will produce cancer. Nothing. So far, we have not had any report, not a single report of cancer. So that way, I think it has survived the time. So there it has been shown that it reduces triglyceride and reduces insulin resistance. So it has three roles in diabetic dyslipidemia: as an insulin sensitizer, in A1C reduction, and improving the lipid levels, the triglyceride and the non-HDL. There have been studies, this is an Indian study, which has shown that if you directly measures of insulin sensitivity as measured by two different indices here, you can see a considerable improvement in the insulin sensitivity. Now, insulin sensitivity is opposite of insulin resistance. So, the sensitivity improves, it means that the resistance is going down. That's the other one by resistance is sensitivity. So, you can see that an independent study here showing quite a significant increase in insulin sensitivity. So, you remember the slide which I've told you that insulin resistance is the main problem leading to all these. And here you have a drug where you're reducing that and improving insulin sensitivity. Now, the data, there are 18 clinical trials on 5,824 patients, which have shown that the triglyceride reduction is from 45 to 62%, which means you have a triglyceride of 500, it will come down to below 250. That's a significant reduction. And if you have a triglyceride of 250, it's going to come to 125. It's going to normalize it. The non-HDL comes down. I'm sure Dr. Narsingan, who's sitting here, will agree with that, and I'm sure he'll be very happy because he emphasizes a lot on the non-HDL. And the improvement in liver function, ALT levels come down, and the A1C levels, of course, here it says 0.7 to 1.6%. I would say it's more like 0.4, 0.5% reduction. Now, here is data comparing saroglitazar with the fenofibrate, a multi-center randomized clinical trial, and you can see that reduction, dramatic reduction, and while the fenofibrate after 6 to 8 to 12 weeks slowly goes off, saroglitazar continues to go down. So actually it beats fenofibrate for triglyceride lowering. Which organizations have recommended it? This is the RSSDI 2022 consensus statement on triglyceride reduction, and among the drugs which are listed by the RSSDI, saroglitazar is also included along with fibrates and omega-3 fatty acids. So, as far as fatty liver is concerned, the data that we have is that the ALT-AST enzyme reduction occurs, significant liver fat reduction has been demonstrated, and there is some evidence that even fibrosis can come down. Now, if you compare the reduction in ALT-AST of saroglitazar with UTCA, you can see that actually the effect on ALT-AST is more significant with saroglitazar as compared to UTCA, and in fact it has the effect on the liver fibrosis, 25% improvement, which is not shown with UTCA, and the reduction in liver fat is also not been demonstrated. This is a study, the evidence 2 study, where a reduction in liver fibrosis using a liver biopsy driven study. This is the gold standard where they use liver biopsy, and you can see that there's a decrease in the this is the percentage of patients in whom it decreased, and you can see compared to the placebo where there's a 23% decrease, in saroglitazar there's a 52% decrease. So here is further data. This is from the Amri Hospital in Kolkata, 112 patients with NAFLD, where they have shown significant reduction in liver fibrosis even in compensated cirrhosis patients. So these are patients who have significant increase in the FibroScan, where if you have FibroScan readings of about 20, you should suspect portal hypertension or cirrhosis. So they may not be biopsy proven, but very strong evidence. And we have done some biopsies and they fairly strongly correlate. If you have very high if you have very 5 scores, KPA scores. So here you can see that even in those who have fairly severe fibrosis, there is a reduction in that after using saroglitazar. Here's another study where this was submitted as an abstract, where you can see a change in the liver fibrosis in patients who have followed up to 144 weeks. You can see the liver stiffness measurement LSM coming down from 22 kPa to 10.9 kPa, which is a very significant one. This is the Indian hepatologists group who have reported on this, and they now recommend saroglitazar in fatty liver treatment for minimum of 12 months. So that's one of the things which they are asked, how long you should take it. This group, the liver group, suggests that they should take it for 12 months, and they have also produced some evidence on that. Next question is it safe in those with CKD? There is evidence to show that it is safe even in stage 3 chronic disease. They took patients specifically with CKD and showed that there was no worsening of CKD and the effect still remained the same. So to summarize, we have a lot of diabetes, insulin resistant syndrome, metabolic syndrome in India. Diabetic dyslipidemia is very, very high, and this is correlated with MACE events, and fatty liver is now considered the new diabetes, and saroglitazar is an insulin sensitizer. It's a one-stop solution for diabetic dyslipidemia with proven changes on fatty liver, reduction in A1C, reduction in triglycerides, reduction in liver enzymes, liver fat, liver fibrosis, and you can use it even if you have fairly advanced cases of stage of fibrosis and even if there is CKD. And with that, I would like to thank you. I'll be happy to take questions. Thank you.
Thank you so much, Dr. Mohan. That was an overall excellent view about saroglitazar. Dr. Bhavana, you would like to join us? Yeah. So looks like FibroScan is going to become a routine tool in our screening process, the way fatty livers are going about.
So 2 years ago, World Diabetes Day, every year we try to introduce a new clinic with new activities. So 2024 November, we introduced liver, in the first diabetic clinic to introduce liver screening for everyone. And so we've been using FibroScan, and while the fatty ultrasound, if you have elastography attached to it, also gives you, but still FibroScan is the gold standard. And sometimes you will find that people whom you don't expect at all to have fibrosis and for fatty liver, both are good enough. But for fibrosis, FibroScan is very good. I think first you can start with the FIB4, but I think if you can have the facility, you should do FibroScan in everyone.
36%.
Yeah, so it's not a small number, and different studies showing the same results. It's not just one clinic.
Sir, what was the weight gain? Because it being PPAR gamma, the thing, what was the weight gain which was seen in patients?
Weight gain? There was no weight gain at all. There's no weight gain at all. With the glitazones, you can get weight gain, but since you have the alpha component here, we don't see weight gain at all.
No, because personally when I used it, I gained around 5 kg, stopped it and got back. So,
really?
Yes.
Oh,
I
we have not seen Dr.
I
think the alpha neutralizes that. So that's one of the, that's why we use the combination of both. With pure gamma, yes. With the pioglitazone and other thing, there will be huge weight gain. But even that weight gain, people say it's actually good because it's redistributing the fat. And for NAFLD and MSLD, pioglitazone is now being recommended. So I don't think that weight gain is a bad weight gain. So
Mohan,
Exactly. Yeah, exactly.
Some patients with saroglitazar, within 6 weeks, we are able to get back to the normal level, the TGL.
No.
But for those patients, how long you want to continue that drug?
I don't think there is any. See, there is no serious side effects with saroglitazar. That is one good thing. We are not seeing any serious side effect. Whether it's the effect or not is you can keep on debating, but side effects definitely is not there. So I don't take it off. I keep them on unless there is an indication to stop it. Even in liver disease, you can use it. Chronic kidney disease.
When you will stop it? When the level comes to TGL?
If you stop it, it will come back, no? Because these are not magic drugs. If you stop a statin, doesn't the LDL shoot up? So if you stop this, your triglycerides are going to go up. So same question we are asked with GLP-1. When will you stop? You can't stop. When will you stop insulin? Insulin at least you can, with other drugs you can. When will you stop metformin? When will you stop statin? When will you stop your ACE inhibitor? When will you start? Once you start these drugs, they have to be
These
taken.
questions are put by the patients.
Yeah.
Because they come now.
I know patients ask that, and with GLP they're asking even more. But the sad fact is that all these only work only as long as you take them. There's no question of stopping them. Or for some time you take the effect. I always believe in what is called as legacy effect. And so if we have a legacy effect with glucose, I'm sure there's a legacy effect with weight reduction, there's a legacy effect with blood pressure lowering, with a statin. Suppose 5-10 years you kept the cholesterol under control. Now if you take it off, you should not take it off. But if you take it off, at least another 4-5 years you'll get the effect. Common sense tells you that. Better than not lowering it in the first place, isn't it?
Good morning, sir. Sir, when we are using saroglitazole, any other drugs we should be careful, sir? If
Combination with a statin, you should always be careful, because when you combine, of course, there's no harm in doing it. We use it together also. But when you have a double, anything double that you use, you have to be careful. Just measure the liver function and all that, and just make sure that things are okay. But I don't think there's any contraindication. Is there a contraindication, doctor? I don't think that.
No,
Can combine both. I don't think there's any.
Thank you, sir.
Yeah. Liver function, you just.
Question. All right. Okay.
Can I have a question, Bhupati?
Once we start someone on GLP-1 and then we want to start, we do a screening and then we find retinopathy. Are we justified once we correct the retinopathy, go back on GLP?
Current guidelines actually say for the literature with most of these drugs, anyone with active retinopathy don't start. And once the retinopathy is treated, how long to wait before starting, we actually don't know. So I think in the trials, when we look at inclusion criteria, they say if someone's had active treatment within 6 months, don't include in the trial. So I use that as the logic even for clinical practice. So in the last 6 months, no VEGF, no laser, maybe it's okay. But still we don't know. And I think that's also the point.
Does time allow questions?
Let me ask Bhavna a question. So is there any evidence, because we know that NAION also is one of the problems, and then retinopathy. One of the questions people ask is, are people with retinopathy more prone to, is there any data at all?
No, sir. Not that I have found. No data of that. So that's a different problem. This is a different problem. And retinopathy we see a lot more frequently. 30 to 40% of our patients will have. Neon is a very rare problem.
Two questions, Dr. Mohan, one to Bhavna.
Yes.
Dr. Mohan, one is saroglitazar's renal safety. The data is very sketchy. It's very retrospective data. That one slide which you showed CKD stage 3.
Okay.
I've looked into it.
But
I haven't
is
found
there any
enough.
report showing harm?
There are some reports showing harm as well. So my question to you, how safe it is in CKD 3? I chicken out. Up to CKD 1, 2 I use it. From 3, 4 onwards I chicken out. So your comments on that.
I think I agree with you, not because of saroglitazar's safety, but I think you should be very careful in CKD with any drug for that matter. Less drugs for any condition in CKD is better, because CKD is like a knife with the thing, so it might go this way, that way. So if there is no absolute indication, I try to de-intensify and take off as many drugs as possible in CKD.
Second question is the evidence of reversal of fibrosis and not worsening of steatohepatitis with saroglitazar. Evidence 3, evidence 4 is there. Do you think the data is solid enough to put it in the national guideline as to a drug for MSLD?
See, the studies are small, but they are positive. So if you say, will FDA approve it? Well, they have filed for FDA. They are waiting for FDA approval. So they've gone to a stage where they could file for FDA. They are not large studies. They're not done on 10,000 people, all with biopsy. But there is some biopsy proven evidence. For sure, we can say they don't do harm. They could do some benefit. Is it as good as resmetirom? Probably not, because the studies there are much more. But we don't have any other drug in India. And this is drug approved by Drug Control of India. So if we approve it, we are not going to go to court if something goes wrong. It's approved drug in India. It's made in India. We don't have any other drug, so I use it. Because I don't have resmetirom. You know, some company is bringing it again, is bringing through Bhutan, something and all is coming. So if the drugs come and better drugs come, then maybe we may not need this and we'll have better drugs. Until then, and they are going to be very expensive. This is also a little expensive. I hope the price comes down. But certainly it's a safety point of view, I think, is not everybody, you have used it, and I don't think safety has ever been a concern. If you use this, you'll get edema, or you'll get this one, or you'll get that one, or heart failure. All those issues are definitely
only CKD, the worsening of renal function.
CKD, yeah, better not to use it. Because the problem there is not the triglyceride at that time. You know, you've got other things to worry about when you got CKD. So.
Regarding NaION, I mean, when SEMA came, I was an enthusiastic user. When NaION came, I became less enthusiastic user. Then Novo presented their data in ADA recently, where they showed there's no increase of NaION. Then I'm told you need to look at the CD-cup ratio. My ophthalmologist never gives me the, you are lucky your ophthalmologist gives you a cup CD ratio. Our ophthalmologists do not. So most of the ophthalmologist people are saying they do not.
So I think we need to start asking for this.
So what should I do? I mean, what do I tell my patient about NaION? Increase, no increase, it's safe.
So at this point, the absolute risk actually is very small. But yes, I think a good way for us to not use certain drugs and pick up those people at risk is to look at the CD ratio and speak to our ophthalmologist and tell them this is what we want in our reporting. Or if you have your own AI device, take the photo,
so
you get the report.
0.4 or 0.2?
So the normal is 0.3 to 0.4. So anything under 0.2 is
0.2.
Possibly not a good idea.
Can I just add? Yeah, so it is a risk factor. 1 in 10,000. I reviewed one of the papers, it got accepted now, came from high impact journal. 1 in 7,000 is what they had said. For that one person is 100%. Yes. And I know of people who have gone blind due to this. I have. Not in India because it's too recent, but somebody from New York, I got a call to talk to that guy and he's irreversibly blind. Nothing you can do about it. Total blindness. But it's 1 in 7,000 people. So therefore, these are idiosyncratic things. With all drugs you get things. Now the bad luck is you have given it to that patient, you have it. Now because that one patient got it, are you going to deny everyone else? I just want to tell you, when I first used metoprolol, when it first came, that guy went into bradycardia and I stopped using it saying, no, I won't use this drug at all. Then I found that was just a bad luck of that first case that it took me 1 year to get back my confidence to use it. So sometimes you get bad luck. No medicine is 100% safe. That's all we can say. Thank you.
But I think we have to ask our ophthalm colleagues, this is what we want in our reporting. So I think that's how it goes ahead.
Incidentally, one of the ophthalmologist's wife whom I am treating, he knew about this. And I said, will you allow your wife to take it? And he said yes.
I have one question to Dr. Mohan and Bhavna. Quickly, I think the time is
already up there.
Okay, now if the way in which the neon occurs is through the proliferation of VEGF, ELISA, we can actually start testing for VEGF and then try to see in case somebody has retinopathy and we start testing
retinopathy
VEGF.
I don't think has
No, this one, especially semaglutide and neon, etc. Can we start measuring, or will that day come when VEGF is going to be tested?
It may come because people are trying to narrow down those people who got it. If there's a marker, we can say. Till that marker comes, we don't know.
Yeah, if VEGF is a marker worsening, and then will that day come someday that, okay,
I'm sure
you have a VEGF
because
test?
AI will pick it up. If you have 1,000 cases of neon, then they'll say these are the ones who got it, and then we'll ultimately be able to. Thank you.
Thank you, sir.
Thank you so much for the presenters. A big applause, please. Thank you.
Thank you, sir. Therapy Symposium. To give the first talk, Unlocking the Secret, Semaglutide, Transforming the Weight Loss Landscape. May I invite Dr. Nandita to give the excellent. Over to you, ma'am.
Very good morning, everyone. It's a pleasure to be back here on day 2 of debate. And before I move on to the topic of discussion, we had a lot of discussion just now about SEMA, and we heard it from many horses' mouth, if I may put it that way. But like I said, before I move on to the topic of discussion as such, which is again about SEMA, GLP-1, why are we here discussing this so much? Why is there this shift? And yesterday also we were addressing this. Why are we so interested suddenly in this? Is it because there are these newer molecules that have come up and we want to know more about it? Or is it because there is really a concern of an issue that we need to address? So that's what I'm going to actually talk about in the first part. This is my financial disclosure. This has been sponsored by, this is a Novo Nordisk sponsored session. Excuse me. And this is the overview of my talk. But as I said, before I move on to that, I'm going to, so this is the, and this was actually also presented yesterday. This is the National Family Health Survey data, in which they have been reporting serially over the years rates of obesity. And it is very nicely represented in the Indian map. So this is from right from 2005, early 2000s, and then serially data. So if you look at the red, the states that have been highlighted in red, those are the states in which you have the highest prevalence. So this is way back in 2005, where only Punjab stood out, and then you have Kerala later in 2006. And I'm now going to serially keep clicking, and you'll see as the years progress, how the color red is actually smeared all over. So you can see this is 2015, 2016, and 2019, 20. So as you can see, the red, which was earlier hardly in patches here and there, is actually now slowly smeared, as I use the word. As you can see, in 2021 is the last that they have reported. You can see that the states are actually exploding in numbers of obesity. And this is by definition of just BMI. Now, you'd see that our own Tamil Nadu is also highlighted in red there, which is southern India, and then you see some parts in the north as well. Now, what I want to bring your attention to further is that the previous data that I showed you was just by definition of BMI. But is it an overall obesity that we are talking about, or how dangerous is this obesity? And here I'm showing you data called the STRIDE paper, which we published recently, in which we reported in our own Chennai, Kanchipuram and Pandruti, in the urban and in the rural areas, the growth in rates of obesity, or the rising rates of obesity. So what you're seeing here in front of you in this slide is generalized obesity in the upper bar. So you're seeing Chennai, Kanchipuram and Pandruti, there is a significant increase in rates of obesity. But more importantly so, you're seeing that it's not just a generalized obesity in terms of definition of BMI like you see in the upper one, but in the lower bar you're seeing abdominal obesity rates also increasing. And when you further tease it out, I didn't put that here, but you find that the rates are increasing not just in men, but also in women. And as you're seeing over here, it is not just in the urban areas, not just in our parts like in Chennai, but even in rural areas like Kanchipuram, that you're seeing here that there is an explosion of obesity. And what is this? So here you're just seeing numbers, and I'm telling you it is in red because it's statistically significant. But what is this percentage of growth is what I'm showing you here in the slide, that the percentage of growth itself, when you compare versus 2006, and when we went back to those same areas in 2016, 10 years later, the increase in BMI, that is generalized obesity, was 50% higher as compared to 2006 in the villages, 18% in Chennai, and more, abdominal obesity was about 60% higher in our villages, in our own Kanchipuram, is what we are talking about. And what about the average BMI? The mean BMI in our population has now also increased from, when you compare statistically significant again from 2006 to 2016. In the village, which was around 21 was the mean BMI, now has actually gone up to 23. And waist circumference also has increased in the city, town, and in villages. Again, this is Chennai, Kanchipuram, and Pandruti that we are referring to. So yes, we do have an increasing burden. And there is a problem that we need to address, and so it is relevant that we are discussing these drugs so extensively, because now as physicians or as clinicians, we are equipped with tools to, it is not a sad story, and we actually do have hope to handle this burden. So that being set as a context, how are we managing obesity? And today, until recently, we had, of course, lifestyle modification. We had nutritional therapy, physical activity, and psychological interventions at one end. But we always knew that the role of lifestyle modification, and I was just discussing with Madam just a couple of minutes ago, she was telling me how she used to live in earlier outside of India, and with lifestyle modification, how it is limited. The weight loss that we can achieve is around 3 to 5%. Then we had at the other end of the spectrum surgery, with which you can of course achieve drastic weight loss. But what is that gap in between to bridge where people feel that they've lost hope with lifestyle, they can't go to the other extreme of surgery, and that is where you have your pharmacotherapy that comes in, which can actually bridge the gap between the two and give people some hope. So we all know that Wegovy is semaglutide, which has 94% homology to the human GLP-1, works on the higher centers, and I'm not going to go into the details of its mechanism of action. We know that it has an effect on both on the homeostatic as well as the hedonic regulation. So we quite often see, I don't know how many of y'all, we find patients telling us that their craving for their favorite unhealthy junk foods has actually specifically come down. In fact, to the extent that I found that some people who are even smokers, I find wives coming and telling me, "Doctor, thank you so much. After you put him on this drug, his craving for cigarettes has also started to come down." So that's another dimension that these drugs actually offer. Moving on to the weight loss trials, we know that there are the whole array of step 1 to step 6, in which they have used semaglutide in a stepwise dose from 0.25, 1 month, 0.5, month on month, up to a dosage of 2.4. And the results from all these trials show that there was more than 20% of weight loss, which started very early, even at week 4, and lasted over a period of 4 years, which was sustainable. 1 out of 3 patients had that weight loss of more than 20%. So that is the power of this drug. And here you're looking at the weight loss across the trials in comparison. And the interesting one I think that I would like to bring your attention to would be probably step 8 in comparison with LIDA. If my point, yeah, that's the one with LIDA, in which you see, and you see across trials that the percentage of subjects who achieved a weight loss of more than 20% is on an average around 30 to 40%, which is quite impressive. These next 2 slides are pretty interesting, and I'd like to just spend a little time over here, that this is the step 1 trial, in which we're seeing that with the fat loss that occurs, so there's a lot of discussion as to whether there is also reduction in the lean mass, and if we are pushing our patients towards sarcopenia when we are addressing their obesity. And this is data from the step 1 trial, in which what they're actually showing us is that even with the weight loss, when the person is losing weight, there is a proportionate, yes, reduction in the fat loss, but for that particular weight, there is a proportionate increase in their skeletal muscle mass. So not that the lean mass is increasing as such, but for the given body weight that the patient accomplishes, there is a proportionate increase in the lean mass as well. But this is what is even more, the SEMA-lean study, which I'm sure many of us have seen, which is a very interesting finding, in which they found that patients or subjects who were put on SEMA, by month 7 and at month 12, there was an improvement in the grip strength. And we know that now recently there is a lot of work being done in the field of longevity and improvement in lifespan. And grip strength has been directly linked to improved longevity. And this is data to show us that in the SEMA-lean trial, people who were put on semaglutide had improvement in their grip strength at month 7 and month 12, which is quite an interesting point. So beyond the weight loss, we know that there are also the pleiotropic benefits. There's improvement in waist circumference, improvement in CRP, triglycerides, and systolic and diastolic blood pressure. Last but not the least, we also see improvement in HbA1c from 8.1 to 6.2. This is from the step 2 trial. More than 80% of the subjects with pre-diabetes also reverse to normoglycemia. in the step 10 trial over a period of 52 weeks. So you're seeing also a drug that is going to help people reverse their diabetes, which is also quite a hot topic, was a hot topic in the recent years. So to sort of summarize what I've addressed so far, we do have a rising burden of obesity in our part of the world. I think it's high time we accepted that and understood that there is an urgency to be addressing this burden. And we have now, as clinicians, we are equipped with the right tools to be using to sort of address this burden effectively. Semaglutide is a molecule which has almost 94% homology to the human GLP-1 and is extremely efficient in terms of body weight reduction, improvement in waist circumference, and are concerned about sarcopenia can also probably be addressed to some extent. I think there was a lot of discussion about that even yesterday, that we need to advise our patients to improve their protein intake and also include some strength or resistance training to reduce that risk as well. And I showed you data that even with the weight loss, there is a proportionate improvement or preservation of the muscle mass. I showed you data from the sema-lean trial that there is also improvement in grip strength that can probably improve longevity as well. The side effects, I think, is another topic of discussion, which I think has already extensively been discussed in many of the other talks. Of course, cardiovascular safety has also been proven. What is the indication? Anybody with a BMI of more than 27 with comorbidities or a BMI of more than 30. The stepwise increase in the dose would be 0.25, 0.5, and then month by month up to a dosage of 2.4 based on the patient's tolerability and patient's response and goals of therapy. Thank you.
Thank you. Thank you, Dr. Nandita. Moving on to the next talk, I invite my mentor and well-wisher, Dr. Shashank Joshi, sir, to give the talk on unmatched and undisputed semaglutide, the role in obesity and cardiovascular outcomes, sir. Over to you, sir.
So this is a Novo symposium, and I think there is a overdose of, in the good old days, I remember NSC, Professor Mohan, there used to be overload of gliptin. Now there's an overload of GLP-1. And taking off from where Nandita left, there is the unmatched, undisputed semaglutide's role in obesity and CV outcomes. It's pretty compelling. Today is Ratha Saptami. This is a Novo talk. So we all know that CVD is the leading cause of death in people living with overweight and obesity, and the numbers are staggering and compelling. So I think there's no two ways about the global burden of the disease. And as the body size, the metabolic abnormalities increase, with every addition of metabolic abnormalities, as we move the gear from normal weight to overweight to obesity, you can see a very steep curve of coronary artery disease, cerebrovascular disease, and heart failure. And that's very, very distressful. And therefore, when you are having obesity, there is reduced lipid turnover, there's a lot of adiposopathy or adiposity with inflammation, a lot of systemic inflammation, leading to a very strong construct between heart disease and diabetes. And when it comes to cardiovascular disease, it's endothelial permeability, plaque development, atherosclerosis, insulin resistance, and even beta cell dysfunction. And clearly, when we look at the causal factors of spending too less and intaking too much, we clearly see that obesity has a direct impact on the entire cardiovascular health, whether it's arrhythmias, sudden cardiac death and atrial fibrillation, thromboembolic phenomenon like pulmonary embolism and DVT, valvular heart disease or heart failure, atherosclerosis, or even cardiovascular risk factors including diabetes, hypertension, dyslipidemia, and obstructive sleep apnea. What is equally compelling is when there is weight loss. More than 10% weight loss drives a significant CV event reduction. And that's something which we recognize very, very well. And that's something which we know very well, that the blood pressure comes down and the lipids come down and the glucose comes down and the insulin resistance and inflammation comes down. And if you look at the various cardiac societies, particularly the Europeans are the first to take a lead, weight loss interventions have an impact on CV outcomes. So even if you saw the original intensive lifestyle interventions with nutritional interventions, they did show weight loss, they did show improvement in cardiometabolic risk factors, but they didn't have an impact on the CV outcomes. Bariatric surgery has been associated with improved CV outcomes in observational studies, but the RCTs assessing CV outcomes were not available. And among the obesity drugs, as Nandita was alluding to, the semaglutide 2.4 milligram once a week showed clinical benefit in a dedicated CV outcome trial involving people who are overweight and obese with pre-existing CVD without diabetes. And therefore, the AHA-ACC hypertension guidelines also recommend GLP-1 receptor agents for hypertensives who are living with obesity and overweight, and about 27, even the Indian DCGI recommends them. And you can clearly see that this was based on the STEP program. Unfortunately, the history of obesity drugs has been very dubious and very controversial. You know, in the SCOUT trial with sibutramine, we saw that there was possible harm coming out from sibutramine. The rimonabant study was terminated prematurely, not because of cardiovascular harm, but because of some neuropsychiatric evaluation. The naltrexone bupropion is still approved by the US FDA, and the 3-point MACE study, which is the CV outcome study called the LIGHT study, actually showed it was safe. But the study integrity was compromised, and you could see that naltrexone bupropion was neutral or safe. The naltrexone convene study, the data was not available, and in the locurcerin from the Carmalima TIMI group, it was completed, again it was safe and neutral, but again it had its own molecular death. And in the SELECT trial, clearly beyond reasonable doubt, probably this is the best data piece available with us from a CV standpoint, that once a week semaglutide in a 3-point MACE clearly showed a 20% reduction with safe and beneficial effects, with compelling weight loss. So I think this is the uniqueness of the SELECT trial compared to all other anti-obesity drugs. And therefore, when we look at Wegovy or semaglutide 2.4 milligram with people living with obesity with cardiovascular disease, SELECT is one of the largest cardiovascular trials. 41 countries, 800 sites, 17,600 plus participants, with 492 participants from India, clearly randomized in a very nice way of a BMI about 27, age about 45, with established cardiovascular disease, with no prior history of diabetes. And you could see the primary endpoint being the 3-point MACE, and the secondary confirmatory endpoints being the occurrence of cardiovascular death, composite heart failure endpoints, and all-cause deaths. Very, very balanced demographics, of course, a little male gender preponderance, age being 60, a reasonable Asian population there, and the CV inclusion criteria had MI only 67%, stroke only 17%, PAD only, peripheral artery disease only 4%, and more than 2 CV inclusion criteria 8%. A1C around 5.8, BMI around 33, EGFR normal, chronic heart failure in 1/4 of the cases, with preserved ejection fraction being around 12.9 out of the 24, so almost 50%. And with pre-diabetes, probably 66%. And if you see the entire distribution of the BMI curve, below 30, almost 1/3, and 30 to 35, rest, and then pretty much everybody else on the right-hand side of the curve. So clearly they had standards of care in SELECT, and that's very important to recognize when we look at these trials. They had adequate medical treatment with lipids, blood pressure, antiplatelets, and glycemic control. They also had heart-healthy eating, including weight loss where appropriate, physical activity, smoking cessation, and limitation of alcohol consumption. And if you see, almost 86% of them were on platelet aggregation inhibitors, almost 89% or 90% of them were on lipid-lowering drugs, 70% on beta blockers, 45% on ACE inhibitors, 29 or 30% of them on angiotensin receptor blockers, and 27% of them on calcium channel blockers. And this data was very compelling. 20% significant reduction of the curve. And what was more compelling was the very, very early separation of the curve. So you could see that the p-value is geared towards superiority, and you can see that this is the only anti-obesity medication with proven cardiovascular benefit in people with overweight or obesity with cardiovascular disease without diabetes. And I think this is compelling data. And therefore, if you look at the label in India, it is indicated to reduce risk of major adverse cardiovascular events, cardiovascular death, non-fatal MI, non-fatal stroke in adults with established cardiovascular disease, either with overweight and obesity. And it's the only ESC recommended obesity medication in this space. The risk reductions in MACE were so evident and so soon after initiation that there was some pleiotropic effect beyond weight loss. So the separation of MACE curves appeared before the maximal weight loss was achieved. 80% of the MACE risk was mediated by factors other than body weight loss and was independent of changes of body weight, and this is very, very compelling data. 19% of reduction in all-cause deaths versus placebo, 18% reduction in the risk of composite heart failure outcomes, and 15% reduction in the risk of CV death. The data is consistent across each and every measure of CV outcomes: MACE, CV death, composite heart failure outcome, all-cause death, expanded MACE, all-cause death, MI stroke, non-fatal MI, non-fatal or fatal MI, non-fatal stroke, non-fatal or fatal stroke, coronary revascularization, hospitalizations for unstable angina, heart failure hospitalization, urgent visit, and nephropathy. So clearly you could see that Wegovy was associated, or semaglutide 2.4 milligrams, with reduction of multiple cardiovascular metabolic risk factors. HSCRP by around 40%, better lipid biology. There was some drop in A1C, reduction in body weight, reduction in waist circumference, and reduction in blood pressure. And more than half the participants with pre-diabetes were showing remission to normoglycemia. So if you ask me, these drugs are remission agents. They are disease modifying agents and remission agents in its truest perspective. And therefore, if you look at the entire anti-obesity space, which was clouded with non-inferiority or premature termination or increased cardiovascular risk like the SCOUT trial, SELECT actually threw up a complete surprise with superiority being demonstrated. And Krishna in the morning was saying that these are anti-aging drugs, but these drugs, particularly semaglutide, might have something more in their pleiotropy, and he did allude to that in his morning talk as well. So finally, clearly we recognize that despite of standard of care, the burden of CV events remains pretty high in people with heart disease and overweight and obesity, despite of them being on best of care, that is antiplatelets, statins, ACE, ARBs, good lifestyle. And in that population, SELECT was able to show, as the semaglutide 2.4 milligrams was the first and the only medication in this space to show a proven 20% MACE reduction, and data is there for us to see and believe. So clearly this agent is indicated to reduce the risk of MACE in adults with established cardiovascular disease, either with obesity and overweight. Thank you so much for a patient hearing.
Thank you, sir. Thanks for the wonderful talk. So we'll move on to the next talk. May I invite Dr. J.J. Mukherjee, sir, to give the talk on Beyond the Dual Hype, semaglutide leads the way. Over to you, sir.
Good morning. Pleasure to be in Chennai. You are hearing semaglutide, 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 no talk. You are wondering what's happened to the other anti-obesity drugs. Yeah? So this is not only semaglutide, right? There's tirzepatide as well. So I've been given the difficult job to go beyond the dual hype. I hope you know what dual means. The pun is intended. If I come in 2027, probably it will be triple hype. If I'm standing here in 2029, it will be the quadruple hype. We're getting multi-agonist anti-obesity drugs. But here I am to defend semaglutide. Leads the way in CKM story. being sponsored by Novo, but I'll try my best to be as unbiased as possible. You've seen this slide 50 times. I don't need to say what is CKM syndrome. It's the old wine in a new bottle. People sit, meet in meetings, and they come up with new terminologies. It's cardiovascular, metabolic, and renal disease. You've seen this slide many times. So people with diabetes have increased risk for cardiovascular disease. People with cardiovascular disease have increased risk for renal impairment. People with renal impairment have increased risk for metabolic and cardiovascular. That's basically CKM syndrome. So obesity affects all organs. You've seen this multiple times. Metabolic conditions, those of you are interested can see the percentages. The percentages vary depending on which study you see, whether from India or Mexico or Japan. So these percentages take with a very bit of pinch of salt. Musculoskeletal, there are 3 M's basically. That's what the Lancet Commission said, 3 M's, musculoskeletal, metabolic, and mental. But here in the Novo slide, you'll find some more. Musculoskeletal is osteoarthritis, mental is depression, and then comes the cardiovascular disease, which Dr. Shashank Joshi mentioned in great detail about the SELECT trial. Then there are respiratory diseases, kidney diseases, and reproductive disease, polycystic ovarian syndrome. So these slides are just to tell you obesity is bad. Now, semaglutide has unique and robust evidence for improving health outcomes in people with obesity beyond weight loss of 21%. Now, 21% is the maximum weight loss with 7.2 milligrams of semaglutide. These are the step-up trials. So cardiovascular disease, you just heard SELECT. You did not hear the STEP-HFpEF, but you might have heard about it yesterday or day before yesterday. It's semaglutide in people with heart failure with preserved ejection fraction. I'm sure you must have come and heard the ESSENCE trials before, must have been presented in Chennai not once but many times, trying to tell you that semaglutide is good in people with MASLD. You just heard about saroglitazar. Saroglitazar is still struggling with its phase 3 trial in US. It's only been licensed in India. Semaglutide has now been licensed and approved by FDA, apart from resmetirom, for use in people with MASLD and MASH. Metabolic diseases, of course, it's a very good drug for people with diabetes, dyslipidemia. And STEP 10 trial looked at the reversal of people with prediabetes to diabetes, and also just now heard the SELECT trial, where almost half the people have a reversal of diabetes for many reasons, primarily probably because of weight loss. Kidney, there are 2 trials. The STEP 2 trial, they just looked at the reduction in ACR, which is not a hard renal endpoint. But in SELECT trial, there was a secondary endpoint. There was reduction in the composite kidney outcome. There are 5 composites. I don't have time to go through it. And there was statistically significant benefit in renal outcomes in people with semaglutide in the SELECT trial, where people with obesity without diabetes were given semaglutide. Knee osteoarthritis, only semaglutide, not tirzepatide, has got a dedicated trial called the STEP 9, where there was a reduction in the knee osteoarthritis score. And of course, physical function in QL improves. So what are the stages of CKM? When all of us are born, we have no risk factors. We have adequate sleep, I hope. We have good diet, I hope. We exercise, I hope. I don't do any of those 3. No smoking, hydration. Then you go to stage 1 and stage 2. Stage 1 is nothing but obesity, whichever way you want to measure it, by BMI, by waist-hip ratio, by waist circumference, and along with obesity, impaired glucose tolerance. That's stage 1. Stage 1 sets the stage for stage 2, where obesity brings in the other risk factors, which are hypertension, dyslipidemia. And in stage 2, see, this is the reinvention of the same things. In stage 2 CKM, they're now included CKD. So people with CKD, eGFR less than 60 for more than 3 months, or ACR more than 30 for more than 3 months, that's the definition of CKD. Coming to stage 3 and stage 4, stage 3 is basically subclinical ASCVD and subclinical heart failure, which is probably difficult to diagnose. And then most of us in this room see stage 4. People who have got type 2 diabetes, with hypertension, with some form of heart failure, ischemic heart disease, atrial fibrillation, or chronic kidney disease. So now comes the various trials which semaglutide has done. Semaglutide has spent billions. And the next slide will show you how many billions they have spent, because I'm going to show you all the trials under each of these stages. So stage 0, fortunately or unfortunately, semaglutide doesn't have any trial. So on the day you're born, you should not start semaglutide, because it's not going to prevent any of your risk factors. After that, if you're at any stage, you should be on semaglutide. Stage 1. Stage 1 is what? I told you obesity, right? So you've heard all the obesity trials, all the STEP trials. There's no doubt that semaglutide is a good anti-obesity drug. All the STEP trials. I don't know if you've heard all of them, the 14 of them. And then comes OASIS 4. OASIS 4 has just been approved, semaglutide 25 milligrams. I'm very surprised why 25, because Novo has a 50 milligram data, which is more robust than 25. But still Novo chose to license 25 for FDA. FDA has given license to 25 milligrams of semaglutide oral. As to when it's going to come to India, I don't know. Stage 2, where I told you that there's hypertension, there is diabetes, there's dyslipidemia. We all know that semaglutide is a very good anti-diabetic drug. It also reduces hypertension, as you just now saw, and it has got mild beneficial effect on lipid profile. And if you see the margins, this tells you oral semaglutide, subcut semaglutide 1 milligram, or subcut semaglutide 2.4. It's available in four different ways, of which oral 25 is not available to us in India. So Pioneer are all the oral semaglutide trials, Sustain are all the 1 milligram subcut semaglutide trials, STEP trials are all the 2.4. In all three groups of trials, and that's billions of dollars. It has shown that it improves glycemia, improves blood pressure. And with regards to CKD, flow trial, I mean, this is an MCQ question. Flow is 1 milligram subcut semaglutide. It reduces clinically significant renal endpoints. And Essence trial, I told you, is the trial in people with MASLD MASH. It was a biopsy-proven trial. Stage 3 is subclinical. Again, your flow and Essence works. And stage 4, where you and I see the patients. Ideally, we should be seeing in stage 2, obesity. That's what the whole purpose of the last 3 talks are. That at stage 2, you should be starting this drug. But if you have missed your patient in stage 2, stage 3, at least in stage 4, when they have all sorts of issues, I can see Sustain 6, SOUL, and are basically the cardiovascular outcome trials. Select, these are in people with diabetes. Select is people with obesity without diabetes. Flow trial is the renal outcome trial. STEP, heart failure with preserved ejection fraction, is basically in people with heart failure with preserved ejection fraction. And STRIDE is people with peripheral vascular disease. So what it tries to tell you is semaglutide can put itself in any of these various boxes. So semaglutide protects heart, kidney, liver, and more. It's a very nice slide. At the end, take a picture. It summarizes all the trials they've done. So up to 21% weight loss is with semaglutide 7.2, which is not available to us. If you see the weight loss is about 15%, this is the average weight loss. As Nandita presented, 1 in 3 will have more than 20% weight loss. But if you take the average weight loss is 15% in step 1 in people with obesity without diabetes, and everybody in this room knows that in people with diabetes, same BMI, same amount of obesity, weight loss is always half compared to a person who is obese and non-diabetic. So therefore, in step 2, the weight loss was 10%. Overall, 21%. Glycemic reduction, 2.8% is the maximum, but generally it's about 1.8 to 2.2% if you use whichever form of semaglutide. Here this is Sustained, which is 1 milligram, which is what we know as Ozempic. Now with regards to cardiac, you saw some of the trials being presented. SOUL trial was with oral semaglutide. Select and Sustain. Select was 2.4 semaglutide. Sustain 6 was with 1 milligram subcut semaglutide. STEP heart failure was with 2.4. And PAD outcomes was the STRIDE study which Nandita just showed. Everywhere if you see, I think percentages are hard to remember day-to-day work, but all of them are statistically significant. So semaglutide is not only working on the metabolic outcome, which is weight, blood glucose reduction, blood pressure reduction, it's also protecting your heart on the right-hand side, also having effect on protective effect on peripheral vascular disease. What about the kidney, Dr. Mukherjee? Their kidney outcome, that is the flow trial. Flow trial was 1 milligram subcut, as I said, 24% reduction, and this is renal endpoint was the primary endpoint, 5 renally significant endpoints. So heart done, kidney done. What about liver benefits? I'm saying Essence again and again. I'm sure you will hear it in another session. I'm giving a summary of everything. There was improvement in fibrosis as well as resolution of steatohepatitis. And this is what Novo beats the drum. This is from the SELECT trial, 20% reduction in all-cause mortality. But maybe in question and answer session, we can discuss this in more detail. So effects in MASLD and MASH, if you see all the drugs. So now comes tirzepatide. Oh, I've only 3 minutes left, I have to rush. Sema and tirzepatide, if you see, don't see the others. Sema has got clear-cut, unequivocal level A phase 3 randomized control trial data where everything is beneficial, except if you see even semaglutide says reduction of fibrosis progression is still potential benefit. With tirzepatide, everything is potential because tirzepatide does not have a phase 3 data yet. They have Synergy NASH, which was phase 2 data. As to when will the phase 3 data come, we have to wait for it. With regards to cardiovascular, renal and others, if you see semaglutide, beneficial, this is level A evidence, randomized control trial. Tirzepatide is, at the moment, they do not have a data like SELECT trial in obese people. CKD did not have a dedicated trial. They have secondary endpoint data about beneficial and reduction in EGFR. Heart failure, they both have data. So with this, I'll come to this last. This is the latest. This is called the Obesity Association. What is Obesity Association? People in ADA, some groups meet together and they become a professional practice committee. and they've come up with this algorithm. This algorithm is nothing new. This algorithm was discussed by us many times, but now at least it's official. What's official about it? People with obesity, BMI more than 25, without obesity-related complications. Of course, on the top, remember, behavior, health, nutrition, exercising, muscle strengthening, it has to go. Just giving semaglutide will not work. You have to do all these things. On top of that, if patient does not have any other obesity-related complication, which is rather rare actually, you won't find an obese patient who does not have osteoarthritis, heart disease, renal disease, etc. Most of them will have something, but there are few, 10 to 20% who will have no obesity complications. Here, if you see the data, tirzepatide is above semaglutide with regards to amount of weight, the quantum of weight loss. Now in people with ORCs, it's very hard to take this in 1 minute. You can take a picture and go home and read. I've made it easier for you. The ones with the red margin are in favor of tirzepatide, and ones with the blue margin are in favor of semaglutide. So if you have an obese person with pre-diabetes, despite all the data you saw about SELECT, etc., tirzepatide does better than semaglutide in prevention of progression of pre-diabetes to diabetes. If you come with type 2 diabetes, the reduction of HbA1c is better with tirzepatide. If you come to hypertension, BP lowering is slightly better with tirzepatide. But, as I said, people with obesity do not only come with diabetes and hypertension, they come with organ involvement. So if they have underlying heart disease, heart failure with preserved ejection fraction, if they have fatty liver, as Dr. Mohan presented, almost 70, if I'm not wrong, you said 73% of people in your study have MASLD. So there you go. Then here, in this situation, semaglutide does better than tirzepatide because semaglutide has got level A randomized controlled trial data, which tirzepatide still lacks. They so far have phase 2 data. If you come to OSA, again, tirzepatide better, it's a red margin border. And if you come to osteoarthritis, blue margin, because did a step 9 study in people with osteoarthritis. So this is, I think, what the Obesity Association put together, that information we already know, but it's nice to have this so that whenever you next time prescribe a patient, you can tell them why some association is supporting me. So, last slide. Weight loss more than 10%, both are A, but just see the size of A, it's slightly bigger for tirzepatide. Pre-DM, type 2 diabetes, hypertension, tirzepatide does slightly better than semaglutide. But as I said, most of the people with obesity will have some associated organ involvement. So if it comes to ASCVD, HFpEF, MASH, or OA, then tirzepatide, as of now, in 2026, has got level B data, grade B data, whereas semaglutide at present has level A data. So I had a difficult job of comparing both of them in a very short period of time. I've tried my best. I'm sure you'll have questions. I'll take it in my question time. Thank you.
Thank you, sir. So all the speakers are available here. You can just have their question at the break time. So due to lack of time, I'll just skip to the keynote address. To have the keynote address, may I invite the chairpersons, Professor Shantaram sir and Dr. S.N. Narsingan sir, to take this.
Good morning, everyone. I think we are going to have an excellent session by two eminent speakers today. There's going to be a keynote address. I think Dr. Mohan is going to talk about the lean diabetes. It is a continuum of type 2 diabetes. He is going to impress upon us the importance of identifying lean diabetes, and it is going to tell us that it is a continuum of type 2 diabetes and not a separate entity. I am sure I will also learn from his talk how to manage such patients. I am sure he will be able to give us the important information on this particular aspect of diabetes. Over to you, Dr. Mohan. Dr. Mohan is the Managing Director of Dr. Mohan's Diabetes Specialty Center and is also the President of the Diabetes Research Foundation of Dr. Mohan's.
Thank
Over
you,
to
sir.
Dr. Mohan.
Thank you for the kind introduction, and I'd like to thank the organizers for yet another fantastic debate meeting which has been organized. It's actually a paradox that after talking about so much about obesity and listening to two molecules, I'm going to talk about the other end of the spectrum, which is lean diabetes. But this is also important because not everybody in India with diabetes is obese, as I'll show you later. And even more important, because of this entity called as type 5 diabetes, which has suddenly come up from nowhere. And so I thought we should talk about what I think about that condition. No conflict of interest to declare. These are all government-supported studies. So obesity and type 2 diabetes is almost like a sine qua non. So you think that both cannot be separated kind of a thing. But is it true that everybody with type 2 diabetes is obese? Well, type 2 diabetes can obese in obese people, obviously, also in overweight people, also in normal weight people, but also it can occur in lean people, which is sometimes very difficult to accept. Why should it occur in lean people when adipopathy and obesity is so closely related with type 2 diabetes? So I don't know if this will work. So which pathophysiology, I'm going to ask 3 questions and then hopefully give the answers later. Which pathophysiology best describes lean diabetes? Is it complete beta cell dysfunction? Is it pure insulin resistance, excess glucagon secretion, or severe insulin deficiency with mild insulin resistance? You can vote, you vote. Otherwise, we will go on. Oh, okay. So most people voted for that. So lean diabetes, where is it most commonly seen? Is it Northern Europe, North America? Is it in South Asia and Africa or Australia? It's an easy one to do. If you're going to vote, we'll see that. Great, that's right. So I don't have to give this talk now. You all got 100 on 100. So lean diabetes showed which of the following compared to normal weight? Higher prevalence of retinopathy, neuropathy, higher C-peptide, lower microvascular complication, lower insulin requirement. Okay, at least something for you to listen to. Okay, so the concept of this lean diabetes is not new actually. People think it's now very new and it's just come. It's not new at all. In fact, I must thank Professor Siddhartha Das from Orissa because they are the ones who brought this up. And at that time, remember, there was already this malnutrition diabetes being discussed at the time. At the same time when he described lean NIDDM or type 2 diabetes, there was already this discussion about malnutrition diabetes. And then so much of work went into it when Professor Bajaj proposed it. In fact, Bajaj wrote in the WHO report that 75 to 80% of all diabetes in India is this. You know, where I had to take him on and say that's certainly not true. Whether it exists or not is another debate. I don't think it even exists. But that 80% of all patients have this is a total lie. So that is not true at all. So this is the paper that Dr. Siddhartha Das published in as early as 1995, and he actually described the metabolic pattern and so on, and he distinguished it from malnutrition diabetes, which his boss, Professor Tripathi, B.V. Tripathi, had proposed from the same city and the same college. In 1997, we published this report on lean NIDDM. Actually, it was a fairly large study even at that time. And at that time, we had worked with Professor Paul Zimmet and Professor Mackay and Ish Bhatia and looked at GAD antibodies in all of them. We had done C-peptides and nicely phenotyped them as far back as 1997. And what we showed in that was that retinopathy, nephropathy, and here are lean people, ideal body weight, obese, males, females, type 2. It was called as NIDDM at that time. So you can see that actually, if anything, the complications were worse in the lean people because their A1Cs were also higher in this group. So again, to us, this was not a new entity at that time. Then came this report from CMC Vellore, published in 2022, where they called it an atypical form of diabetes among individuals with low BMI. So to give credit to the CMC group led by Dr. Nihal Thomas and Dr. Meredith Hawkins from Albert Einstein, Montefiore, New York, they had very nicely phenotyped these patients. So that had never been done to that extent. So they did clamp studies, and they did insulin secretion studies, and they did all kinds of studies. The only problem was there were only 20 people. And these 20 people were from the northeast, the poorest of the poor who visit CMC Vellore. So they took them out, took the poorest, the thinnest of them, and then studied them in detail, and they showed severe insulin deficiency, which is obviously there because they don't have much of insulin resistance. And they said it's a new entity, and now they made it into type 5 diabetes. So they called this as malnutrition diabetes. So they had a BMI of 18, waist circumference of 74, severe insulin secretion is low, but it's not type 1. In type 1, insulin is absent, C-peptide is absent, but here it's present. So that's why we say it's part of type 2. And then the A1C is very high. They didn't describe the complications in that, but they've done very detailed biochemical testing. So this is called as type 5 diabetes, and Peter Schwartz, who was the president of IDF, attended that meeting and immediately said, we'll make this into type 5 diabetes. So it was announced, based on that one report, it was announced that a new entity has come. And now, of course, quite rightly, they have now called for more research on that, which I accept fully. We should do more research. When it turns out to be a separate entity, so be it. It's great. Even my objection to Bajaj is only that. Show us a marker. Why it's different. FCPD, you got a marker. GDM comes during pregnancy. Type 1, you got ketosis, and you got antibodies. And for so many other diseases, for Modi, you've got a genetic marker. Show us a marker, and then we'll accept it as a type 5 or type 25 or whatever you want to call it, we can call it. But show that it's different, which so far we don't have. Okay, so is it a different entity or not? So first of all, we looked at INDAB, because INDAB is a whole country. It's a representative sample of the entire country, all the 31 states, male, female, urban, rural. If you look at INDAB, the representative of INDAB, and compare it with the census, they actually go parallel. You cannot even separate it out. So it's one of the most beautifully done representative studies. So if you look at this paper and look at diabetes, these numbers are great. Now this is looking at it in a different way. Does diabetes occur in lean people? So if you take all people below 18.5, there's a small diabetes there. And of course, with obesity, it goes up. There's no doubt that as you get more obese, the prevalence of diabetes, this is prevalence of diabetes. So even in very lean people, you have diabetes. And this diabetes is not type 1 diabetes. Type 1 diabetes is much more rarer than this. If you go and screen a population, you'll hardly pick up 10 cases, 15 cases of type 1. But this you do pick up. So it's much more common than type 1 diabetes. This is one way of looking at it. Okay. Now, if you classify according to INDAB and classify and see whether you're able to separate out these people who are at 18.5, and then you go into different categories, even above 30 if you see. Now, these are fairly large numbers, 565 people, it's not 20 people, it's 565 people representing the whole country. You can see the BMI is 16.8, same as what was reported from CMC Velo. And if you look at them, they are poorer, they have more smoking, all the things which are associated with leanness is actually there. So they are lean people, they're just lean people, a lot of lean people in India, and some of them have diabetes. Okay, now if you look at the physical activity, actually it's higher in this group. Vigorous activity is the highest in this group, which is why they are thin. And if you look at triglycerides, lowest in this group. If you look at HDL, highest in this group. Look at LDL cholesterol, lowest in this group. So there is a continuum of this. If you just start dividing people into different things, it's not fitting in. If they're all separate, you can say they're a separate entity. It's beautifully flowing. You look at cholesterol, lowest in the group. HbA1c, highest in the group. These are Indian studies, the whole India we have studied, and we are able to show that lean diabetes seems to be, if you look at insulin, highest in this group, because most of them need insulin because they are lean and they have more severe diabetes. Now, that much phenotyping we could do in INDAB. INDAB is not a well-funded study. It's not meant to do. So then we had to go back into our records where we have close to 400,000 patients in electronic records, and said we'll go into this for deeper phenotyping and see what happens. This was published more recently, and the title itself says lean diabetes, one end of the spectrum of type 2 diabetes and not a separate entity. And now for this, if you go back, now we've got large numbers. The lean, less than 18.5, is close to 6,000 people. It's not a small number, 6,000. And we've got totally 400,000, 4 lakh people in the registry, and you can see some of those numbers are 73,000, 15,000. I don't think anyone in the world has these kind of numbers. And if you look at them, you'll find that the HbA1c is again the highest, exactly what we found in INDAB. Now replicated in 400,000 people, okay? it will be difficult to even replicate the study anywhere else in the world. And if you look at C-peptide, fasting C-peptide lowest, and it keeps going up. Look at stimulated C-peptide lowest, and it goes up. And these values are very similar to what Nehal Thomas. So exactly what he has reported, saying it's a completely different entity, type 5 diabetes. If you draw a line there, then you call this type 5, call it type 6, 7, 8, 9, 10. You can go on like that, and you can produce 500 types of diabetes based on BMI. I don't think we should do that until we really say that a disease is completely different. So this is what we published, and this is a graphical abstract about that. Now here is another data which has come from NHFS. I have nothing to do with it. Independent study just published a few days ago in January 2026, where they have identified, and they are saying that this type 5 diabetes, what they're saying is nothing but lean type 2 diabetes. So coming from NFHS data, exactly showing the same thing. Now let's look at clustering of diabetes. Now, you remember a few debates earlier when this paper was published, I had presented that type 2 diabetes itself is not one disease. It has severe insulin deficient diabetes. Leave the first one out, what Alquist reported, because this is really type 1. But if you look at the type 2, you have an insulin deficient variety, an insulin resistant variety, and a mild age-related variety. When we applied that to Indians, we got slightly different because we are like 10, 15 years younger when we get type 2 diabetes, and we're much leaner. So when we did our clustering, what we got is 4 types. The severe insulin deficient type, the IROD or the insulin resistant type, which will be the obesity one which we're talking about today for semaglutide and other drugs. Then we have a combined variety. That combined variety we actually described for the first time, and it's now been replicated in Genes and Health in Pakistanis and Bangladeshis in the UK. It's been replicated in a Chinese study and by 3 or 4 other studies. And this is a unique population for us to study because it's not seen in the white European population at all. They have both insulin resistance and deficiency, and they have the lowest HDL and the highest triglycerides. So it's a unique South Asian one. And then you've got a mild age-related one, which comes due to age, milder diabetes, and so on. So you got these 4 types. Now the question is this SID the same as what they are talking about? So you take SID also, some of them go up to BMI 23, 24. Now if you focus on the SID variety, which is less than 18.5, you'll see it's exactly the same. This is not the same study, by the way. It's a different study. So if you look at it again, you'll find that the C-peptides are the lowest, but measurable, nowhere in the type 1 range. And if you look at HOMA beta here and HOMA IR here, again the lowest, showing that they have the lowest insulin resistance and the lowest insulin secretion, lowest C-peptide, the HDL being the highest. So same thing is coming, replicating again and again and again. When you do it in different ways and look at it, you're getting the same answer. To me, if you repeat something 3 times, 4 times, then that's the truth, and that's how it comes out. Now, if you take the CMC data and you look at our lean SID data, the BMI is even lower than what we have than CMC. And look at the cholesterols, identical. A1Cs are identical, wastes are identical, triglycerides are identical, HDL is identical, C-peptide is identical. That's exactly the same. So what is that one marker which is different in those 20 cases to say it's type 5 diabetes and describe a whole syndrome out of it and make the whole world believe that? Lean diabetes is not new, because as far as early back as 2015 in May, this paper came out saying that lean diabetes is an emerging entity in the era of obesity. And what they're saying is that even for pathogenesis of this lean diabetes, it works in a different way. If you plot the insulin sensitivity versus the beta cell function, the obese people behave in a different way, and the lean ones behave in a different way because they're at different end of the spectrum. So in one place you have more insulin resistance driving that. The other side you have more insulin secretory defect driving it. Both have both, but this is predominantly insulin resistance, that is predominantly insulin secretory defect. So now if I ask you which pathophysiology describes lean diabetes, is it complete beta cell dysfunction, is it pure insulin resistance, excess glucagon, or severe insulin deficiency with mild insulin resistance, I think the answer is pretty obvious. It is just severe insulin deficiency. And again, South Asia and Africa, which have the poorest people, naturally will have this disease. This may change. After 10 years, when you have a lot of obesity in India, you may not see this at all. It may disappear, just like FCPD disappeared. After some time, you may not be seeing this. As it is low. In our clinic population, it's 1%. of all our patients. In India, it's 5%, because you're going to Jharkhand and Northeast, from where Nihal got his cases, it is less, it's more common there because there's more leanness there. And then if you look at, compared to what do they have higher rates of retinopathy and neuropathy. We showed this in 1998. It's not new. We showed that then and we're showing it now again. In that paper, DRC paper, we have all the complications on these large numbers. So to conclude, ladies and gentlemen, my message is very simple. While we know that adiposity and obesity are well-known risk factors for type 2 diabetes, however, it can also occur in very lean people. I think it's right to call it as lean type 2 diabetes, which is nothing but SID. It's a severe insulin deficient variety of type 2 diabetes. And I think with the Alquist classification and our clusters now, we don't have to further keep reclustering it until we find some new evidence. We find that new evidence, science keeps on moving. But we have to do more research and find out why are these people getting it in the first place? Why did they get the diabetes in the first place? That would be worth doing. We are doing all the omics on this group, incidentally, in very large numbers. We are doing genomics, we're doing proteomics, we're doing transcriptomics, we're doing lipidomics, and we're doing metabolomics. We are doing epigenomics in this entire group. So the story is not complete. We are also continuing our research in this. But as of now, to classify it as type 5 or MRDM, I think it's a little premature because I've been in this game for about 40 years now. 40 years ago, 30 years ago, we discussed it and we threw it out. And I think we should still keep it out until some new evidence comes in, and then we should take it. Choice of anti-diabetic drugs also vary. I don't know whether these people respond to semaglutide and to terzepatide, whether they are the right ones to use it, or perhaps we should be using insulin secretagogues. We should be using a little more of DPP-4s, smaller dose of sulfonylureas, and maybe insulin would be good in these patients. Precision diagnosis and treatment depends on accurately classifying the subtypes of type 2 diabetes, and I hope I've convinced you about that. Thank you very much. And I've given you 3 minutes back.
Thank you, sir. Thank you, Dr. Mohan, sir, for the excellent presentation, highlighting that lean type 2 diabetes is a continuum of type 2 diabetes and not a separate entity, alluding to various facts, and emphasizing that its implications for the outcomes when compared to obese type 2 diabetics and the management strategies which is different from the obese type 2 diabetics, be it the lifestyle modification or the therapeutics. Thank you, sir.
Thank you very much.
We'll take up questions at the end of the session. We'll next move on to
is it possible, since the two topics are different, I'll just take one question or something and then I can run off to catch the flight to Delhi.
Okay. Okay, sir. Any questions?
Any questions? Yes, Krishna.
The one thing I can't understand, if it's malnutrition-related diabetes, shouldn't it go away if the malnutrition goes away?
Well, that's what happened to FCPD. It came down. And now it's only 1% of all the patients that I see. It's predominantly obesity-related thing. The other thing that has been carefully examined is, if it is malnutrition producing it, then we should have seen a case of Kwashiorkor and marasmus develop type 1 diabetes. I've not seen a single case report in the whole world where Kwashiorkor or marasmus has gone. If it is so obvious, all of them should have developed diabetes. All that they have is a mild glucose intolerance, which you feed and it goes away. Okay, even Dr. Bajaj's experiments in monkeys only showed glucose intolerance. They didn't really develop diabetes. So it's never been proven that a malnourished person actually leads to diabetes. So there is no proof that it actually leads to that. Micronutrient deficiencies, maybe. Maybe it's something else which is working there. Maybe it's a good area to research on. But to say that it's the cause, you really have to prove that. I don't think we have the evidence.
The second is, there are actually criteria for causality, right?
Yeah.
That there should be an association.
Yeah. That it's not proven here.
It's not proven.
It's not proven at all. 100% no.
Good afternoon, sir. Sir, regarding the lean diabetes, my question is very basic, sir. Which drugs we prefer and which drugs you don't prefer in your experience, sir?
We don't have an RCT. We are trying to do, and the SID and the other variety, we have got an RCT. It's getting completed. It's called aggregate trial. So SID, you can roughly equate with this. We have got a beautifully designed RCT. I won't talk about it now, but probably next debate I can come back and show you the results. So it stands to reason that drugs like metformin or other drugs would not be the choice here. We believe that either a DPP-4, which works very well in our population, by the way, a low-dose sulfonylurea and insulin. This would be the first line. But it doesn't mean Dr. Ramchandran has published a paper many, many years ago looking at lean diabetes when we were in Roypuram many years ago. He has looked at lean diabetes and metformin. It works. It works even in lean people. It doesn't mean that metformin cannot be given in underweight people and so on. But the first choice may be a sensitizer rather than a secretagogue rather than a sensitizer. But we need data. We don't have a proper answer. When you finish the aggregate trial, I'll come back to you.
Thank you so much, sir.
I think in interest of time, I'll stop here. Thank you.
Sorry. Our next topic is the intersection of quantum science and metabolism, to be delivered by Dr. Shashank Joshi, who needs no introduction to the metabolic or endocrine society, and COVID has taken him beyond this society into the general public. So over to you.
Dr. Shashank, I think I should appreciate you because you have come in the costume, what has been repeatedly emphasized by Dr. Krishna Sheshadri, the traditional way in Tamil Nadu, which is now being strictly followed by you. We expect more science from you now. Thank you very much.
So thank you so much, and it's quite a challenge to speak after Dr. V. Mohan, and I have to thank Krishna for giving me this talk called Intersection of Quantum Science and Metabolism. It's a tough talk to do. I don't have any duality or conflict of interest for this talk except hospitality from Krishna, Sanjay, Arvind, Bhavna and the primer team. So you know, today is Ratha Saptami, and if you look at quantum metabolism, we need to reset our rhythm, recharge our metabolism and realign with season, because season changes, you know, when there is Makar Sankranti. And we know that time is a manifestation, it has its own challenges and powers. But when we look at quantum science, for clinicians, practitioners, you know, what is quantum science, you know? It's fundamentally predicting electron behavior. So fundamentally what it's trying to do is map electron behavior, and there are methods of calculation to predict this electron behavior. So that's quantum mechanics, to put it in the most simplistic terms, because Krishna also gave me a mandate that keep it as simple as possible, and that's the but you can actually map it now. We have nanoscale quantum sensors, which are like nanodiamond quantum sensors, which can track metabolism inside living cells. So it's feasible now for modern science to actually track living cells using quantum sensors, which are like nanodiamonds. But when you look at metabolism, from again a very simplistic angle, we have chemical energy because of the food we consume, carbs, fats, proteins, micronutrients, and we pump out the chemical waste as carbon dioxide and water, and we are thermogenic. So our currency is ATP, which is the body's energy currency, and we have a lot of anabolism and catabolism on a biological pathway with different substrates which go into that. So clearly when we look at it from a quantum physics perspective, we look at materials of simple structures, materials of complex structures, and then we put them through an anabolic window or a catabolic window. So that's a little more complex in it. So fundamentally when you are exercising, our body is either converting or using energy. Oxygen, water, food, as sweat, breath, carbon dioxide, heat, or urine or feces. But from a metabolic standpoint, we all know that proteins are nothing but amino acids. They're a pool of nitrogen. They fundamentally go into the urea cycle. And that's the protein axis. And then of course we have the carbs, which are little more complex. We have glucose, we have the pyruvic acids, we have the glycogens. They all ultimately go through a common pool of acetyl-CoA and the citric acid cycle, and carbon dioxide ultimately comes out. And that's what happens. And finally, if you look at lipids, we look at fatty acids and glycerols. They all go through beta oxidation. And ultimately, we have the entire electron transport chain and oxidative phosphorylation. So if you look at it from a very simplistic angle of cell metabolism, whether you are using a glycolytic pathway through the cytosol outside this mitochondria, but inside the cell, or inside the mitochondria, whether it's the electrons carried via the NADH or FADH2 through a Krebs cycle or an electron transport chain, it's fundamentally nothing but ATP, which is our body's currency for energy, and substrate level phosphorylation. And therefore, from a quantum standpoint, when we put them through quantum computation, quantum simulation, quantum communication, quantum metrology, it's called as a bosonic mode. So that is the engineering mode of quantum science. So obviously, you know, at a cellular level, metabolism is not as classical as what I described, the biochemical pathways. And there is a lot of quantum metabolism which is beyond that. So we see that happening very often. So, you know, there is a historical divide and recent convergence. You know, biologists always doubted physics, but now physics can connect molecules. And quantum biomedicine is something which was improbable once upon a time, is now having resources which are testable. And the foundations of metabolism, whether it's NADH or FADH2, which carry these high energy electrons from the TCA cycle, fundamentally are nothing but high energy electrons. And these electron transport chain pump the proton across the membrane to build a potential. And we all know these cytochrome C pathways. And therefore, when we look at it from a quantum perspective, we have three quantum principles in biology. One is tunneling, in which we are trying to have the quantum escape through a barrier. Second is cohesion or superposition, which is charge transfer via a delocalized quantum state, and then probably we try to derive one probability wave, or it could be entanglement, which is nothing but a quantum connected biological site. So clearly these effects are observed in biology. You know, when you look at photosynthesis, you know, from green sulfur bacteria, there's a long-lived coherence from the FMO complex. Electrons take multiple energy pathways and increase efficiency, and we can actually do ultra-fast 2D spectroscopy to show quantum beats in energy transport situations. So clearly the photosynthetic complexes transfer energy with an exceptional efficiency. And therefore, the traditional models like classical hopping overlook the quantum coherence. And therefore, when you look at a green sulfur bacteria, FMO complex, you can actually, it works like a quantum energy wire. And therefore, we can actually look at a wave-like energy flow, which enables quantum sampling and energy selection. We also know that cytochrome proteins, like in the avian retina, are light activated. And they are generating entangled radical pairs. And they can be picked up by spin and genetic studies. And finally, through proton tunneling and enzyme kinetics like alcohol dehydrogenase, lactate dehydrogenase, we can get kinetic isotope effects, which can substitute hydrogen with deuterium, with slower reaction, and we can get tunneling of protons. And we have now experimental tools like EPRs, isotope substitution, ultra-fast laser spectroscopy to validate these effects. So we can actually do the proton tunneling governance, the kinetic isotope effects, and the quantum simulations, and the quantum machines which are available. And we can actually study mitochondria from a healthy cell or a tumor cell a little better. So clearly, can we translate this electron into patients? Can we look at quantum mechanics of life, quantum algorithms of electron tunneling, spin dynamics, quantum coherence, which is all Greek and Latin to most of us, redox potentials, electron coupling, spin states, energy landscapes, and so on and so forth? Can we move them into biological complexes? Can we do experimental validation of all this? Can we look at endocrinology of this? Can we look at the ligand receptor quantum dynamics and the endocrine feedback loops? And can we look at various experimental challenges and scientific critique for quantum biology? Well, we all know I called it too warm, too wet, because biology operates on a noisy, thermal fluctuating environments. And quantum coherence and entanglement are typically short-lived in such conditions. And therefore, there are challenges of preserving quantum states in cellular systems. Therefore, many claims in neuroscience, olfaction, consciousness remain very hypothetical and debated because there is lack of reproducibility. It's difficult to replicate a cytochrome magnetoreception finding across species or labs. And therefore, many of these quantum biological claims have not passed peer scrutiny or lack sufficient controls. And classical models still dominate due to computational accessibility. And quantum computers are still in infancy for biological system modeling. Large biomolecules are computationally intensive to simulate quantum algorithms. But that's why we have had some false leads in this entire view. But when you look at glucose and diabetes, which is our focus area, we can clearly see from a quantum standpoint insulin signaling and glucose metabolism. For example, insulin receptor activation via quantum transitions is easy to understand. The blood transporters, the glucose transporters which are there in various cells, their quantum dynamics in membrane systems is easy to understand. And therefore, we can actually study experimental gaps and emerging models to understand insulin signaling, and this is an advancing state. And now we have better tools for quantum sensing. For example, we have the NV diamond sensors, which I showed you, which detect local redox shifts and clearly recognize that in a much, much better perspective. We have the passive microwave radiometry and cytochrome quantum emission profiles. So clearly we are understanding this better for precision endocrinology. We are understanding the hybrid modeling for drug binding and enzyme kinetics, metabolic disorders, and personalized therapy. But can it apply to metabolism or medicine was an ask which Krishna told me to do. And in my last 10 minutes, I'll attempt that. Michael Brownlee, who lives with type 1 diabetes at Albert Einstein, a good friend of ours, okay, put out this very nice paper in Nature in 2001, almost 25 years back, and said that despite of advances in endocrinology, clinicians frequently encounter unexplained variability of metabolic responses. And he put out this hypothesis, and he's a good friend of my friend Jeffrey Mechanic, who's at Mount Sinai, to say that can we explore quantum physics, which governs energy transfer at a molecular level, and use AI to bridge this understanding of unknown. So that's probably the outliers, the non-responders, and that's the hypothesis. And this is what he actually said, that this topic matters to clinicians. And probably that was the reason probably Krishna thought, because people with same BMI, same A1C, same insulin levels, behave very differently with different molecules. And the classical biochemical hormonal models cannot fully explain this. Just in the previous talk, we saw Dr. Mohan telling that the lean variant of diabetes may not be a distinct entity, but we probably need to do quantum science in that entire subset to understand BMI below 19 better. And therefore, when we look at metabolism, it depends on the energy transfer efficiency. And quantum physics now, with modern tools, is able to understand that energy transfer at that scale. So this layer understanding then will explain us the real life clinical unpredictability we see in clinical practice. For example, some people get metformin intolerance, some people even on a small dose of sulfonylurea go into hypoglycemia, and some of these can be predicted. So remember, metabolic efficiency is not just hormone levels. Two patients with identical insulin signaling may oxidize glucose differently. And that inefficiency will precede over disease. And some may get fatigue, some may get weight gain, some may get poor glycemic control. And that is where quantum physics might have a deep dive into that deeper energetic problem. And they may actually influence different enzymes which execute these metabolic instructions. And this is an excellent paper, again by Jerry Schulman and his group from Yale. Rohit knows him probably pretty well. And he's really put this out, how mitochondrial dysfunction in obesity and type 2 diabetes can actually impact. And can we use this quantum physics there? Mitochondria was addressed by Deepak earlier. Clearly is central to diabetes, obesity and aging. Clinically, this presents insulin resistance and exercise intolerance. And standard tests will often show normal enzymes. However, the energy output could be reduced because the electron transfer may be insufficient rather than enzyme absence. And therefore, the quantum tunneling efficiency directly affects the mitochondrial performance. And this is a very nice paper in the Science by Wallace et al., which actually says mitochondrial disease in man and mouse. And I would urge you all to read it. And that explains partial responders. You may give a semaglutide, you may give a tirzepatide, not everybody may respond. So many people respond partially to insulin, partially to metformin, partially to GLP-1 analog. Classical explanations are on adherence or genetics. But even in compliant patients, there is variability. And if you look at quantum efficiency of enzyme levels, it may amplify or blunt drug effects. And the small molecular differences can lead to a large clinical difference. And this can reframe the so-called term drug resistance mechanistically. And again, a very nice paper on misconceptions of drug recovery in Nature by Smith and Kearns is worth a look, published quite some time back. So to understand clinical observations, one must examine metabolism at scale where energy transfer occurs. And this scale is not hormonal or cellular, but submolecular. It's at the level of electrons and proteins behaving according to quantum rules. And that is why Krishna thought quantum science is relevant and important. Because it's the quantum rules which determine the electron and proton shifts, not hormonal and cellular shifts. And these rules influence the reaction of speed and efficiency. And their operation will determine living cells. And that is a stage of so-called quantum metabolism. And electron transfer is real metabolism. Because that is where an electron transfer reactions is central to glycolysis, TCA cycles, oxidative phosphorylation. And therefore, these reactions occur faster than classical chemistry predicts. And there again, quantum tunneling allows electrons to bypass energy barriers. Because enzymes are structurally optimized for this. While when the tunneling efficiency drops, the ATP production falls. So clinically, this is called as metabolically inefficiency. And we can actually map now. We can map proton transfer, metabolic redox reactions with isotopes. And experimental isotope substitution slows these reactions disproportionately. So it cannot be explained by classical kinetics. And there is no exotic systems, but everyday metabolic pathways. And therefore, quantum effects make them physiologically relevant. Oxidative stress is so much talked in basic science, but reactive oxygen species arise from electron leak. This leak probability increases when the transfer efficiency falls. And clearly we recognize that the link between mitochondrial dysfunction is directly proportional to aging and diabetes. And therefore the antioxidant defenses may buffer, may not eliminate the problem. And that's something which we can understand better. So clearly diabetes is a inefficient energy utilization. It's not just a hormonal disease. Glucose availability may be adequate, yet the oxidation may remain impaired. And it's a quantum inefficiency which reduces ATP per yield per glucose molecule. And you can clearly see then it gets digressed to harmful pathways. That worsens as glucotoxicity. And treating efficiency becomes important in lowering glucose. Obesity is nothing but energy partitioning. Obesity reflects nothing but a state of chronic preference of storage over oxidation. And small inefficiencies of energy transfer can shift this balance. And quantum inefficiency favors fat accumulation. So this can even occur without caloric excess. And that explains weight regain after dieting or the so-yo or the cycling as they call it. And targeting efficiency may prevent relapse. And finally, aging and fatigue. With aging, mitochondrial efficiency blunts. And quantum coherence can give us the answers because there's a lot of accumulated noise and damage. and the electron transfer becomes less reliable with ATP production. And that explains fatigue and sarcopenia, and therefore aging is also a partly physics problem. So AI now has become a clinical bridge. We knew quantum physics before, but AI has been a modeler. And Eric Topol wrote this nice paper in Nature Medicine, who's a cardiologist. Quantum influenced metabolic systems are non-linear. And again, this was a thing which Krishna alluded to in the morning, and therefore I think his talk and my talk, we had not seen each other's slides, are non-linear and complex. Human intuition and classical statistics struggle to model them. And that's where AI can integrate biochemistry, physiology, and clinical data. AI can detect patterns of metabolic insufficiency and then risk stratify and therapy selection. And therefore it can translate physics into clinical practice. And therefore we don't need to do that. So let us look at 3 clinical illustrations. One picked up from, the group from Yale, 48-year-old man with type 2 diabetes for 8 years, A1C of 8.2, despite of good adherence to metformin, basal bolus lifestyle. BMI, renal function, hepatic parameters are stable. Secondary causes of insulin resistance are excluded. Escalating insulin dose produces diminishing glycemic effect, increasing hypoglycemic rates. Structured aerobic exercises leads to a marked glycemic improvement without significant weight loss. So quantum physics explains this observation by improving electron tunneling efficiency with mitochondrial enzymes. Exercise is upregulating the mitochondrial structure, reducing the electron transfer distance and energy loss, and ATP is generated despite of unchanged insulin signaling. So this case illustrates that improving quantum level energy execution can outperform hormone escalation. So clearly we can explain persistent insulin resistance by quantum inefficiency. Second is fatigue. I might take a minute more. Okay. Fatigue with normal labs as quantum energy failure. 55-year-old woman presents with chronic fatigue, poor exercise intolerance, gradual weight gain over several years. Thyroid, cortisol, glucose, lipid profiles are within normal range. Despite of normal endocrine testing, she reports early exhaustion, minimal exertion. Classical hormone explorations fail to account the symptoms. Quantum physics might identify an inefficient electron transfer, proton transfer within the mitochondria, and reduced tunneling efficiency will show that all you need to do is graded exercise, micronutrient depletion for mitochondrial coherence, and symptoms may improve before any measurable biochemical change. And finally, what Krishna alluded to in the morning, the variable GLP response through quantum amplification. 2 people with the similar BMI, metabolic profiles, lifestyle habits are started on GLP-1 receptor therapy for obesity. One patient achieved sustained weight loss and metabolic improvement, while other plateaus despite of good adherence. Appetite suppression is comparable in both. Classical explanations are compliance or drug adequacy is insufficient. Again, quantum physics will explain this divergence on the differences in metabolic efficiency amplification. And the small differences in electron transfer, mitochondrial coupling, magnify downstream energy utilization. So the responder efficiently converts the reduced caloric intake into increased oxidation, while the non-responder keeps storing energy. And therefore, an AI-guided quantum-informed phenotyping may predict outcomes before therapy initiation. And that might be where a future will go. And Brown's put out this, again, nice paper in Nature, long time back, which explained all this. So remember, metabolic inefficiency is a unifying clinical concept. Whether you are within fatigue, insulin resistance, weight gain to normal laboratory values, and we can actually translate mitochondrial dysfunction to patient symptoms and insulin resistant beyond signaling pathways, obesity as an efficient energy utilization, and aging as a progressive metabolic. So remember, variability is a rule in endocrinology. Because we see a lot of heterogeneity, but we can explain part of it. And therefore remember that in my closing slides, exercise is a metabolic efficiency enhancer. And a lot of things can be explained by quantum science alone. Nutrition also is a regulator of metabolic execution and functions as a molecular tuning to metabolism. Sleep circadian rhythm improves metabolic efficiency and energy handling and stress physiology. And therefore, the real-world practice of drug response and variability for endocrinologists like all of us go beyond adherence and genetics, and we have some answers in quantum science. And AI enables us to do precise mapping and go beyond pathway blockers. We can also do preventive endocrinology and early risk detection, and we can operationalize quantum metabolism using AI. So clearly, quantum simulation, experimental validation, and clinical integration is here to stay. And bridging physics, biology, and medicine is getting more and more converged as we go on. But there are ethical and clinical concerns in quantum biomedicine, over hype risk, patient privacy in quantum diagnostics, equity and access, and regulatory uncertainty. So obviously my final slide, and I'm sorry that I went ahead of my time by a minute or two, is that are we observing quantum level miscommunication, whether it's diabetes, whether it's cancer or neuroendocrine diseases? Because clearly we have some answers coming up in that direction. Could quantum informed interventions restore the redox balance and metabolic integrity? And will quantum twin of metabolism redefine diagnostics and predictive medicine? Thank you for a patient hearing.
Thank you very much, Professor Shashank Joshi. I am now trying to recollect how Shashank Joshi was delivering lectures in the past on so many subjects, and a well-known speaker, renowned speaker in various forums. And all of you know about his research activities and the scientific approach with whatever subject that has been given to him. Probably he will be throwing a lot of light for us to understand better. Today he paved the way for us to proceed further in the quantum physics and the quantum application, including the artificial intelligence. The tough topic that has been given to you, you made it simple, but I am really not very happy to gather all the points. Probably I may request you to give me the slides so that I'll go through that slowly and try to understand in a better manner. The topic that was given by Dr. Krishna will be the appropriate person to raise any question.
So to start, Shashank says, I have a question, sir.
Sure.
So going by your talk, I think this thing should supplement pharmacogenetics in precision medicine.
Absolutely. Absolutely.
Absolutely.
I agree with you. Yeah, Krishna.
So I just wanted to give a background of how this is an evolution. So every debate we try to push the barrier a little. And if you look at the last time, we talked a lot about, in fact, this mitochondrial story has been building up for the last 3 years. Everybody thinks that when you put a mitochondrial talk, it's about hemoglobin. It's not. We started talking about the efficiency of the mitochondria. Even last year we had this talk about what is creating a problem in the mitochondrial efficiency. And interestingly, over the last few years, the interest in quantum science and quantum this thing is shifting the large unknown we have in patient care as a efficiency issue. We have been always trying to find if it's a polymorphism, if it's a genetic thing, it's not. It's probably not. They're all the same, but you're still different, and that's what Shashank's brought in. And the next few years, you'll probably get a lot more of this. And by the way, quantum science intersects not just biology. There's another part that's dealing with spirituality, and there's another part that deals with a whole bunch of other things.
I wish you had given me the spirituality bit. It was easier.
That's easier to do, right?
That's easier to do. But one thing, Krishna, I must say that in all this, the amplifier or the game changer is lifestyle. So I think just blaming it on genes or non-adherence is not the issue. And just plugging in the lifestyle might just be the game changer of efficiency improvement.
That goes back to this morning we had this, I tried to do another experimental talk on NASH and longevity. ultimately it boils down to whether we respect the bacteria that live with us, the soil that lives with us, the area that we live with us, and ultimately it sort of comes to that holistic thing that we need to start doing. I think that's the whole story. Thank you so much, Shashank. Thank you.
Good afternoon, everybody. Now we go to the last bit of the program, and it's my pleasure and honor to do the primer honors. Primer honors are two parts. One, first we have a couple of invocation and Tamil Thai Valte. I request all of you to stand, make you do some exercise. Before that, may I welcome our chairman, Dr. Arvind, and Dr. Krishna Sheshadri onto the dais. Please stand up for the invocation. I'm going to do a little bit of exercise to all of you. Please come. Please stand. Please keep standing. Ravi, play the next one. Thank you. Can be seated. Now, it is my pleasure to, it's Primer's honors. We honor every year a person who's contributed to the medical community over a long period of time. And this year, we are proud to present the Primer honors to Dr. S.N. Narsingan, who's MD FRCP. Sir, please come on to the dais. He's Vice President, World Hypertension League, is Vice Chairman of the Lipid Associations of India, Medical Director, Sir, Dr. Shashank Joshi, please come in. Medical Director, Armora Heart Center, Chennai. We have been listening to him for the last 3 decades. I think I've been listening, and I know people here. He has 77 articles to his credit, 766 guest lectures. He's published. He's the one who's instrumental in publishing the lipid guidelines for India. Over the years, from 2017 to 23, he's received many awards. Some of them are the Lifetime Achievement Award by Tamil Nadu MGR University, Master Teacher Award by Indian College of Physicians and API, Distinguished Teacher Award by Government Stanley Medical College and Hospital, the Jeevaraj Mehta Award in 2015, World Hypertension League bestowed on him award in recognition for setting highest clinical and academic standards in field of medicine, Lifetime Achievement Award by the organizations of the International Society of Renal Research, Excellence in Diabetes and Lipids Award by the Lipid Association of India, 3DCon 2024, present him with the C.V. Krishnaswamy Award in 2024, Physicians Day Award. He's received the Presidential Award for World Hypertension League for his organizational capacity to conduct World Organization Congress 2025 at Chennai for the first time, which happened in India. Ladies and gentlemen, please stand up and give him a standing ovation. And I request Dr. Arvind, Dr. Krishna Seshadri, and Dr. Shashank Joshi to honor Dr. Nasr.
So Dr. Narsingan has been a teacher of teachers for many of us here. And I request him to say a few words of, to all of us, words of advice.
Yeah, good afternoon. I think soon after finishing my MBBS, I started my career as a physician practicing medicine. I was showing a lot of interest in the field of medicine. I joined Standard Medical College with my MBBS qualification as an honorary assistant professor there, and then got into MD and rendered Stanley Medical College and hospital free service as the capacity as a honorary assistant professor for a period of 20 years, teaching students all the time. And I was very much attached to the students. Even now, they recognize me wherever I go. They always come and try to induce me to recollect what I did for them. That is something great which I really liked for my entire life. And I am cherishing it all the time. And that will be remembered forever in my life. So that's number one. Number two, the organizations which had helped me to grow. In fact, I really appreciate these organizers for having given me a lot of opportunities to serve them, including API, then the Indian College of Physicians, Lipid Association of India, and Indian Society of Hypertension, and the World Hypertension League, which actually comprises more than 100 organizations under its banner. And I was asked to be the board member in the beginning, later the vice president, and I continue to serve the organization as a vice president. And they have elected me as the president-elect, the first president from India to take charge in the year 2030. And in fact, my association with all these people for a long, long period, and particularly to Dr. Arvind, in fact, he spent his time in the beginning of his career at MV Hospital for Diabetes and Professor Viswanathan Diabetes Research Center as a student who had undergone this course of diploma, and used to be very, very quiet and used to learn a lot of things. Quiet and used to learn a lot of things. I still cannot forget the way in which he was trying to learn from teachers, not only from me, but even from Dr. Mohan and Dr. Ramachandran and Professor Viswanathan. We were all together. And Professor Viswanathan asked me to be the honorary assistant professor there. So I'm just trying to recollect when I saw all these people now bestowing all the wishes for me. And Dr. Krishna, the moment I started looking at Krishna, I can only recollect how we had engaged in a discussion in an airport, how he spent his time during his career in American Board of Endocrinology, and how people are very particular to give him the opportunity to continue in the same field. By repeated appearance for getting the degrees to be continued to have a good amount of practice, even in other countries also. He has to write an examination. He was mentioning repeatedly about the career, and I was very much impressed. From that time, I think he has been very closely associated with me. I used to invite him for all our activities in the association,
And of course, he was also very kind enough to invite me for most of the meetings, including the debate or endocrine meetings. I am really very happy today that you have selected me through the organizers to this forum, and then to recognize my activities and then give your wishes and honoring me also. Regarding debate, I think many meetings of debate which I attended, I am only recollecting the days when the debate was the first or the second one promoted by Dr. Prasanna Kumar, assisted ably by our Dr. Sanjay Reddy, Dr. Arvind, and all of them were together, and they all were enthusiastically arranging all these activities, and they were bringing me to the forefront and requesting me to take part in the debate. I was the one who was trying to talk about statins for all diabetics, opposed by Dr. Vagesh Iyer, endocrinologist, saying that not required. But today, tomorrow, and year after, I will be telling that every diabetic should receive statin. And that is the truth. I am sure all of you are practicing in the same way. And I think Sanjay has been very close to us. For all meetings, he used to be very close. And he is the one who always be seated in the faculty lounge, try to see whether everybody comes on time, everybody loads the slides on time, everybody is attending the meetings properly. He has been overseeing the entire services rendered by all these faculty members. And Sanjay was very, very affectionate towards me, and love and affection, what he had shown to me, probably had given me a good amount of life. In fact, no, he used to tell me that, sir, you are the teacher for teachers, professors for professors. All those, what I can say, mentioning about my activities through some good people, I am really very, very happy. I think I am blessed by God to get this sort of wishes from all these people. And Dr. Shashank Joshi, I think he had left, no? Yeah. Shashank Joshi, I think I've already mentioned. And I'm really happy that some of the people in the audience are also my students. My friends are here. And today is the day which I will remember it forever, because I had been associated with the debate many times. They had given me opportunity to take part in the activities. And I have been seeing them growing day by day, year after year, every 2 years. Like that, no, the things were arranged. Initially, it was in Bangalore. Now it got shifted to Chennai. I know the entire story. I don't want to take much of time. But I'm telling you that this organization is the best organization which goes only on a scientific basis, only on evidence all the time. In fact, I was trying to give a complicated case of dyslipidemia, which I sent to Dr. Krishna Seshadri. The next day is mentioned, sir, try to teach them what to do on the next day when they go back to the practice, rather than talking about the complex dyslipidemias which you had seen in your clinical practice. So this is the best advice what I can get it from a junior most person like Dr. Krishna Seshadri, how I am supposed to talk to the people, what he wanted for debate. So I am really, really very happy that all of you are here in the afternoon to witness this particular program, during which time I am being honored. I am really very happy to get this honor from all of you. Thank you so much.
Thank you, sir. Thanks for accepting the award from my side. Thank you very much for all the services you render to the society. Yeah. Can I now call upon Dr. Rohit Kulkarni? Dr. Rohit Kulkarni is a friend of ours. It's for a long time, but more than that, I want to introduce Dr. Rohit Kulkarni. He is the recipient of Dr. Prasanna Kumar's oration this year. Dr. Prasanna Kumar, my mentor and a founder chairman of Prima, unfortunately is today has to be in Bangalore, so he's not coming for the conference, but we miss him. And I request Dr. Arvind and Dr. Krishna Seshadri and Dr. Narsingan to facilitate Rohit Kulkarni. Dr. Rohit Kulkarni is MD PhD, holds the Diabetes Research and Wellness Foundation Chair, Section Head of Islet Cell and Regenerative Biology, and Associate Director of the Diabetes Research Center at Joslin. He is Professor of Medicine, Harvard Medical School, an Associate Member of the Board Institute of MIT, Harvard and principal faculty at Harvard Stem Cell Institute. He is recognized for the excellence in diabetes research by the Ernst Oppenheimer Award, Endocrine Society, Albert Renault Prize, EASD, and Paul E. Lassie Medal and Award. He is an elected member of the American Association of Clinical Investigation, Association of American Physicians, and American Association for the Advancement of Science. His laboratory, called Kulkarni Labs at Joslins, is interested in investigating mRNA modification, stem cell biology, and organ crosstalk in the long-term goal of finding cures for diabetes and obesity. Ladies and gentlemen, please stand up and give him a standing ovation. He's from our country, from Bangalore, from India, and one of the few people who's doing basic research and dedicated his life to the same for the last 40 years. Thank you, Dr. Rohit, for accepting to deliver Dr. Prasanna Kumar's oration. Last. May I now invite Dr. Rohit to start the session. Thank you, sir. Lunch is in the next room. No, no problem. Take this off. You can wear it. Don't open
it. I invite the chairpersons on stage, Dr. Sridhar.
Thank you.
Thank you very much, and thank the organizers for this honor. It's a privilege to be here. So my attachment to debate goes back a long way. We were just discussing the other day how many years ago. It's probably like 15 years ago. I remember sitting down with Dr. Krishna Kumar, Prasanna Kumar, Krishna Sheshadri, Arvind, and Sanjay. And we're talking about how to, integrate basic science into clinical medicine. And it's remarkable that this has been going on for so many years, and it's been a privilege to be part of it. And we also have other people now as part of the organization, Dr. Bhavna Sosle and Dr. Shubha also, who are part of it. So it's great to be here, and I really am privileged that you're providing me this opportunity to give this oration. I know that Dr. Prasanna Kumar is not here, but he's a great friend, and he's been an amazing person to communicate about science. So when I was discussing what I want to talk about, I've given many talks on data, and what Krishna suggested was perhaps I could give a glimpse into how I came out to pursue a science as a physician scientist, so that gives an idea about the youngsters in the group. So I've decided to give a little bit of history of how I came out to be where I am today, and also snippets in the middle as tips for the junior faculty on how they could adopt some of these things that I've experienced in my journey as a physician scientist. So these are my disclosures. So I started, as many of you might know, that I'm a graduate of Bangalore Medical College, a very proud graduate, then went on to do work at St. John's Medical College, working on clinical nutrition. And then I went on to do endocrine fellowship at Hammersmith Hospital in London, followed by ending up at the Joslin Diabetes Center since 1997. In between, I also did a sabbatical in Switzerland for about a year in the lab of Marcus Stoffel. So my interest in research started when I was in MBBS, but also mostly during my MD when I joined St. John's Medical College, talking about energy expenditure. And the problem at that time in the 80s, in the late 80s, was chronic undernutrition. It continues to be a problem now, but I think here now it's overnutrition. during the 80s, we were trying to figure out the reason why a chronically undernourished individual can take in such low energy, but then is able to do manual labor, which is high energy output. So there seems to be an imbalance between energy intake and energy output in chronic undernutrition. And now we know it's the opposite. In obesity, it's more energy intake versus energy output. But that undernutrition was a big problem in the field. And St. John said the first whole body calorimeter where you could put a person in the calorimeter and you can determine the energy expenditure of that individual. There used to be a treadmill inside in the calorimeter. The person would stay in for about 36 hours. And we used to do night duties looking after this individual. So there's a different type of night duty doing calorimetry. So that is how I began my research, being excited about asking questions and finding answers in this context of undernutrition and energy imbalance, which has implications also for obesity in many ways. So that is when my research bug bit me, and I hung on to it for the rest of my career. Subsequently, I went on to the Royal Postgraduate Medical School at Hammersmith, where I worked with Steve Bloom. Many of you might know that he was among the first people to work on GLP-1. The Kryman paper in Lancet is a very well-cited paper. I worked as an endocrine fellow there and then went on to do a PhD at the same time, studying peptides, regulating islet biology. Subsequent to that, I tried to come back to India, but I didn't have opportunities to work in India, so I went on to the Joslin Diabetes Center, where I worked with Ron Khan, who was a leader in insulin signaling, and began working on signaling pathways in the beta cells, and that's how I spent a lot of time in the context of beta cell biology. So the first step for junior faculty would be to focus. So when I started my work in the 1990s, late 1990s, at the Joslin, the first thing that I was told by my mentors was to focus on a specific topic, right? You can't be picking different topics. You need to pick a good, interesting topic and just keep focused on that and go in depth. Because your interest could be very wide and very, very thin in depth, but it could also be just very narrow, but you can go very deep in how you want to understand it. So I took that to heart, and I just started working on the beta cell. And at that time, insulin signaling was mostly focused on adipose, liver, and skeletal muscle. Very few people spoke about insulin signaling in the beta cell. The beta cell has insulin receptors. In fact, the number of receptors on the beta cell are equally dense or even more dense than the adipocyte or the hepatocyte. So why are we not talking about insulin signaling in the beta cell and the effect of insulin action on the beta cell? Why are we restricted to other peripheral tissues? So we took on this challenge, and shown here is a graphic of over 100 manuscripts that we have published to establish that insulin signaling is critical in the beta cell, and that any form of therapy should consider insulin signaling in the beta cell. So there's overwhelming evidence to argue for this. And I'll give you a couple of examples. And when I was doing this, you know, it's always a dogma, right? When people talk about insulin signaling, it's always restricted to peripheral tissues. So my plan was, I thought I'll find out what's happening in the beta cell and then move on. But then the reality was different. We had to undertake very difficult experiments, but because working on the human beta cell in vivo is a huge challenge. In humans, you can take a liver biopsy or adipose fat biopsy, but getting a biopsy of the islet is virtually impossible. So you had to design experiments and move from bench to bedside in a carefully titrated manner, and that took us about 10 to 15 years. And so we developed a model which is very critical for us, called the insulin receptor knockout, because of a lack of ability to work on humans at that stage. Obviously, you can't make a knockout model of a human. So what you could do was to knock out the insulin receptor in the beta cell and then study what is the consequences in that mouse model, right? It's pretty simple. And we published a series of manuscripts. I won't go into great detail here. We showed all aspects of type 2 diabetes emerging in this model. So shown, for example, is the acute phase response after glucose injection. All of us know that you have this first phase response and the second phase response. Look at what happens in the knockout mouse model. You have a loss of this first phase response. And this is typically what is seen in patients with type 2 diabetes. So we have created a beautiful model in the mouse which mimics what happens in humans. So the next challenge was a series of experiments to understand what exactly is going on in this mouse model. I won't go into great detail because I'm sure all of you are thinking, oh, this is actually a mouse model, right? Where's the data and the human? So I was lucky to interact with Alison Goldfein, who was a very close colleague at the Jocelyn, and she was very excited to work with me to translate what we showed in the mouse into the human. So we went on to do a series of experiments, which again took about 8 or 9 years. And just an example to the juniors that you can't, wake up and find an exciting discovery within a few months. You have to persist and focus with a long-term goal. So along with Alison, we showed that in normal individuals, so all this is in human studies, exogenous insulin enhances glucose-stimulated secretion in healthy humans. So this is the first demonstration that exogenous insulin in healthy humans, when you increase the insulin level exogenously to mimic postprandial insulin levels, it stimulates glucose-stimulated insulin secretion. So that's got a healthy effect of exogenous insulin. And then we went on to show what happens in individuals with type 2 diabetes, that this insulin augmentation is impaired in insulin-resistant humans. So clearly, what we showed at the bench was translated in humans to show that exogenous insulin is important in regulating beta cell biology, independent of effects on hepatocyte, adipocyte, and skeletal muscle. I want to emphasize that this is focused entirely on the beta cell. And this was also showed subsequently by other groups. Murray and Ella Ferranini also showed the same thing after we showed these studies. And this has implications for what experiments were done in the early 80s, where they could not understand some of these experiments that were done which had beneficial effects. So Tim Garvey and others had shown that if you diagnose a patient with very early onset type 2 diabetes, give them a short burst of short intensive insulin therapy, then you can take away the insulin and then the patient comes back to normal. He does not need insulin anymore. So they were puzzled by that finding, and we could show that this short-term insulin therapy in individuals with early onset type 2 diabetes is acting on the beta cell to preserve the beta cell and promote beta cell health. And that allows the beta cell to preserve itself over a period of time, and then you can take away the insulin and they come back to their normal HbA1c. So this is still now overwhelming evidence from our own studies to argue that short-term insulin therapy may have its benefits in individuals who have insulin deficiency, and you can slowly titrate it away and then they become insulin independent. And the mechanisms and the pathways are all shown by the manuscripts that I showed you earlier on. So we think this is one of the most exciting things of my career. I continue to work on this. And when we discovered this many years ago and reported on this, there's still some skepticism in the field. And so in 2021 and 2022, more data came to emerge to show the pathways which are relevant. So the beta cell is unique. It secretes insulin, and insulin is having an effect on itself. So there must be a special pathway in the beta cell, as opposed to hepatocyte, adipocyte, and skeletal muscle, to regulate this mechanism. And Heiko Lickert in Germany identified Inceptor. And Inceptor is a protein which is expressed exclusively in the beta cell and some hypothalamic tissues, but not expressed in hepatocyte, liver, or skeletal muscle. And this Inceptor is important in titrating insulin signaling in the beta cell. So this makes theological sense that in healthy individuals, Inceptor plays a role to make sure that insulin action on the beta cell is tightly regulated. And if you knock out Inceptor, or you have a mutation in the Inceptor gene, this leads to symptoms of diabetes, because this dysregulation leads to defective insulin secretion. So what we had proposed in 1999 is now authenticated by another protein which supports what we have been arguing, that insulin signaling is critical in the beta cell and that the Inceptor plays an important role in regulating beta cell biology. And we wrote a commentary on this article to mention that. So that was a very exciting area, and subsequent to that, Dr. Mohan alluded to this type 2 diabetes and how different subtypes of type 2 diabetes are important. It comes back to the argument that the beta cell is a prime culprit in all forms of diabetes. Having an argument or having a debate with my mentor, Ron Kahn, where I showed this slide and said that in the 20th century, its insulin resistance was a major component of type 2 diabetes. But I think in the 21st century, we now know that there are subtypes of type 2 where you don't have to have insulin resistance or have minimal insulin resistance, and these individuals have beta cell deficiency or proinsulin defects or obesity, and even in the individuals with obesity, there is a defect in the beta cell. So up to 60% of the individuals who walk into the clinic have defects of the beta cell already. They have minimal insulin resistance. So we need to be careful about the therapy that we want to use. So what we did on the beta cell is now translating into the effects of how therapies can be modulated and how we need to pay importance to the beta cell as a primary target. We also did, I'm just trying to give you examples of what all I did in my career, and so during this time we also developed an important protocol for generating beta-like cells from human blood samples. As you all know, it takes about 9 months for the beta cells to mature in a human. But we're able to truncate this to 44 days. So within 44 days, we can take a blood sample and then derive a beta-like cell from that. So this, we think, is a remarkable achievement. Obviously, this is something that is done by a number of different groups, but we spearheaded our efforts at the Joslin, and now we have this facility where we can take samples from patients with type 1, type 2, or MODY. We can make beta-like cells. We can begin to do research on those beta-like cells in those individuals who are still living, because we can't get those beta cells from their pancreas. But we can get the beta cells by taking a blood sample and deriving the beta cells to study. So this, for us, is a very exciting area of work as we continue. The second tip for youngsters is to always consider a second portfolio when you're doing your research. So I've been working on the beta cell for a long time. Obviously, that's an area that I'm going to work on for the next several years. But it's also important to keep your own sanity, to have a second interest. And you try to reinvent yourself as you do research. So instead of a slow decline into obsolescence, I decided to work on an emerging area of science. And that was RNA modifications. So this interest that we got in this area was around 2014 or 15, about 10 years ago. And this was a big risk because I didn't have any funding for this. But it's important that youngsters realize that you have to take something where there's a knowledge gap in the field and be brave enough to move in the direction and begin to develop that slowly. So this took some time, but now my lab is one of the leading labs of RNA modifications in metabolism. No other groups have done as much work as we have done in the area of diabetes. And the reason for this also is because RNA is a neglected molecule. So many of us work on protein. Clearly, protein is a critical component. DNA in the context of epigenetics, but we don't realize that RNA is the missing link which can regulate protein, but also can regulate DNA, right? So that is part of the epitranscriptomics. I won't go into great detail here. I've given talks before, but I just want to emphasize that the concept of epitranscriptomics has now emerged is very important. That understanding how RNA is able to regulate protein, and RNA can also regulate DNA through modulation of many enzymes has emerged as a very exciting area. And the National Academy of Medicine in the US has suggested that RNA biology is here to stay for the next few decades. So we were very lucky. I mean, this is very serendipitous that we were interested in this 2015, and the Academy came up with this this kind of advice to the NIH just 4 or 5 years ago. So we are well positioned to work in this for the next decade or so. So my lab has been working in this in a number of areas. I won't go into great detail here, but just to give you a glimpse that in addition to beta cell signaling, we are working on RNA modifications in multiple tissues which now have been published in high impact journals. One example would be here. You can see that RNA modifications, which is M6A or methylation, is important in type 2 diabetes. So doing a number of different experiments on the M6A methylome, we could show that just RNA sequencing, shown here on the top, segregates type 2 from controls. But if you do the M6A methylome, see how well it segregates. Look at how type 2 is differentiated from controls compared to RNA sequencing. So suggesting to us that M6A sequencing is the way forward, not RNA sequencing. And this is an important advance in the field, which again allowed us to look at some of the pathways which are important in the beta cell. So tip number 3 for youngsters again here is to consider a sabbatical. I think if you want to learn something new and different, you need to challenge yourself. You need to go back to the bench. So this is what I did in 2018, just before the COVID. I spent a year in Switzerland, in Zurich, at ETH Zurich, in Markus Stoffel's lab, who was interested in RNA biology. And I went back to the bench to do some experiments, and it's not trivial, right? We all like to sit and just relax as you grow older, but I think you need to challenge yourself and go back to the bench if you want to learn something new. And this is what I did for that year, and subsequently, and this allowed me not to burn out, because if you don't take on a new area, it's very easy to remain static and to burn out. So we went on to do several other studies. I'll give you a couple of examples here. We looked at RNA biology in the context of type 1 diabetes, and this was spearheaded by Dario De Jesus, who was a fellow in my lab, and now is an assistant professor in Chicago. Sevim was a fellow in my lab, and she's now a senior scientist. Both of these individuals spearheaded our efforts in understanding how RNA biology is important in type 1 diabetes and type 2 diabetes, and also early differentiation. So we showed, for example, that this signaling pathways are important in type 1 diabetes progression in human beta cells. I want to emphasize that some of this work has been done in human beta cells, showing the translational relevance of what we did. So one example is, again, coming back to signaling pathways in human islets, how can we take islet samples from patients with diabetes and to study the gene expression? It's virtually impossible, right? There's no ethical approval that you'll get. But we're fortunate that in Scandinavia is the only place that it could happen. In Scandinavia, this particular study looked at sampling in patients with early onset type 1 diabetes. They agreed to take a biopsy. The ethical approval was completed. And these 5 patients provided a sample of islets, early onset type 1, and this has been a major advance in the field. This is the only data set that we have to show that there is data from patients with type 1 diabetes. So we took advantage of this and looked at the gene expression patterns in our own models, and we could show that this circle, the red circle here, in the genes in these individuals with type 1 diabetes are similar to the genes that we are showing in our models. So that gives us assurance again that what we are looking in our models at the bench are similar to what is being shown in humans. Now that is an important, again, advance in understanding translational medicine. Sometimes it feels very, very painful to do the research, but I think you got to stick at it, right? I'm sure you guys recognize who this is trying to push this boulder up. So some of these studies that we went on to show, and you also get challenged by the critiques from the referees for the manuscripts, but we could show that ER stress is an important component which modulates RNA biology in type 1 diabetes. One other point to consider is when you're doing research, you should be brave enough to get into any part of science. So here is structural biology of this metal 3 enzyme, which is important for RNA modification. All of our studies led to this point, but then we had to learn about structural biology, structural components, to advance to the next stage of the mechanism. So this again took us about a year and a half, but this just gives you an example that you can't box yourself into small silos. You've got to get out of that and learn something more if you want to really come to the mechanism. And this was a very, very exciting and satisfying experience because we nailed down the mechanism by which this important pathway is regulated in type 1 diabetes. Are there other metabolic tissues which are important in RNA biology? Yes, of course. For example, the alpha cell. This paper is in revision. I'll be happy to talk about this when I come back next. Alpha cells are important for hypoglycemia. I'm sure all of you are aware, the glucagon secretion. How that is regulated becomes important, and so we have shown that aspect here, as well as alpha beta cell crosstalk. We've also shown in brown and white adipose tissue that this is important. RNA modification is important in the context of prostaglandin signaling in brown fat as well as in white fat. So again, won't go into too much detail. It's also important in the context of liver regeneration in mice as well as in humans. So you can see the RNA modification data is encompassing multiple tissues. So finally, in the last few slides, I want to argue that RNA can also be a good target. I know the proteins are important targets, like GLP-1 receptor, for example. Kinases are important, right, in breast cancer. Ion channels, all these are examples of proteins. But you also have the RNA biology can define targets for type 1 diabetes. So what we did in our own experiments, first of all in a mouse model, is to target this molecule called metal 3, and we could show that in these animals which are receiving the metal 3, the diabetes free proportion was much lower compared to the controls, suggesting that you can target these molecules for therapy. And here are some other examples of what can be done in immunohomeostasis, infections, tumor immunity, stem cell therapy. All of these have shown to be important for protein targets. But which is the most important example that I can give you? It's the COVID-19 vaccine, right? It's based on RNA biology. So this is an excellent example of how RNA can be a target and how we can establish this expertise in metabolism. The last tip for juniors is always to be innovative, right? So you have to focus. You have to make sure that you think of a sabbatical, getting out of your own silos. You have to be innovative. You have to take on additional roles as the emerging techniques arise. And Dr. Shashank gave you a good example of quantum biology and artificial intelligence and ChatGPT. How can we adapt all those things to your own research and biology? It becomes very important. You can't say, oh, this is not for me. So you have to be innovative. And here are some different types of innovation, right? So you can't be, here's one example. You always find individuals who are sitting on the armchair and they always say that this will not work. They'll never do an experiment, but they always say, oh, this will not work. So you need to get over that hump of these individuals who discourage you from doing work. But this is just a cartoon to show you that some of your research can just be incremental. Your concept could be watered down. But the idea here is to encourage youngsters to have the courage to be innovative and adapt it to your own system. Then finally, I just want to end with a couple of slides. I know that I'm standing between from lunch. Can anyone tell me, today is the 25th, what is the significance of January 23rd? If I add one more, the year, great. So we tend to forget the date, right, when we have the year. But that was the first day that Leonard Thompson received the injection of insulin. The first time it was unsuccessful because he was allergic to the insulin and they were worried. They went back. So the first injection he got was on the 19th of January. Nobody knows that. He was allergic to it and nothing happened, so it was still impure. So Banting and MacLeod went back and purified that insulin and re-injected that individual on the 23rd. And that's how he continued to live for a number of years. So that's a very important date for us. But I just wanted to mention that, it's been 100 years, right? No, it's 104 years actually. And we still don't have a cure for diabetes. So, this oration has been exciting, but I just wanted to emphasize to the youngsters in the field that we still have a major challenge for us. We have to cure this disease. And obviously my work will continue and all the work that you guys do as clinicians is important. But there's an important component of scientific research or translational research which is critical for us to cure diseases, not just treat them. I know that Wegovy and Mounjaro are fantastic to treat diseases, but we need to cure the disease, right? That's when you've accomplished something. Otherwise, many companies are making billions of dollars. But I just wanted to close with this, saying that we have a lot more work to do. It's been an honor to be part of the Debate Society, or the debate meeting. I hope to continue for several more years. It's been a pleasure to work with my colleagues and the organizers, and it's a thrill to be back in Bangalore. And it was great to meet Dr. Ran Narasimhan as well as all the pioneering work that you have done. So I want to stop there and thank the people in my own lab who have done all this work over the years, and all the mentors and trainees over the years, fellowships available if people are interested. So when you give these talks, the question always comes, what's next, right? Is he going to fade away? That's not on the cards. I'm not going to exit because I finished giving this oration. Some of these orations are given for a lifelong work, but I still think that I need to find a different way, and with RNA biology is something that we're working on. We also have additional interest in cognitive decline and using AI and biology and others. So I'm really excited for the next decade of what I want to do, but I'm always thankful for this opportunity, and thank the audience, and I hope that I've inspired or pushed some of the colleagues and junior faculty to consider translational research. Being a physician is important, but being a physician scientist is even more important. So thank you again for the organizers, and thank you.
Thank you, Dr. Rohit Kulkarni, for that fascinating lecture on your life journey. As this is an oration, the usual protocol, there are no questions entered. Let's end this fantastic conference with the national anthem.
Thank you, everybody. Thank you, Dr. Rohit. And thanks to all of them who attended the debate. We're open for lunch. Thank you very much.